dignitaries, distinguished faculty, delegates, colleagues, and my dear friends. It gives immense pleasure and great honor to welcome you all to the Karnataka Orthopedic Association Instructional Course Lecture, KOPPAL HIP-360 2025. As an organizing chairman, I feel privileged to host this academic feast where knowledge meets experience and science blends with innovations. This year, our instructional course has been carefully designed around some of the most challenging and evolving areas in the orthopedics: hip fractures, hip arthroplasty, and hip bone clippers. These topics not only represent most common clinical problems but also demands precision, expertise, and constant upgradation skill to ensure the best outcome for our patients. Hip fracture continues to remain the major health concern in the Indian populations, requiring us to refine our surgical techniques and post-operative protocols. Hip arthroplasty is one of the most successful surgery in the last century. It is evolving rapidly with newer implants, approaches, enhanced recovery pathways, and robotic arthroplastic surgeries. Similarly, the management of hip bone tumors represents the cutting edge of the technology, where timely diagnosis and advanced reconstruction techniques can restore both function and hope of the patient. Of course, over the course of this meeting, we will enrich by the wisdom of eminent national and international faculty who will share their expertise through the lectures, case discussions, live demonstration, and interactive sessions. I am very confident that every delegate here will return not only with updated knowledge but also with renewed enthusiasm to apply these learnings in their clinical practice. On behalf of the organizing committee, I extend my heartfelt gratitude to the Karnataka Orthopedic Association, our respected seniors, faculty, sponsors, and of course of all our delegates, without whom this program would not have been possible. I warmly welcome each one of you once again and look forward to an inspiring and fruitful academic journey together. Thank you.
Let's now begin the first session of the day. Instructions. Every speaker has 10 minutes, 8 minutes for presentation and 2 minutes for discussion. Kindly do follow the time constraints. Let's now invite Dr. Vijay Angadi sir from JIMS Gadag to speak about the topic Fracture Intratrochanteric Neck of Femur in Young Adults, Management Dilemma.
ಆಫ್ ಮಾಡ್ಬೇಕಾ ತಡಿಯೋ ಅವ್ರು ಹೇಳಿದ ಮೇಲೆ ನೋಡೋಣ ವಿಚಾರ ಮಾಡೋಣ ಇದನ್ನು ಸ್ವಲ್ಪ ಡೌನ್ ಮಾಡಿ ಸ್ಟ್ಯಾಂಡ್ ಕ್ಲಿಪ್ ಓಪನ್ ಮಾಡಿ ಅದು ಹಂಗಲ್ವ ತಡಿಯೋ ಲಾಕ್ ಮಾಡಿ ಓಪನ್ ಮಾಡಿರೋದು ಲಾಕ್ ಮಾಡಿ ಲೈಟ್ ಬಂದ್ ಮಾಡಿ ಆಫ್ ಅಣ್ಣ ಲೈಟ್ ಆಫ್ ಇದನ್ನು ತೆಗಿಯೋ ಏ ರಾಗ ಲೈಟ್ ಆಫ್ ಮಾಡೋ ಈಗ ಇದನ್ನು ಮಾಡಿದೆ ಬಂದ್ ಮಾಡಿ
It's an intracapsular fracture neck femur in young adults. The management.
Bro, lock mada.
So I would like to bring a greeting from the neighboring district, which is like we are neighbors. So we share all similarities between KOPPAL and Gadag. So greeting from Gadag. So fracture neck femur, the fixation till the age of 60-65 years, it's better to preserve the head. So it's better to fix the neck of fracture. Then after 60 you can
my talk, I would like to answer these questions. How urgent the femur neck fractures in young patients? Is there any difference in the outcome between the closed and open reductions? And what is the best implant for the femur neck fixation? And also the complications following the injury. Under these headings, I am going to cover this. Coming to introduction, the fracture neck femur in young patients typically result from a high energy trauma. So it's challenging to obtain a complete stability in surgical fixation and also to prevent the complications like avascular necrosis, non-union and implant related complications. The key goal is to preserve the normal hip joint functions. As all we know, the precarious blood supply of the femoral head and neck supplied by medial and lateral circumflex artery from the profunda deep femoral artery. Externally rotated, it won't be touching the couch lateral border of the foot and limb will be shorter. The imaging modality, the basic will take AP and hip lateral view. In the AP, it's better to compare the contralateral side. And traction will be taken in case of artery fractures. And this is the way you can distinguish it by taking the 50-degree internal rotation. You can see the whole leg. In case of upper fracture, it's better to take always in internal rotation, 50 degree of internal rotation. Clinically, in the X-ray, we can make out the normally you will have a center slide. In fracture neck femur, there will be a break in the center slide. CT will be taken in case of impacted fractures, and MRI is for the occurred fractures. The coming to treatment goals, the treatment goal is to here preserve the femoral head and to functional hip joint movements and to achieve the anatomical reduction and stable fixation. And meanwhile, the prevention of complications like avascular necrosis and non-union. So coming to first dilemma, which is the timing of surgery. So fracture neck femur is a surgical urgency, but it's not an emergency. So accuracy of reduction is more important than the timing of surgeries. So generally it's better to early surgery, which is mean time of goal is to do within 12 to 24 hours. The studies have shown timing is less controversial related to avascular necrosis. The initial displacement and reduction is more important than the timing of the surgery. The fixation methods, there are various fixation methods like the cannulated cancellous screws, then dynamic hip screw plate, then femoral leg system, and medial buttress plate with augmentation. These are the different modalities of treatment options in young patients. Coming to cannulated cancellous screws, it is indicated in stable fracture and minimally displaced Gardner's type 1 and type 2 and valgus impacted fractures, where the shearing forces are less and it can be done percutaneous. The advantage is it is a minimally invasive, hence less blood supply, less operating time and less chances of infection. And it is a more of bone preserving so that you can plan for the second surgeries. Then it is a familiar and inexpensive and configuration is flexible. Usually we will be fixing with inverted triangle and you can add one more screw, calcar screw for the better stability. Disadvantages, this implant doesn't have inferior angular rotation stability that for the vertical fractures and displaced fractures. So there the high rate of non-union and fixation failures are there. Then there is a varus collapse where there is a neck shortening and it may go for the varus collapse. The studies, coming to evidences, the studies have shown cannulated cancellous screw appears to be ideal screw fixation for the managing stable or minimally displaced intracapsular fracture. So still it is a first modality where in the stable fractures or completely reduced fracture we can think of cannulated cancellous screws. Coming to next modality of treatment, that is dynamic hip screw. The indications are Powell's type 2, type 3, where the vertical shearing forces are more, and basal cervical, where we want to achieve more of compression, and displaced fracture, if the anatomy of the reduction is obtained and health preservation is attempted. So in displaced fracture also, DHS is the option. Advantages: it is having a greater angular and shear resistance. Then, so it will allow the controlled collapse and compression, leading for the union of the fracture. And it can be easily augmented with anti-rotation screw and even also the bone graft. Disadvantages: as we know, this is a more invasive procedure, hence chances of blood loss, infections are more. Then the larger implant footprint. Once you take out the implant, there will be a larger footprint, so it is the chances for the subtrochanteric fracture. So implant related complications also more, cut out, varus collapse, and AVN also relatively high. These are the studies where dynamic hip screw versus cannulated cancellous screws been taken in type 2 and type 3 femoral neck fracture. It shows the vertically oriented Powell's type 2, type 3 femoral neck fracture. Still, DHS shows significantly lower risk of non-union compared to cannulated cancellous screws. Coming to third option, that is a femoral neck system. The indications for this is displaced unstable intracapsular fractures in 9 patients, including Powell's type 1 and type 3, and basic cervical fractures, where we need both axial and rotational stability. The advantage is combining both the sliding compression and anti-rotation plate. Also, it is a low profile plate, so it gives a improved axial and rotational stability compared to other implants, and often associated with it's a minimally surgery, shorter operating time, and you can bear the weight, you can allow the patient immediately. Disadvantages: device specific and lateral plate positioning, and occasional lateral side pain will be there, and theoretically there is stress riser for the subtrochanteric fracture, and still long-term complications like AVN failure has to be matured. And stent studies now report shows no consistent superiority for the femoral neck shortening and overall complications rate. So results are still heterogeneous. We need studies. These are the evidences where shows femoral neck system and cancellous screws have shorter operation time, less blood supply, and reduced hospital stay compared to DHS. These are studies where the comparison of neck femoral fracture treated with both FNS and multiple cancellous screws and dynamic hip screws. The study shows the DHS requires longer surgery, greater blood loss, and longer hospitalization. Then FNSC has a least fluoroscopic time. So FNS is significantly more expensive compared to cancellous screws. Coming to fourth modality, it is the medial buttress plate with augmentation with CC screws or DHS. It's indicated in type 2 and type 3 Powell's, where the vertical and high shearing forces will be there, and where the medial calcar combination, and we need a medial support. Right? Salvage or delayed presentation of the fracture neck femur in 9 patients. Advantages: it restores the medial calcar support and markedly resistance to the varus collapse. So it can be combined with either with the CC screw or DHS or FNS. Medial buttress plate is augmented construct, can have a faster healing, better functions, and fewer complications in unstable fractures. The disadvantage is more invasive, as we have to go through one more approach, and technically sensitive placement, and potential for plate related irritation and need of implant removal, and does not rely on the prevention of AVN as a vascular injury and is suspected. The studies have shown where femoral neck buttress plating with 3.5 medial plate improves the outcome by reducing fixation failure and non-union and avascular necrosis and reoperation time. The best results occurs when you put the plate on the medial side or anteromedial, not the anterior side. Coming to one more dilemma, whether we go for an open reduction or closed reduction. Still here, the anatomical reduction and stable internal fixation gives the patient best opportunity to avoid the complications like varus or posterior plate. The studies have shown whether it is an open reduction or closed reduction, the results are same. AVN results are more in case of poor reduction. The recent data favor the closed reduction, where the open reduction having a greater risk of reoperation and with improvement in the reduction quality, but they have a reoperation is more. The surgical approach comparing, there are two separate surgical approach, anterior and anterolateral. Both have its own disadvantages and advantages. Anterior Smith-Peterson is an excellent visualization of the femur neck. Then it's easier. You can put the medial buttress plate easily, and it needs a lateral separate incision for the anything like DHS or CC screw fixation. Whereas anterolateral Watson-Jones, it's a limited exposure, so you can't visualize subcapital fractures, and it's difficult to place the medial superior buttress plate. So these are the approaches. Coming to mean one reduction technique. The reduction techniques usually we use a pointed reduction clamp and jaw sticking with KOFs or sand pins. Provisionally fixed with the wire fixation. Then finally you can try for the medial buttress plating. Coming to complications, the complications avascular necrosis. The avascular necrosis studies have shown the avascular necrosis is more in case of early displaced fracture compared to non-displaced. The timing of surgery is not significantly correlated with AVN risk. And newer implants like FNS can reduce the avascular necrosis. Then non-union. Non-union complications after intercapsular hip fractures, the non-union rates are more in case of around 9%. That's also more in case of
Dr. Vijay, can you complete your talk at the earliest because you have crossed your
yes, sir, yes,
a lot.
Since I am beginning, I have covered all of this. Yes, I will finish.
This is again to all the speakers. If you want to become a good speaker in future, try to restrict your time. How to do it, we can have one more class for that. But you should not read the whole thing. Because that's very important restriction of the time. All awards in any conferences will be given only by limiting the time. So you should know how to use it. Okay?
Non-union rates are more in displaced fracture and valgus symptomatica. Osteotomy is effective. And effect of fracture reduction policy also very important. The poor reduction quality strongly correlated with AVN and non-union. As I told, timing of surgery is not related, better to do within 12 to 24 hours. Fixation methods, the larger implants have higher AVN risk than the smaller implants like cancellous screws. And reoperations around 18-20% requires reoperations because of AVN non-union. That's due to complications. That's due to early displacement. These are the studies where they show the AVN and complications, other complications. To summarize my talk, the anatomical reduction is critically. Ideally fix the fracture within 24 hours. Then open or closed reduction is not significant. Prefer cancellous screws in case of stable fractures, and where it is a DHS also in type 3 fractures. And it's all counsel the patient for the early regarding the significant risk of complications and reoperations. Thank you.
How do you go for middle approach?
Smith-Peterson approach, sir. We have to go through the anterior approach, Smith-Peterson, where we have to fix the butter plate, then come back to lateral approach and fix with CC screw or FNS.
Is there any role for muscle critical graph nowadays?
Okay.
Yes, sir. That's done in delayed presentation non-linear. Next, delayed presentation non-linear, not as an initial session.
Posterior combination.
Yes, sir. Posterior combination and medial character. Thank you.
Thank you for presenting that. Our next speaker is Dr. Rahul. Okay. Sorry. Our next speaker is Dr. Nandi. Okay.
Thank you, sir, for sharing your expertise on this complex dilemma. Please welcome Dr. Santosh Nandi from BLTEA Bijapur to present on diaphyseal fitting modular bipolar hemiarthroplasty in comminuted fractures.
ಅಮ್ಮ ಅವ್ರೇನೋ ಮಾತಾಡ್ತಾರೆ ನಂತರ. ಯಾವ ಡಾಕ್ಟರ್ ಇಂಟ್ರೊಡಕ್ಷನ್ ಬೇಕಲ್ಲ, ಈಗ ಹೇಳಿದ್ರೆ ಅವ್ರು ಬೇಡ ಅಂತಂದು ಅದೇ ನಮಗೇನು
Greetings from BLE University, Dr. Nandi, HOD, Professor, Department of Orthopedics. So my today's given topic is diaphyseal fitting modular bipolar hemiarthroplasty in comminuted intertrochanteric fracture in elderly individuals. So nowadays, I think all of us have come across these osteoporotic fractures. So many times we end up in a compromised fixation or our fixation are failure due to severely comminuted fractures as well as osteoporotic bones. So long stem hemiarthroplasty is often considered better than internal fixation or dynamic hip screw or proximal femoral nail for comminuted intertrochanteric fracture in certain patient population, especially due to elderly individual, those are having osteoporotic bones. So poor bone quality makes fixation unreliable. So seeing in this picture, osteoporotic bone, the fixation has been done and it has been paid. There is a cutout of screw. So by having a modular diaphyseal fitting, there are problems with fixation where early mobilization is delayed, weight bearing is delayed. So hemiarthroplasty allows immediate full weight bearing. Then with the fixation, we have again secondary surgeries, patient may need secondary surgery. So better pain relief and function of the patient. Technical consideration with long stem. The long stem prosthesis help to bypass the unstable proximal femur and anchors in the diaphyseal bone. So this Evans classification we can see in this usually is do it in group 4 severely committed unstable fractures. So key differences between diaphyseal and metaphyseal bipolar stems. So diaphyseal fitting stem has long stem which starts from 190 mm to 305 mm, whereas metaphyseal fitting, that is bipolar, routine bipolar, which has got a short stem, it starts from 130 to 145 mm. So usually poor diaphyseal fitting stem where there is poor metaphyseal bone, whereas in metaphyseal fitting we require an intact metaphyseal bone. Primary stability is achieved in the cortical diaphysis, whereas in metaphyseal we have achieved proximally in the metaphyseal cancellous bone. So surgical complexity, the more technical demanding in diaphyseal fitting fracture and not less technical demanding in metaphyseal, that is in bipolar or any other osteomotor process. Stress transfer. The stress transfer distally can lead to stress shielding proximally, whereas in metaphyseal, stress transfer more naturally through the metaphysis. The indications are comminuted IT or suffragant fractures, whereas in metaphyseal fitting we can use only in displaced intracapsular neck fractures. The risk of prosthetic IC fracture is higher if not well removed or well sized. In metaphyseal, lower, especially with the proper technique. So there are some supporting articles where we can see that bipolar arthroplasty for unstable introductory fractures is effective with additional widening techniques, which showed her better results and early mobilization of the patients. These are the other supporting articles which states that bipolar hemiarthroplasty, particularly long stem, is very in elderly patient is safe and practical options for unstable intratrochanteric fractures, offering early mobilization, fewer bed rest, complications, and better quality of life. And these are the some more where in osteoporotic fractures they have been used long stem. The outcome is they have got a very good outcome. So, going to the principles of diaphyseal fitting fractures, the stem selection and insertion is important in this case. Rigid fixation. The chosen femoral stem should be long enough to achieve stable fixation in distal femoral diaphysis. Next is a modular design. The modular stem allows alignment, adjustment in length and offset, which is beneficial for fracture reduction and limb alignment. And proper rotation is required so that there is anteversion is maintained. 5 to 15 degrees of anteversion is required for this patient. And then with the trial reduction, you can achieve the proper length and the offset can be managed. Then special thing we have to look into in these cases is reaming and sizing of the implant. The reaming of the proximal fragment is that our reamer should start at the entry point and it should be, the handle should be a little bit posteriorly and it should direct towards medial side. If we direct the handle anteriorly, it may, there is a chance of fracturing the anterior cortex due to bowing of the femur. Then this is the diagram which shows it should go into the center. The hand should be little bit posterior, anteriorly, so that it enters into the canal. The engagement of the stem. So once the stem is introduced, there is slight expansion of the stem so that it gets fit into the shunt. Then reduction. Sometimes we have a small fragment like LT is fractured. So this has to be reduced with a K1 so that it should have a stable construct. So sometimes we have some other problems like additional we can add the adjoint fixations with plate cable wires so that it can be stable fixation. Then sometimes we can use a bone graft as well as neck length has to be maintained. The components of the long stem bipolar are the bipolar head, humeral head, that proximal body, fluted stem. The stem, it looks like this. It has got 8 flutes around it. So it has got a fluted stem and a tapered design. From proximal to distal, you compare it. It is proximally the diameter is more and it gets reduced. How it comes distally, and distal tip and longitudinal ribs. It has got longitudinal ribs where it gives a good rotational stability for the implant. So here is the one case preoperative. A severely comminuted intertrochanteric fracture, 85-year-old lady, which was planned for a long stem hemibipolar bipolar prosthesis. So patient was positioned in the lateral position, knee flexed to relax the posterior structures, and the lateral incision was taken centered over the greater trochanter. And the fracture site was exposed. This part, the arrow which is showing is the greater tuberosity. We entered through the greater tuberosity. We retracted the greater tuberosity along with the attachments. So we went in between the fracture site and head was extracted. So extracting the head in the trochanteric fracture is a little bit difficult task because we have an attachment around the trochanteric region. So it has to be meticulously done, and the excised head is measured. So as I was telling you, the reaming part, it has to be directed posteriorly and medially so that you will not breach the anterior cortex. So this is the stem prosthesis, humeral prosthesis which are introduced. So after introducing the implant, then we are doing a tension band wiring around the greater trochanter. So post-operative X-ray was obtained, AP and lateral views. Hemogram post-operative protocol was followed, and the dressings were changed after 2 days, and full weight bearing was allowed on first post-operative day of this patient. Suture removal, everything was done according to our protocols, and this was the checked X-ray of that patient. And this is the patient. Patient is immediately mobilized after first post-op day. So this is the second case, severely comminuted osteoporotic bipolar done. Okay, this is a 95 years old male. Okay, this is the third case, which was old case, almost 1.5 to 2 months. So this was done. This part reduction was difficult to achieve intra-op because due to old fracture we were not able to reduce it. But the patient is doing fine, is moving. This was the fourth case with LT along with the fragment. So these are the cases. So one more other thing, for failed DHS also we have done 2 to 3 cases. In this, only thing is we have to have a longest stem which is available so that we can bypass the stress areas. So to prevent the fracture, this is the longest stem which was available. So this is another case, failed case. So take home message is long stem diaphyseal bipolar hemiarthroplasty have improved the stability and early post-op mobilization, especially in cases of unstable comminuted intertrochanteric fractures. Thank you. At the outset, I would like to thank all the organizers for giving me an opportunity to share my experiences, and thank you to the organizers. And I welcome you all for the 50th KOPPAL conference, that is Golden Jubilee at GHQ, that is on 31st January. So, with the permission of Secretary and just a few eminent speakers, I am displaying them prior to your permission. We have Chaitanya Mudgal from USA, Ashish Prabhutkar, Girish Datar, Milind Chaudhary, Naveen Thakkar, Amit Putti, Ramesh Sen, Ratnakar Rao, Shiv Shankar, Samir Sheikh, and Sampath Dungre Patil, and Dr. Ashish Prabhutkar has given his consent to attend the events. Thank you.
This stem and the femoral curve, bone curve, they usually long stem, typically. There will be stress risers, and in the long run they experience middle pain. Did you experience anything?
Still now we have not come across, almost we have done 20 to 25 cases. But long stem only we are using in the failed, the maximum stem we are using only in the failed cases.
Any questions? We will go to the next topic.
Thank you, sir, for an insightful discussion. Our next speaker is Dr. Harish Murthy from RIMS Raichur, who will speak about unstable or reverse oblique trochanteric fractures and also share a few tips and tricks.
Good morning, everybody. At the outset, I congratulate KOPPAL Orthopedic Society for having conducted a very nice Karnataka Orthopedic Association ICL. The KOPPAL Orthopedic Society being the youngest district chapters of Karnataka Orthopedic Association, and this chapter is conducting the ICL. It is definitely a very nice event, and once again congratulate the organizers of the KOA ICL 2025 for having conducted this in a very nice manner.
There is some technical issue that get resolved. KOPPAL Orthopedic Society was supposed to host this ICL last year itself. This opportunity was given to KOPPAL Orthopedic Society the last year only, and they had almost accepted the invitation and they were supposed to conduct the ICL, but because of some other technical problems and other issues, the KOPPAL Orthopedic Society was not registered yet last year, and that was the reason why it was not possible to conduct the ICL. But I am very happy and delighted that at least this year they could conduct the ICL.
Adiós.
not for uncontrolled collapse. In such cases, either you have to use DHS with trochanteric stabilization plate or cephalomedullary relays like PFN or 95 degrees DCS or the locking plates. The classification of the intertrochanteric fractures, I will not go into detail, but these are all the unstable intertrochanteric fractures. So this portion, these are all the unstable intertrochanteric fractures of the AO type. So there is one more classification by G.S. Kulkarni which he has shown. So again, these are the unstable varieties of the intertrochanteric fractures which we are all interested because these fractures tends to fail. The another classification which is not very popular is the CT based classification, which is also called as the Nakona classification, and which has divided the intertrochanteric fractures into 3 parts: greater trochanter, lesser trochanter, 3-part greater trochanter, 3-part lesser trochanter, and 4-part fractures. So this is the Nakona classification, which is a Japanese classification that will tell us. So coming to the length of the PFN, you have to be very careful whenever there is a reverse oblique fracture. So you have to use a long PFN. If you use a short PFN, then it tends to fail. So always use long PFN in reverse oblique fractures. So these are the various implants that has to be used in intertrochanteric fractures. The next most important thing, important in the successful outcome of intertrochanteric fractures is reduction. So if you put in a nail like this without an unreduced fracture, definitely it will fail. So above fixation will again fail. It needed a revision surgery. So only long PFN will not do wonders. Reduction has to be appropriate. Only then the long PFN will work. So your all efforts are needed, either closed or open, to get a good reduction. Only then the intertrochanteric fractures will do good. So intertrochanteric fractures, reduction focuses on normal alignment of the fractured bones, either through closed or open techniques, aiming for anatomical reduction and stability, particularly emphasizing restoring the anterior medial cortical contact. The treatment often involves closed reduction and attraction, possibly with assistance with percutaneous mini-open techniques to improve the fracture position before internal fixation with an intramedullary nail. Never put in a nail before the fracture is reduced. Only you reduce the fracture first and then put the nail. That is the most important key goal in prevention of complications. What are the various tips for reduction? You see many cases where you can see the fracture is flexed in like this. In the lateral view, you can see many cases the fracture is flexed. There are various methods by reduce this flex fracture. One is a common use of a Homan. So we try to pass one Homan and push the proximal or the flexed fragment down and then get the fracture reduced and then fix the fracture. What the Lambert's principle was given in 20th century, that is the exposure reduction is very critical to the stability and functional recovery, and inadequate reduction is the major preventable etiology for lost reductions and construction failures in intertrochanteric fractures. So there are various provisional fixation in anatomically reduced position can be done either by K wires, spikes or SS wires, and then the definitive fixation can be done. So this is use of K wire. So this is a fracture. You know that intertrochanteric fractures reduce in abduction, but for us to nail, we have to adduct the fracture. So for that, we can temporarily reduce the fracture in abduction, fix it with K wire, adduct the fracture, and then nail. The entry point has to be very good. The entry point should be somewhere exactly at this point. Then only the locking will go perfectly. Another common problem what we all have seen in trochanteric fractures are like this. If this is the fracture and this ideal entry point what is given is the tip of the trochanter. And when you go through the tip of the trochanter, the common problem what we encounter is that it usually ruptures here. And when it ruptures here, when you pass the reamer and when you pass the nail, this fragment goes into varus. So whenever you pass like this, it ruptures here, then you pass your reamer. So when you pass your reamer, what happens? This goes into the varus and our nail will come at the fracture site, and this is the common problem we all would have encountered many number of times. So how to overcome this problem or how to overcome this wedge effect? So the most important thing in wedge effect is this is another similar case. So here what we have done, if you enter from the tip of the trochanter, this portion will get ruptured or broken, and the same thing, there will be a varus thing. The next most important tip is enter more medially. Be it subtrochanteric fractures or intertrochanteric fractures, though the literature says go through the tip of the trochanter, my suggestion is go more medially. The more medially you go, the chances of varus collapse is less. So go more medially. So the prevention is, rather than going from the tip of the trochanter, go more medially. You can prevent the wedge effect in intertrochanteric fractures. One more common problem what we see is irreducible variant. So sometimes the lesser trochanter, the iliopsoas is attached to the lesser trochanter and it prevents the reduction, and you can see fracture like this with a very prominent lesser trochanter jetting out, and if you fix either with DHS or PFN, you will get this type of reduction and the patient will not be happy. So these are some of the fractures where either open reduction is required, or sometimes you can get away with reducing in external rotation, releasing the iliopsoas and then internally rotating it and fixing it. So this is one nice paper by Said was given how to reduce the intertrochanteric fractures. This is one fracture which I encountered in my clinical practice. Can anybody tell what is the problem in this fracture? What will be the problem in this fracture? The lesser trochanter is inside the medullary canal. I don't know if you can see. The lesser trochanter is sitting inside the medullary canal. So this is one special type of irreducible variant which I have seen in my clinical practice, and it was very difficult for me to get that fragment out from the. So you can see the lesser trochanter is sitting inside the medullary canal, and this was a very difficult fracture. I tried all the possible means. I tried pulling with a hook, then pushing with one. This was the ultimate thing. I could somehow succeed in dislodging this by giving traction, pushing that fragment, and then I could fix the fracture. So these are some of the problems which we encountered in comminuted intertrochanteric fractures. So augmentation, I think, is the most important thing in intertrochanteric fractures to get good results. The augmentation can be done with trochanteric extra screw, tension band looped around the tip of the trochanter, circular wires whenever there is a subtrochanteric fracture, or a trochanteric augmentation plate. And we did a thesis in our college, and tension band wiring in comminuted intertrochanteric fracture. So these were some of the cases. You can see the proximal fragment was flexed, and we used the Whippo wire passer very frequently and try to reduce the fracture fragments. And this is the pre-op and this is the post-op. So the augmentation, trochanteric side plate. So these are the. I would like to give show some of the cases where I have operated with tension band wiring. So this is again you can see the X-ray looks very innocuous, but when you see the CT, you can see how difficult it is, and you can see the flexed proximal fragment. Either you can push it with a Bowman, or you can use a SS wire or circumferential wire or the tension band wiring. So that will reduce this flexed fragment, and that will help us to fix in the reduced position. So this was the reduction and how the fracture. Again, another case, very comminuted intertrochanteric fracture. We have after the tension band wiring, so we pass it with Whippo wire passer, one loop above, one loop below, and then pass it in the tension of figure of 8, and these are some of the results. I don't know whether the video will work. I am very sorry, this video is not working. So, but she is walking very comfortably, and so this is another case. This is the Nakona 4 part. We can see lesser trochanter, greater trochanter, and this is the Nakona 4 part fracture, where we have again passed the same tension band wiring, and we have got a reasonably good results. And this is the post-op CT after the tension band wiring reconstruction. It gives a reasonably stable construct, and this is the amount of functional recovery we get after the tension band wiring in unstable 4-part Nakona fractures. And the video again is not working. The patient is walking. This was a very, very unstable, though the X-ray looks very innocuous. If you see the CT, so you can see the greater trochanter, the lesser trochanter, and this much of comminution. The CT, how bad the X-ray is, and you see how much wide gap it is there. Somehow we could get this type of reduction, and this was the results what we could achieve in this case of, and the patient is climbing down the stairs and the patient is walking. Unfortunately, this video is not working here. So the reverse Z effect. So this was described by Verma and Crispo. The reasons is still not clear. Probably the fracture fixation in varus, severe medial comminution, inappropriate entry, or poor bone quality are reasons of the Z effect and reverse Z effect. To conclude, the good results with anterior medial contact is the most important factor to get good results in intertrochanteric fracture. Concentrate on good reduction before putting in the nail. Try all closed means to get good reduction, and if not possible, don't hesitate to open either minimal or open to get good reduction. In reverse oblique fractures, PFN is the implant of choice. Long PFN is the implant of choice. Augmentation will give good results in unstable intertrochanteric fractures. Thank you.
ಲೈಟ್ ಹಾಕೋಣ ಸ್ವಲ್ಪ
Sir.
Did you try with the lateral braces in case of comminuted trochanter? There is no lateral wall.
I have tried the lateral trochanteric plate. Unfortunately, in my hands the results were not so good. So that is the reason I have stopped doing the trochanteric buttress plate or the trochanteric side plate, and I have continued with the tension point by the reconstruction. I have done few cases of trochanteric buttress plate. I have done with the PFN, and somehow the results were not good. So that is the reason I have stopped using it, sir.
Sir, define lateral wall anatomically, sir.
Sir, 3 to 4 centimeters from the trochanteric ridge is the lateral wall. Now, when it comes to the lateral wall, there is lot of debate whether to completely reconstruct the lateral wall or not. There are two schools of thought. One school of thought definitely says that the lateral wall has to be reconstructed in a comminuted intertrochanteric fracture. But there is another school that says that if you get a good reduction with anterior medial contact, you can get away without managing anything for the lateral wall. In fact, that Jetwa has shown that only with the 10 snails he could get away with anterior medial reduction. So if you see G.S. Kulkarni and his followers, they say the lateral wall has to be reconstructed whenever there is an unstable intertrochanteric fracture. Whereas Akashi and his team, they say that lateral wall need not be addressed and you can get away only with anterior medial reduction.
Sir, failure of the DHS could be due to the sliding mechanism failure also.
So I have told you that DHS will fail in unstable intertrochanteric fractures because whenever the lateral wall is fractured, the whole of the proximal fragment will completely collapse. So DHS is designed only for controlled collapse, and the lateral wall will prevent that complete collapse. So the lateral wall has to be intact if you are doing a DHS. So if lateral wall is collapsed, DHS is not the implant of choice. You have to use PFN. In PFN, what happens? The nail itself prevents the collapse. So nail will prevent the structure that is acting as a lateral wall. So the nail will now act as a lateral wall and give the support and buttress and prevents the uncontrolled collapse in reverse oblique fractures.
DHS should not use in reverse oblique fracture.
In reverse oblique fractures, DHS is absolute contraindication. DHS is absolute contraindication.
Whenever you are dealing with comminuted intertrochanteric fracture, when you go in, do you go in with the plan of putting a nail, doing DPW for all cases? My question. And second is, when you decide to do a DPW along with the nail, do you do it DPW in the same supine position after nailing, or you again put it in the lateral position and put a DPW?
No. See, I have already shown you what are all those fracture patterns that are unstable intertrochanteric fractures. So If the fracture is going into the head, if the fracture is going into the subtrochanteric region, if there is four-part fracture, if there is vertical shear, so these are all the unstable variants, reverse oblique patterns. So these are all the unstable patterns. I do both. Even I have done few cases where I have done primary hemi replacement arthroplasty. So what are those cases where I try to do primary hemi replacement arthroplasty? What are those cases where I try to do TBW? And what are those cases I do only PFM? Usually, whenever I operate, I always keep a Mimpo wire passer and SS wire kit ready for tension band wiring if I am doing a PFM. So that will be there autoclave. Only and all my tension band wirings with PFM I am doing in the supine position with fracture table. I am not used to doing PFM in lateral position. Dr. Ashwini, he is very well versed in doing intertrochanteric fractures in the lateral position. Unfortunately, that slide is missing. I have just put in what are all those fractures that are the unstable variants. But invariably, during any PFM, our set will be ready, because only after putting the traction and internal rotation, we will get to know how good or bad you get the reduction. And otherwise you will have to take a traction view preoperatively or do CT. Nowadays, at least in Raichur Institute of Medical Sciences, in my unit, I have made it compulsory to get CT in all intertrochanteric fractures, unless it is a stable fracture. But all unstable intertrochanteric fractures, I have made it compulsory to get CT, and CT will tell us whether to keep tension band wiring, and I try to classify with the Lacuna and then see whether SS wire, or I have used only circumferential wires in subtrochanteric variants and tension band wiring in unstable variants of IT. Yes, sir.
Because of proximal reamer, it's a 14 mm diameter. If you do with the proximal reamer,
yes,
then there are high chance of neck combination and vascularity damage to the head. How do you avoid that?
See, the invariable thing what happens is that whenever you pass a reamer, the reamer will tend to go to the less strong area. In the trochanteric region, the less strong area is the lateral part. So that is invariably what happens is that the reamer tends to go more laterally. The reamer will not go medially. So you try to enter, you see practically, you try to go in more medially. Sometimes that happens is that if you enlarge, the reamer tends to come laterally, it will not go medially. And I have hardly ever seen any avian post IT. So our vascularity problems will not be there, but invariably what we see is the wedge effect, wherein our nail tends to go within the fracture site. Whatever you compress, the nail will prevent the complete compression, and you will get the fracture may compress, but it will end up in varus. So that is the reason only tip to get a good reduction is medial entry. More medial entry than what is recommended for the PFL. So be it subtrochanteric fractures, be it intertrochanteric fractures, a medial entry definitely is the key for success.
And how about using PFN A2 in all these fractures?
See, I have a PFN A2 set. I started using it, but somehow I discontinued it. There are various reasons why I discontinued PFN A2 set, because I thought that the amount of compression we achieve with regular standard PFN, I think it is more than the PFN A2. So I thought we can achieve more compression with the PFN. So that is the reason why I stopped using PFN A2. And the only thing is that that is one reason. The second thing is that it is costly to the patient. So I felt that the advantages of PFN is more than the PFN A2. So I stopped using PFN A2 and continued to use regular PFN.
So I have stopped using PFNs. I have been using PFN A2 from last 5 years.
So that is your personal thing.
I want to compress, we get very good compress with PFN A2, and even with the lateral wall combination, we get very good results in PFN A2.
The PFN or the cephalomedullary nails, long cephalomedullary nails, be it PFN or PFN A2 is the treatment of choice in reverse or unstable intertrochanteric fractures.
I think we can further discuss later on.
Okay,
Okay, and you please see that how many PF they need to failure you have seen. Okay, carry on.
Thanks.
Next speaker, please.
Thank you, sir, for the thoughtful discussion. Now I invite Dr. Veerabhadra Javadi from KIMS Kalpa to share insights on subtrochanteric fractures, always a challenge.
ತೆಗಿತೀಯ ಅವ್ರನ್ನ ಸ್ವಲ್ಪ ಹೇಳಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಚಲೋ ಆಗಲಿ.
Okay, good morning all once again. Greetings from Karwar. Rather, I should say it's a shower of raining greetings because it has been raining like hell in Karwar from past 1 month. And before I start my talk, I would like to request audience to have more patience listening because many of my slides seem a repetition of whatever Harish Murthy sir has just explained elaborately. So, having said that, subtrochanteric femoral fractures always a challenge. The objectives of my this will be define unique anatomical considerations of subtrochanteric femoral fractures, describe the important considerations of positioning, reduction techniques, and implant choices, and a little thing about atypical subtrochanteric fractures. So, you know, subtrochanteric fractures, you have a bimodal distribution. Young patients usually result of high energy, road traffic accidents, and geriatric patients usually low energy, prevail from our patients. And beware of atypical subtrochanteric femoral fractures in these patients. So, bimodal, again, young patients follow ATLS protocols associated with has to be first, which are life saving, then temporary stabilization, and plan accordingly for fixation. Old patients, beware again. Look for atypical subtrochanteric fractures, any protocol pain on the thigh, history of other fragility fractures, medications, especially long-term medications, bisphosphonates for osteoporosis, and quadrilateral fracture suspicion must be there, and endocrine evaluation as necessary. So, subtrochanteric region is that part of the region which is spans 5 centimeters just below your trochanter, and it doesn't usually stay there. It extends approximately and distally usually. So, why it's important to have bony considerations and also soft tissue considerations? Because subtrochanteric region is the region of maximal compressive forces and tensile forces, and it is the single long bone in the body that has the largest asymmetric difference in the load. And so, what does it implicate? What is the clinical implication of that? Because bone yields under compression, but lateral cortex is always under tension. So, we need to get the reduction of the lateral cortex, no varus absolutely. And fixation must allow compression of our lateral cortex. So, because the fracture isolates your short proximal fragment, our room for error becomes very, very, very small. Warm welcome to our President, sir. Hello, sir. So, continuing my talk. There is a vast soft tissue, there are very much forces acting upon both proximal and distal fragments. You know, proximal fragment is being flexed, abducted and externally rotated, and distal fragment is being erected and medialized. So, our clinical application is we have to must overcome all these forces to obtain the reduction. So, there are innumerable number of classifications ranging from old Taylor to Senchema, but our main concern should be whether there is a medial support is there or not, and whether our fracture is extended to the trochanteric region or not. So, how to prepare for face the challenge now? What are the regions? So, be ready right from the position of the patient to reduction of the fracture and also choosing the wise implant for the fracture that is necessary to be fixed. So my implant choice would be either extramedullary or intramedullary. Extramedullary range from DCS, fixed angle grade plates, PFLCP, intramedullary basically cephalomedullary lens. And most of the times it's the nail overtakes the plates. The only reason is the biomechanical advantage the nail has got because of its short liver arm, and it has a favorable loading pattern, and whenever there is a medial cortical defect and lateral wall failure, always it is the nail which gives you more advantage in defending the forces across the fracture. And moving on, again the nail has a greater load to failure, greater number of cycles needs to get fail, and higher force it needs to the nail to fail. So moving on to just a little bit of more important key points in positioning and also in reduction. Positioning, there are many surgeons prefer either supine traction cable or lateral position. So the advantage of being in supine is ability to hold reduction without need for assistant, and supine position for polytrauma patient management will be more helpful. Disadvantage, again, you can have traction table in complications, more challenge for access for open reduction, and difficulty especially in obese and muscular patients, and sometimes your traction can actually accentuate rather than helping you in reduction. Lateral position with free leg advantage again overcomes abduction of the proximal fragment, ability to move distal fragment in sagittal plane to match flexion of your proximal fragment, and especially it has got improved access for your entry point in obese patients. Disadvantage, probably more of it, imaging of proximal femur can be unfamiliar or difficult. So once you get the position, the next foremost thing that you have to look is only the reduction of the subsequent fractures. The current evidence says that the quality of reduction alone is the chief parameter deciding the outcomes of subtrochanteric fractures. And why this? Because you know various deforming forces that always occurs on this proximal and distal fragment. And I said you always traction always won't give you reduction, it will in fact reduce accentuates. And nail cannot be used as a single reduction tool or any type of tool for your reduction. So there are many tools available for your reduction for your proximal trochanter. So basically ranging from simple bone hook, sand spin, your retractors, bone assisted reduction clamps, collinear clamps, or sometimes even femoral distractors and reduction fixators. These are simple depiction of how these tools will help us in reducing the fractures. A F device basically more in low subtrochanteric fractures. Sand screws used as joysticks. Point reduction forceps, RTR, Hodger's clamps. That will be again. These are the various tools. Whichever is helpful for you, whichever you are more familiar with, that you can use this one. This is much more like a push and pull technique using false spikes and bone hook. And sometimes polar blocking screws are also very helpful. When there is medial and lateral translations, you can just place your nail as central as possible. And the other tools that are helpful are your reduction clamps and collinear clamps. And one more very important is surplus, where especially when there is medial compression or medial large bone fragment, you have to go for your surplus. Once you've done the reduction, we rush through the process so that we finish the put a guide and finish the nailing. No, there is some mindness there. Again, you have to choose your entry point very, very wisely. Any urgency or any problem in choosing your entry point, all of the process will be spoiled. So your entry point should be just medial to the tip of the great trochanter and central in the lateral aspect. So just other depiction, if your entry point is changed, this is the problem. Whenever you take a great entry point, always the fracture will go into the varus. So nailing metal nail technique is optimally paired with closed functional reduction to maximally preserve the fracture biology, but subtrochanteric fracture is not tolerant to malreduction, particularly varus infection. Thus, have a very low threshold to perform open reduction to ensure no varus is there. So, well-aligned fracture via open reduction is always preferable to the percutaneous malreduction. So, once you do the entry point, again there is one more speed breaker there to look for. That is, always there is a natural tendency of starting to go from lateral proximal to distal medial. There you should be very careful, and you have to be exactly parallel to the lateral cortex. That is the one tip that you can follow while removing the proximal fragment.
So is there now, once you finish the nailing, is there any role of the plates now? Okay, when a nail might not work, but many surgeons may not accept this because many of the fractures they do in nailing itself. So combination of the nailing starting point, especially tip of the graded trochanter or piriform fossa. So solution is definitely a 90 degree angle plate or even a proximal femoral locking plate. So the other scenario where nail might not work would be already a fixed mal reduced in varus or flexion with poor starting point and prior nail in place can be next to impossible to correct with nail alone. So you can note that there is a very lateral starting point and nail path is also very lateral, and correcting varus with another nail in this short proximal fracture is very difficult. In such scenarios, this angle plate may be a very good option. You can bone graft that towards starting point and correct varus and fix with the plate. There a little about atypical femoral fractures. These are low energy femoral fractures. So pathogenesis mainly due to stress fracture occurring in the abdominal underlying bone. These are usually due to remodeling suppression. So American Society for Bone and Mineral Research have defined fracture must be located along the femoral diaphysis from just distal to the lesser trochanter to just proximal to the supracondylar flare. In addition, at least 4 or 5 major fractures or features must be present. None of the minor features may not be. What are those 5 features? The fracture is associated with minimal or no trauma. The fracture line originates at the lateral cortex and is transverse. Medial spike, no or minimal comminution, and localized periosteal or endosteal thickening of the lateral cortex is present with the fracture. So some minor features are increased cortical thickness of the diaphysis, prodromal symptoms of your thigh pain, bilateral incomplete or complete femoral fractures, and delayed fracture injury. So beware that of especially this atypical femoral fractures. The nature of the atypical femoral leads to lower healing rate and there is abnormal lateral cortex. Atypical femoral fractures are very much intolerant to varus. Even as little as 5 degrees, there is a failure of thigh cracks. So anticipate for prolonged healing time, and medical treatment would include stop bisphosphonates, calcium and vitamin D supplementation. Consider anabolic agents. At last, to summarize, the key factors to face the challenge is mainly the anatomical reduction. Whether it will be either it is open, closed, mini, invasive, doesn't matter. You have to get anatomical reduction, and you have to get a next crux is you are getting an ideal entry point. And at last, don't lose the reduction while nailing and fixing the reduction. Thank you for your patient listening. Once again, thank you.
Come back.
Yes, sir. That's once we get reduction, we will be little bit aware to push a guide wire and finish off the job. The crux lies is mainly the 90% of the job will be fine if you take a good entry point. Once your entry point is wrong, usually it will be more lateral, then everything gets spoiled. That is the main cause for the reduction. And even after getting the reduction, the main thing, the other important thing is how do you make the proximal fragment. So as I already mentioned in one of the slides that whenever you take guide wire, it usually tends to sway from lateral to medial. So the path becomes more medial as you go there. So the crux is again you have to be as parallel to possible to the lateral cortex with the proximal fragment. And especially in the AFX, there are lateral beakings. You have to make that all the lateral beakings before you put a nail.
Bilateral supracondylar fracture.
Yes, sir.
How do you deal with the supracondylar? Bilateral.
Bilateral, again bilaterals are most, in the old age you should have a suspicion for AFib, sir. It's a AFib fractures. Again all the principles remain same, especially in the AFib fractures we tend to get that beaking, sir, lateral beaking. That is the only one thing you need to look upon while you are to rest all principles remain same, sir. only thing is you should anticipate more healing time in subtrochanteric fractures. Especially
and pathological fractures.
Yes, sir. Same principles goes with the same things. Thank you.
When do you start periparatite in subtrachanteric fractures? What are your indications for that?
I should admit, sir, I have not used that. I really don't know what is the solution. I think Ashmur sir can throw some light for that.
For atypical subtrochanteric fractures, invariably I start them on periparatite. If you see all those major and minor criteria which was given by the Shane Vaughan Elizabeth criteria of the American Society of Biomedical Mineral Research, they have given very nice guidelines. The 5 major criteria and 6 minor criteria, and in that article also they have shown that using periparatite is the choice for all atypical subtrochanteric fractures. In fact, even for other fractures also nowadays I am using periparatite very frequently. Yeah, I can start even pre-operatively also, there is no problem. Nothing. In fact, the problem should not be with periparatite, but the problem should be with denosumab. There should be some complications or there are issues in starting denosumab or bisphosphonates in the management of post-operative fractures, but now the evidence suggests that you can use combination of periparatite as well as bisphosphonates or denosumab in the post-operative management after osteoporotic fractures. So earlier there was an issue stating that denosumab or bisphosphonates should not be used for few months after fracture fixation. But now the recent evidence says that you can use bisphosphonates, or I preferably use denosumab and periparatite after intertrochanteric fractures or subtrochanteric, especially atypical femoral fractures.
Harishmurthy, just one. Has the union changed in using bisphosphonates or teripeptides or denosumab? What was your earlier results of union and now? Have you ever tried to compare it?
Sir, I think definitely teriparatide definitely benefits in the union rate. Bisphosphonates I was not using before also, sir. So I am not a great user of bisphosphonates, but recently I have started using denosumab. So the results are quite good, sir. But I don't use denosumab alone for fractures, but I use denosumab for patients, especially elderly, who come with back pain and where I think suspect osteoporosis as the cause of back pain. I use denosumab. But after fractures, my first drug is teriparatide. Definitely it helps in the fracture union, sir. I think there is no doubt about that. Even the literature also suggests the same thing. With the sizes quadrangulus, there may be doubtful evidence, but with teriparatide, I think the evidence is very clear.
I am also using teriparatide in the elderly population with severe osteoporotic fractures. Even I compared the callus formation, it's better with teriparatide after using.
So in my hands, many times I find this high subtrochanteric transverse fractures are very difficult to use. Many times I went for open reduction. And whenever there is a more of a medial column fracture, a loose fragment, getting a closed reduction is very difficult. You have to open and fix either the subclass where and then go for open reduction. Those are my indications. And then some long spinal fractures where you struggle to get closed reduction, go for open reduction just to put a linear clamps, hold the reduction and then go for the.
If alignment is good and even though there is a lot of combination, if it has a very good cross-section area, the more the cross-section area healing will be better.
If you feel alignment is good, there is no virus and everything is fine, then you can go ahead, sir. There is no issue. The only thing is we are worried about your virus. You should never get a virus unless otherwise. But you should have a medial support. Medial support is very much important. If you can reconstruct the medial column, because it's a large time, better go for it and do a subclass. That is the one thing you can think of.
Thank you.
Thank you very much.
Thank you very much.
expertise has been enlightening. Our next speaker in this session is Dr. Arun Nayak from Navodaya Medical College, Raichur, who will talk on trochanteric fracture fixation, why do they fail?
Good morning, one and all. Respected chairperson. At the outset, I would like to thank the organizing committee for having me here. As already said, my job is also much easier after reading the lecture after Dr. Harish Murthy. So many of the slides overlap here. My topic for today is trochanteric fracture fixation and why do they fail. So reasons they are multifactorial, communication factors, fracture pattern, implant choice and surgical technique. So some of fracture related factors are first is unstable fractures like already mentioned, the reverse oblique, transtrochanteric, subtrochanteric fracture with a intertrochanteric fracture with subtrochanteric extension, combination of posterior medial cortex, and osteoporosis and lateral wall incompetence. Implant related fractures, factors are improper choice of implant, like dynamic hip screw used in unstable or a reverse oblique fracture, there is high risk of failure. Intramedullary nails are preferred in those unstable patterns. Mechanical mismatch, implant is too short, inadequate in diameter or improper screw design. Surgical technique, again poor reduction, which is one of the most important thing, varus malreduction, distraction at the fracture site, improper placement of the lag screw, right? And failure to reconstruct the medial capilla, which excessive loading can also lead to failure. Biological factors, poor healing potential, elderly comorbidities, smoking, corticosteroids, and other conditions impairing bone healing. Post-operative factors, premature full weight bearing in osteoporotic and unstable fracture, infection, and non-compliance of the patient. If you sum up factors which we have control are like preoperative imaging, implant selection, position on table, reduction, so that is open, closed, using adjunctive reduction techniques whenever required, starting entry point, and size and length of the implant application, as well as post-operative protocol. And things we don't have control, fracture pattern and combination, patient comorbidities, habits, and design of the implant. So this is a nice paper where the frequent use of post CT scan, which definitely helps. It always guides appropriate surgical decision making. The two concerned with the lateral wall fractures. So characteristics of the injury, whether it is stable, unstable, reverse oblique, and thin wall, lateral wall also leads to failure. Displacement, whether it is significant, so that what reduction technique you use, and you should be aware of bowing also when there is a cephalomedullary nail. Why stability matters, right? The loading, load sharing and load bearing. So also already mentioned about the your arm. DHS relies more on the intact lateral wall for controlled impaction. But cephalomedullary nail offers a short lever arm and better control in case of unstable patterns. Critical fragments are the posterior-medial calcar and lesser trochanter, which are key for the medial buttress. Lateral wall integrity predicts DHS failure if it is compromised. Osteoporosis, definitely cutout chances are more. So this is a study where the lateral femoral wall thickness, it says like 3 centimeter below, if the length is more than 20 millimeter, you can go ahead with the DHS. So if it is less than that, there are chances of fracture, right? And medial translation of the femoral shaft with lateralization of the, so no lateral wall, no hips. One more study here, also DHS was done, and they studied that post-operative resurgeries were more when there is less lateral wall. So it is one of the predictor of fixation failure and need for reoperation. So preserving or reconstruction of the lateral wall, it is more crucial in this case. Implant selection, depending on the same what already said. Reduction, coming to reduction, it should be spot on. Without reducing, if you go ahead, chances are bad outcome or failures is always there. So for reduction, again lateral, I am stressing that lateral wall thickness for using DHS, neck shaft wall reduction or residual based cervical gaping also. So what is acceptable? So anteromedial calcar reduction, and you should avoid translation, avoid negative medial cortical support. I will just tell about this in detail. Avoid anterior malreduction, restore the neck shaft, avoid varus, that is the root, avoid distraction. So while performing, if at all you cannot reduce, you don't get the anatomical reduction, how much mal reduction can you accept? Right? So what is the acceptable mal reduction or what? So this is a study which is says that percutaneous reduction technique must be utilized whenever you fail to get the reduction, right? And it is helpful, and the cutout chances are less. So the surgeon should prioritize fracture reduction and optimal implant placement, and should not hesitate to use incision, accessory incision to assist the fracture reduction. One more paper where anteromedial cortical support from People's Republic of China. He has given like negative, neutral, positive and negative medial cortical stabilization. So neutral is accepted, but positive is accepted and not the negative medial cortical stabilization. Likewise, in lateral view, anterior cortical stabilization, positive is accepted and negative is not accepted. So you will see our pictures. So what are these adjunctive techniques? Shank spin manipulation, wall spike, bone hooks, circular wire, collinear clamps and mini fragments. So cutout basically is related to improper surgical technique. So quality of the bone, quality of reduction and implant placement also has a role. So in this we have important tip apex distance, which is useful intraoperative indicator regardless of whether the nail or a plate is chosen to fix the fracture. Perhaps the most important measurement of accurate hardware placement within the head. Older theories about screw placement favored a low and occasionally a posterior position of the last screw, thereby leaving more bone superiorly and anterior to the screw. And this effectively lengthens the tip apex distance and should be avoided. So this is a figure. So when your tip apex distance is less than this, the probability of less than 20, probability of cutout is less. The moment it goes beyond the cutout chances, you can see in this. So in terms of cephalomedullary nail, the predictors of failure, here there is one more known as Calcar reference tip apex distance, and it says the lower and posterior half would be beneficial. So this is some X-rays. So preoperative imaging, here we cannot make out lateral wall this thing. Sometimes traction can make out. Otherwise, you go ahead with the CT. Then first thing is reduce. Without reduction, no implant or reaming. Then go ahead with fixation. Some of the causes of failure here, you can see there is an anterior distraction which can result in reverse Z effect, all those things. This again one more case, 10 weeks post-op female had again you can see post here there is negative this thing, and even implant failure can happen through the aperture of laxer. So pearls, varus is the enemy. Even perfect implant placement cannot compensate for varus reduction. Respect the lateral wall. Entry and trajectory as per implant design. Osteoporotic head, consider helical blade or cement augmentation. Conclusion: intertraumatic fracture remain a challenge. Despite modern implants technique, failure rates remain high. So highlight is need to optimize fracture reduction, which is not non-negotiable. Implant selection should be proper and implant placement should be proper. Thank you.
I just want to know, how do you measure your lateral wall thickness in a day-to-day practice?
Sir, it is said that it is 3 centimeters below the innominate. There, from there, you have to measure the lateral wall thickness. So for that, you have to take X-ray in correct position, right? So if rotation is there, you might be, it would be difficult. So better CT scan, if it is there, it would be very difficult.
Just before conclusion, I want Dr. Harishmurthy has done a lot of work on trochanter. Please tell the audience, when do you mobilize patients in any trochanteric, subtrochanteric fractures?
Sir, I think we can start partial weight bearing from secondary itself. If the stabilization, if the fixation is good, we tell the patient more weight and then they all collapse. That is not the right answer. See, our fixation should be such that the patient should be able to bear weight at least touch or partial weight bearing from 4th or 5th day. Though we say no, we will delay weight bearing for 1 month and all, even if we tell the patient not to bear weight, wait for 1 month or so, the patient will definitely bear weight. So our fixation should be strong enough so that the patient should be able to bear at least partial weight bearing from 5th or 6th day, sir.
Why 5th or 6th day? Why not
Second day also, yes sir, yes. Immediate post-op, the patient should be able to bear weight, at least partial weight bearing.
Sir, how about the thrombolytic agent usage in fracture cases?
In intertrochanteric fractures, my chances of DVT has been very less. I am not using regularly thromboprophylaxis. But for THR I am using, but nowadays I have again shifted to ecosprin. Earlier I have started on levodoxaban, I have started on low molecular weight heparin, but I had some wound healing issues. So now I have shifted only to ecosprin. I only stick with ecosprin for DVT prophylaxis.
Have you encountered DVT?
Yes, in one patient I had a mortality after cemented bipolar.
Any risk factors associated with the patient or surgery?
See, not surgery, but one patient I could not find out. See, that was, I was mobilizing the patient, she was fine, walking around. After walking, she collapsed. So that is the only one patient I have seen death because of PVT. I could not find out any other reason, but I had one episode of death in 26 years of my clinical practice. But I only now use EcoSprint. Other than that, I am not using anything.
Okay, thank you very much, Nayak, for your wonderful talk. I think
Sorry,
this is the next
sir. With your permission. Now, we all know the reduction is the most important factor in intertrochanteric as well as subtrochanteric fracture. We do use, the circulation wire. We have seen problems with circulation wire post-op many times. They come back with infection. So, is circulation wire really required after you have done your permanent fixation? Like, or have you tried where, you have passed the nail now, PFM nail. Have you tried removing the circulation wire? Or you always left it behind?
See, the literature evidence says, even the AO teaching now says that the circumferential wire, in between few days here, there was lot of criticism for circulation wire. And it was told that that compromises the vascularity and leads to infection. But the recent evidence, even in the AO literature now says that it is a very nice MIPO tool to achieve and maintain reduction. I have not tried removing the SS wire after getting a reduction and fixing the proximal bolt and distal bolt. I have not tried that, but I still feel that it will give some amount of inherent stability without causing much problems. There is one thing that can be used is the cable. The cable is supposed to give less amount of vascular damage than the single SS wire.
And any experience of having a medial plate?
For the fracture necrosis?
Yes.
No, only I have also seen the literature and I have just seen, but I have not used particularly. I have not personal experience with medial plate. With Smith-Peterson's approach is not there. I have not used it.
But anybody has used any experience? Medial plate?
Okay, thank you, Nayak. We'll go for the next session, please.
Professor and Head of the Department of Orthopedics, SNMC Bagalkot, to share his insights on the topic. Are we missing the femoral bowing in PFM?
Good morning, everybody. At the outset, I would like to thank the organizers for giving me an opportunity to present my views here. President sir, Secretary sir, and the Chairman sir. Greetings from SN Medical College, Bagalkot, to all of you. I think I have brought a topic which is seen by you probably, which has not been addressed or discussed very widely. This has been our guiding for the implant selection in IT fracture. Whenever we wanted to choose, we went for the classification, AO classification, unstable fracture, DOS type C, lateral wall is incompetent. Whenever there is all these points, we have used a long intramedullary nail for fixation. These are all considered as unstable fractures and it requires a long nail or else something which will reconstruct the lateral wall. But the problem with this is, in elderly patients, along with this instability, there will be a bow which is not matching with our available implants. So it brings about a problem. You say unstable fracture, long nail, increased bone, short nail, where to compromise? Whether we have to go for the extramedullary system, like proximal femoral plating or some other device, or still we should go with the long nail. So all the dots type C, at this point I would like to recommend to all the postgraduate students. This has been a stellar article in intertrochanteric fracture management, educational article. Please go through this, it's very important. It will make many points clear to you. So whenever there is a lateral wall is not there, it's unstable fracture, long implant. Whenever there is a elderly patient, usually it is dots type C, it is to be taken as an unstable fracture. So there will be bow. In elderly patient, there will be more bowing of the femur. And whenever we use, our implants are, the curvature, the radius of our curvature of our implants is 2 mm. It is for a normal femur, it will work out. But in elderly patients, this bone mismatch will be there and it will create problems. So whenever there is a bone mismatch, what we have done, whether we have changed to an extramedullary implant, I invite your opinion here. Whether you have gone for a shorter nail, which is against the principle. So how to do it? Approximately 1 in 25 cases we will come across such a case. Whether we have changed in 1 in 50 cases. We have experienced the anterior penetration of the nail in 1 in 100 cases. We have splintered the lateral walls because of the bowing when you introduce the long nail. 1 in 20 cases. So why this problem? This problem is because of the bone mismatch between the nail and the bone. So there is one grading system proposed by Eng and Chang Park. These are the bowings. First one, you have to draw a line from the tip of the trochanter to the midpoint of the intercondylar notch. If this passes through the right in the middle of the medullary canal, that is 0. If there is bowing, it will go into the medial half of the medullary canal, that is grade 1. If it is further, it will hit the medial cortical bone, that is grade 2. If it goes beyond the medial cortex, it is grade 3. So we should assess preoperatively what are the type of bows we have got. These are our personal experiences. These are the types of bows we have got. Straight and all variable. And some of the last bows are atypical. You cannot fit them into any of these. It requires a special implant. So these are some of our problem cases. At this point, whether you would like to go for long nail, go ahead, push the nail down, or whether you would like to change this to a shorter nail. What is your opinion? I would like to know what you would do.
Small diameter long nail.
Yes.
We can go with small diameter long nail. Or maybe sometimes we will encounter this problem if our entry point is not right. So these are some problems. I think these are.
So solve the entry point not right. We have taken entry point anteriorly. We have used 10 number nails. Even at 10 number nail, the bone strength is not enough to bend that nail to accommodate the curvature. So we had to we suffered because of this in some of the cases anterior penetration, though it was not very significant. We could manage with it. So these are one more problem which we have come across is because of our manufacturers, some dimensions are different. They are not matching with our. If you compare a short TFN, that is TFN, which is 180 millimeter, and this long TFN, the angle is not at that taper. Angle is distal in the nail in long TFN. Angle is at the taper in a TFN. This has caused the problem in the lateral wall. Everything went fine. At the end, when we tightened the screws, lateral wall splintered. So these are our problems. So whether to change to short nail and DHS was our thinking. So I will explain how it works. Whenever there is a straight medullary canal, the straight nail will work out well. whenever there is a mismatch, like in this case, there is some mismatch in this slide, that line, it will go and hit the lateral and anterior cortex. So how this has been solved? There are some models, there are some studies where the paper models with the nails they have compared and they have studied how this mismatch has to be managed. They have come out with the idea that anterior entry point will prevent this penetration in some of the cases, as serve as resisting smaller radius curvature nails, smaller radius of curvature nail and smaller nails, small thickness nails. They will prevent this, but the small radius of curvature nails are not available to us in the regular implant supplier. So, surgical tips, this is one more study. That's what our commercially available nails are not fitting, but in this study they have rotated this jig to accommodate the bend in such a fashion that instead of anterior bend it has become lateral bend. When a femur goes anterolaterally, if you rotate the jig little posteriorly, it will accommodate the bone. This is what one study says. They have used the contralateral bend long PFN in some of the cases. We don't have any personal experience with this. This is one such example. We came across such a case in our personal experience. This you can notice that there is bowing of the thighs and bowing of the legs. When we took the X-ray of the standard pelvis with both the hips and affected side, we felt that there is more bowing. So we went for the contralateral femur X-ray. There was increased bowing. Normal nail wouldn't go there, and it was osteopetrotic bone. That's why we had to bend this nail to get that nail into the medullary canal. If you appreciate in the second X-ray, that is the lateral view, we have bent this nail by our own ingenious technique to accommodate that femoral bow. Okay, this is for comparison, regular and the bent nail. This is a bent nail. It is very easy to bend a nail of 10. It is difficult to bend nail 11, and it is not possible to bend the nail 12 mm diameter nail. It was not at all possible to bend. So we used a 11 number. We used our own technique. You make sure you have your own armamentarium before you try this. And what I would recommend is, don't miss the bow pre-operatively and don't hit the bow intraoperatively. This will prevent our complications. This is just a small video I would like to play for you. This is a 1997, the famous banana shot played by Carlos in France. So, sorry, I think that video didn't play completely. When the defenders were standing right in front of him, the ball went across, bending across, and it went to the goal. That was a very famous goal. So bend your nail or get an appropriately bent nails whenever you are suspecting such cases. How when to suspect? Whenever there are bow legs, short stature, when you see the X-ray you get a suspicion. Varus deformities of the knee, varus deformity in the X-ray of the proximal femur, Dobbs type C, suspect bowing. In Dobbs type C, suspect bowing. These are our suspicion, red flags, and you suspect and you be prepared. Our recommendation is identify the abnormal bow, lower radius curvature nail keep ready, or keep your armamentarium ready to bend the nail, use smaller diameter nail, and custom design nail, and keep other devices ready when this also fails. Thank you. Anterolateral going. This is not in one plane. It's anterolateral going. That classification is anterolateral. It's not a pure anterior. No, in whichever direction you bend, it will bend.
To accommodate the nail, but people lax will go
differently. That is not my recommendation. view of the affected side is very difficult, it is painful. On the unaffected side, we have flexed that and we have taken the lateral.
Cross lateral view can be twice.
Yes, yes.
Don't you compromise the strength of the nail while bending?
I am not sure, sir. It might have compromised, but in this particular case, it united, the fracture united, patient is happy. So I don't have any complaints.
So when we were students, that Vallali sir must be knowing 3-point configuration of Kunstner nail. What do you say about this? Why only when nail should be inserted to the bent bone? Why not 3-point concept should be adopted for stability?
In the Canadian, we used to have deep or construction nail, but see the problem here is different. He is bending the regular nail. There the three-point concept was definitely there because there was no locking system. Now they have got a locking system. That is the reason.
No, may I take this question? May I take this question, sir? The cranial, the fixation, 3-point fixation was before the locking nails come up. The 3 points used to get fixed because of the entry point. It is hitching on the anterior cortex in between the cortex. But interlocking we have done away with this 3-point fixation. Now matching the bow of the.
I think we'll end up this session now. Okay, thank you very much.
Thank you, sir.
So just one question. So is there any role of most of the time the anterior bending of the femur is at the lower 1/3. What are we using? The regular nails is around 38, 40, 42. If we stop the nail length around 32 or 34, we can achieve hitting the anterior cortex.
Your doubt is correct, which is a valid doubt. That's what one of my options was, whether to go for a shorter nail. The problem is, whenever you use the nail which is crossing the isthmus, you should fill the medullary canal up to the distal metaphysis. Otherwise, it will give a stress riser at the distal metaphysis. It will lead to stress riser fracture at the tip of the nail later on. Especially in these osteoporotic fractures. That's why it is, you have to fill the whole medullary canal up to the distal metaphysis. Sorry, sir, it's out of my.
I want to add, weight is very much common in metabolic bone diseases. Underlying metabolic bone disease, especially hypothyroidism, what we see in our like 20 to 50 age group. Hypothyroidism, which is undiagnosed, and the patient land up with fracture when they come to you. This hypothyroidism, especially landed in lymphedema, coma. We have seen so many patients coming with severe moving of the femur. The underlying cause will be many of the times it is hypothyroidism, which is untreated.
In this particular patient which I treated, it was osteoporosis.
Metabolic bone disease, usually hypothyroidism is very much common in our area.
Yes, sir. Thank you, sir.
Thank you, sir, for enlightening us with a difficult topic. Now I request all the speakers to come on the dais for the small translation program, and I request the moderators and the chairpersons to felicitate the speakers. I request Dr. Vijay Agli, Dr. Santosh Nandi sir, Dr. Siddhartha Patel sir, Dr. Harish Murthy sir, Dr. Veerbhadra Jowade sir, Dr. Arun Nayak sir. Please do come on the dais, sir.
ಇದು ಆಫ್ ಮಾಡೋಣಪ್ಪ ಪ್ರೊಜೆಕ್ಟ್ರ್. ಹಲೋ ಸರ್.
Hello, sir. Hello.
ಎಲ್ರಿಗೆ ಹಾಕಿದ್ ನಾವು ಒಂದು ಫೋಟೋ ಅಂತೇಳಿ ಅಷ್ಟೇ. ರಾಘವ್ ಕೈ ಮಾಡಷ್ಟೆ. ಸರ್
ಸರ್ ಹಲೋ ಪ್ಲೀಸ್ ಸರ್
ಬರ್ರಿ ಸರ್ ಬರ್ರಿ. ಮೊಬೈಲ್ ಬ್ಯಾಕ್ ಸರ್ ಮೊಬೈಲ್.
Without further ado, let us now dive into our second session of the day with Dr. Gururaj Sir, Professor and Head, Department of Orthopedics, KOPPAL as our moderator, and as chairpersons, Dr. Anil P. Patil, Dr. Girish Vastanar, and Dr. Kanaka Chalapati Sir. Please welcome on the dais, sir.
I now welcome Dr. Raju Akimaradi sir from Bagalkot to speak on role of trochanteric stabilization plate in intertrochanteric fractures.
Good afternoon. I want to give a very thankful to the KOPPAL ORTHOPEDIC SOCIety and KOPPAL to make us innovative talk on this subject. My today's topic is role of PSP plate in intertrochanteric fractures. This is the outline. I will go through these headings. This is the classification by AO, in which the PSP has a role, that is A1, A2.2 and A2.3. This is a controversy, short taken with PSP A2.2, but they are telling this is the one small intermediate fragment which can be nailed and with the support of PSP plate, whereas A2.3 is the intermediate comminuted fragments, more comminuted fragments. Why DHS fail in unstable fracture? DHS initially in practice we used to get a simple intertrochanteric IT fractures. That time we have used to use the DHS which has a good controlled collapse leading to union. As the recent trend is changing, there is a mismatch between the GT lateral wall support and proximal femoral anatomy. In these cases, there is a DHS has failed because of loss of controlled collapse and medialization of the femoral shaft. That leads to failures. In 2004, Gottfried reported 24 cases in which all his DHS cases failed post-operatively. Then he came, he analyzed, he noticed there is the unstable fracture with the lateral wall structure integrity is lost. So whenever you want to go with the implant before, we should assess the lateral wall. That is a major determining factor for a fixation device. Why lateral wall is important? Because our all abductors attached to the GT tip and our fixation of the neck goes through this lateral wall. That is the CCS screws or your PFN screws, or this is the main area, and this is the entry point for all our distal fixation devices like short PFN, long PFN, femoral nail. All these this is the entry point. That's why lateral wall is very important. This is how you will measure the lateral wall. The one study has shown this is the 3 cm below the vastus lateralis ridge and 20.5 mm from the lateral wall to the fracture line. That is the major determining factor for our fixation in IT fractures. Initially, this is the paper published by Chinese. They have shown that if it is less than 20.5 mm, most of the cases of DHS have failed. Now I come to my topic, that is the evolution of TSP. Initially, this TSP was introduced in 1998. It was first initially there was actually in PFN was introduced in 96. So they have come up with the DHS trochanteric stabilization plate for a DHS. When you use the TSP plate in unstable IT fractures, that is posteromedial comminution, reverse oblique comminuted GT fractures. Whenever there is a lateral wall thickness is less than 20.5 mm, that time also you should use the TSP plate. These are the different extension of the TSP with the DHS. In 1996, you have introduced PFN name, that is minimally invasive procedure and stable fixation, which prevented the varus collapse. As it is the next slide is what is the it's a load sharing device and it is very near to the mechanical axis of the femur, so it has resisted the varus collapse. Even PFN had its own complication like a screw cutout, varus collapse, implant migration, Z defect and reverse Z defect, and implant failure, anterior proportionation of the nail tip. So, what is the solution? Our own from Solapur, Shashikant, Ganjale and Vasudev have devised the TSP plate along with the PFM nail. What are the advantages of TSP? It creates the biomechanically stable construct, one thing. Next is it restores the proximal femoral anatomy, significant reduction in excessive collapse, and reduction in limb length discrepancy, and better functional and radiological outcome. Even Jain and S. Sital have suggested the same study. TSP with PFN has a good results. These are the different type of TSP plates. Initially, first figure it is devised by Shashikant Ganjale from Solapur. It has a 2 screw for a cervical screw and anti-rotation screws, and top of the cobra shape there is a cortical slots for fixing the GT with the cortical 3.5 mm screws. Later they have devised, there is different variation with the different companies. They have made anteriorly and posteriorly distal locking screws so that bicortical fixation can be achieved. That is the construct of the PFM with the TSP. These are the few cases we operated. PFM with the TSP plate, long PFM with the TSP plate. second case. This is the third case. This is the 102 years old female operated last week. It has a little bit of virus in the post-operatively. We don't know if still we have to follow up our lady. Complications, because we are not locked distally, there is a virus reduction with the proximal virus is there, and poor fixation with the osteoporotic bone. These are the some failures. Even we have tried with circulage wire, still we had a failures. What if even TSP fails? We have to augment screws with the bone cement. TFNUT is a stable construct. Either we go for hemi or total with the circulage wires. Initially there was a proximal femoral locking plate which had a higher failure rates, so it is nowadays rarely used. And take home message is TFN with TSP restore the proximal femoral anatomy. It reduces the varus collapse and limb length discrepancy, superior functional and radiological outcomes. There is a video demonstration for a postgraduate. If the chairperson agrees, I can play. This is done by Shashikant Ganjade on a one shop mod. This is 2 minutes video. If this time is permitted, we can play. This video is not playing. This is for a bone saw mod demonstration done by, not by me, Shashikant Ganjade from Solapur. This is for mainly for a postgraduate student how to introduce. This is not opening. Thank you for your.
Thank you. Nice presentation. Are there any questions?
I will try to interlock plate and nail distally. That I think will give more stability.
That's hybrid fixation.
I don't know. I tried once. 10 minutes.
Dr. Raju, I am Dr. Anand Gangali from Bangalore. It's a very nice, robust, biomechanically, what you say is right. You need to fix the lateral wall when it is damaged. But I would like to ask the audience, the senior faculty, how many of you use this TSP in your cases? If you can show with a raise of hands. Yeah, the question comes now, why is it not very popular? Although the biomechanics is good, a lot of people hesitate to use this TSP, whether it is Solapur TSP or there are other TSPs also in the market. Somehow there is a reluctance to use it. I'm just wanting to know what the reason.
Maybe what I guess that it is principally you are using the intramedullary as extramedullary. You are damaging blood supply on both the sides. That is one. The original disadvantage of more invasive DHS is used along with the nail. It's almost incidentally like the DHS over the nail. That will take away the advantage of intramedullary technique. These are my guesses.
What I think would be, see basically initially the trochanteric side plate came for DHS. So basically because DHS was giving uncontrolled collapse, the trochanteric side plate prevented the uncontrolled collapse of DHS. To prevent the uncontrolled collapse of DHS in reverse oblique or unstable treated trochanteric fractures, trochanteric side plate came to be used along with DHS. Now what we started doing, we started extrapolating it and then we started using this along with the PFM. what was the use, I think, with the trochanteric side plate, with the PFN is that you have not only with these two screws, you have to put another screw superiorly. So that will cause a triangular construct, and triangular construct is supposed to be better rather than a simple two screws. So that was the aim in using the trochanteric side plate. I have stopped using it because I tried few cases. Some of my results, even with PFN and trochanteric side plate, failed. And because it failed in initial few cases, I did not continue. This is my personal experience.
It also helps in the lateral compression. The wall is lateral wall is devoted. If this many a times this screws PFN goes directly to the nail. It doesn't. It cuts the wall and then it goes. This lateral prevents that.
Another thing is for introducing of clay, we have to extend the incision and violate the vastus lateralis. It's very difficult sometimes. And wound healing is a big problem.
Long-term results should be analyzed because most of the papers are not available. The long paper case.
Another thing, sir, as Dr. Suresh mentioned about the screw, going inside. Even backing out, I think, can also be stopped if there is a, if the holes are locking. I don't know whether the plate has got the locking holes. If it has got the locking holes, probably it may even prevent the backing.
College student is done as studies under guidance of Patel sir. Results are almost around 50% are good and 50% are failures. So long-term study should be analyzed.
Any other questions? Yes.
No, very validly as Gangali sir has raised and Pavlov sir was addressing. See, the Z effect what you see is one goes inside. When that becomes a weight bearing screw, other backs out. So whole idea is whenever there is a thin lateral wall, that primarily which is a weight bearing screw is not going to go further inwards. It is a buttress to the lateral wall. So probably we can reduce more Z and reverse the Z effect. We don't have to have a locking hole for that.
Thank you.
iatrogenic or pathological fractures also. So clinical features like pain in the hip, inability to bear weight, shortening and swelling, and sometimes neurovascular complication also. In X-ray, when you take the plain X-ray, you will see the broken shrunken slide. But sometimes when it is occult, CT is must. So you should suspect the fractures. That is, high suspicion you should have whenever there is a high energy trauma, and you should include X-ray of the fracture, that is one joint above, one joint below, and CT scan is highly recommended, especially when initial X-rays are inconclusive in a case of undisplaced or impacted fracture. Intraoperative and postoperative imaging are essential to confirm the diagnosis, assess the final erection and fixation of the fractures. CT, of course, to have better visual of the fracture anatomy and high velocity injury, and whenever there is X-rays are inconclusive. MRI, that is for occult X-ray wise negative fractures, pathological fractures, and to know whether it is a delayed union, non-union, or even AVN early stage. Bone scan is also required to suspect when there is neurologically occult fractures, pathological fractures or malignancy, AVN, the fracture healing assessment, to differentiate between the pathology either stress fracture or osteomyelitis. PET scan, of course, is also for to know the metabolic activity of the fracture site, to know AVN, and to monitor metabolic bone disease. Early management, as all you know, that is initial stabilization and resuscitation, of course reduction with the help of various traction devices. Surgical option, that is, it is really challenging. The primary goal should be to achieve stable anatomical reduction and rigid internal fixation to allow early mobilization. So we have to consider some of the points before going for the fixation: age of the patient, quality of the bone, fracture pattern, and surgeon's experience. Of course, the intramedullary nailing is the first choice because of its superior biomechanical stability. Of course, extramedullary devices also you can use: proximal femoral locking plate, DHS, in arthroplasty, especially in elderly patients. So when you miss the neck fracture, not only pre-operatively, even you miss intraoperatively also. So that is missed nail technique, that stands for minimally invasive skip nail. The problem here is the standard femoral neck fixation requires placing parallel screws or a device across the femoral neck into the head. But if the patient already has the IM nail, the nail blocks the usual entry paths for these screws. So instead of removing the existing nail, surgeons skip or miss the nail by inserting percutaneous screws to the neck fractures in minimally invasive manner. So advantage of this, it avoids the time consuming and risk, the removal of the old nail, minimally invasive, reduces the operative time, blood loss, the chance of infection is also very low. Of course, polytrauma it helps. It has got its limitation. Like in high porosity precision, the risk of malpositioning more, and not always visible if the nail completely blocks the screw pathway, and stability may be less than ideal compared to the standard fixation. So challenges, we have different challenges in adults as well as challenges in the elderly population. Because high energy trauma associated with the polytrauma and soft tissue injuries requires initial stabilization and multidisciplinary approach. Complex fracture pattern often requires specific implants and techniques. Risk of non-union and avascular necrosis is very high due to high energy mechanism and disruption in the blood supply. In elderly again, because of osteoporosis, associated medical comorbidities, and high demand for early mobility. So general principles are always prioritize the neck fracture first, because displacement and malreduction, there is chances of high non-union or UVN are there. Sharp fixation can be done after securing the neck. Use CR freely, both to AP lateral.
anticipate difficulty because hip implants lead to both neck, that is cannulated screws, EHS or small plates, even sharp like nail, plate, sometimes external fixator also. See, neck reduction, there are some pulse technique, that is attempt close reduction first. That is leg better or Whitmer under traction. If not satisfactory, work cutaneous joystick cable method or shank screw in femoral head neck fragment. Don't hesitate to go for minimum open reduction. Stabilize the reduction quickly with 1 or 2 guide wires before addressing the shaft. So, in fixation, first is always nail, that is the single implant, cephalomedullary nail. One implant addresses the both fractures and good for especially young patient. Be aware, difficult reduction, communicated shaft or unstable neck. Second, of course, dual implant, that is separate for neck and shaft. For neck you can use DHS or CC screw. Shaft you can use retrograde, long intramedullary nail. Advantage, of course, easier reduction control, especially useful if neck is displaced or communicated. So sequence is, first always you should fix the neck temporarily with the wires or screws, then proceed for shaft. Exception, again if shaft is grossly unstable, preventing the neck control of the reduction stability, you can fix the shaft with the temporarily external fixator. The entry point, if planning cephalomedullary nail, entry should not disturb the provisional screws in the neck. Use parallel guide wires to avoid collision. So these guide wires insert provisionally wire for the neck fixation before reaming, because it may disturb while reaming of the shaft. And fluoroscopy oftenly, both fractures can lose reduction during reaming or even the screw insertion also. Bone grafting may be required if neck is communicated or you suspect where there is a biological healing is delayed. So post-operatively, of course, with the routine post-op care with the pain control, antibiotics, DVT prophylaxis, and monitoring the neurological status, brain output, and hemoglobin routine, and mobilization and weight bearing. Here, the neck fracture dictates the rehabilitation protocol, not the shaft. So stable fixation, you can go with the toe touch from the day to after the second or third day. Progress to full weight bearing only after the radiological signs of minion. If it is unstable, non-weight bearing or toe touch for 6 to 8 weeks, and gradual progression depends upon the minion of the fracture. Of course, physiotherapy, early, both hip and knee, ROM, ambulation training, wound and implant care, because regular wound inspection is important, and caution with the distal screws of the nails, because there will be stress riser or very prosthetic fractures. And regular radiological follow-up is a must, and the interval of 6 weeks, 3 months, 6 months and 1 year to assess neck fracture union, shaft union, and any implant complications. So the complication surveillance includes neck of the femur fracture risk because it is high chance for non-union and avian. Of course, shaft also delayed union. General complication should keep watch. Young patient, always preserve femoral head at all cost. Elderly osteoporotic, you can think of arthroplasty. Of course, bone health optimization is also required. Complications, we have general complication and related to the fracture configuration, Kasawara, non-union, avian, hardware complication, limb length discrepancy. So how to prevent these complications? Intraoperatively, you can prevent the poor reduction and mal-reduction by achieving good close or open reduction. You can manage this poor reduction of this mal-reduction. If fixation is unstable, devise the reduction. Consider open reduction with the circulate or provisional KOS and other things also. Implant position, mal-positioning, you can prevent by maintaining the tip apex distance, that is less than 25 mm. Placement should be always preferably central to center or inferior central. Manage immediately revision if unstable Otherwise, we have to go for the regular follow-up to see the late complication. Early complications, we have loss of fixation, that is either the implant failure, that the causes are so many, like bone quality, inadequate fixation. You can manage, you can go for fusion fixation or augmentation with the bone graft, with the single or dual implants. Elderly, you can go for arthroplasty. Infection, of course, super pressure, antibiotics, deep surgical requirement, or unstable stage implant removal. DVT, regular DVT prophylaxis. Late complication, especially non-union in the neck, where there is inadequate stability, poor balancing. Either you can manage with the dynamization, of course, if nail is used, bone grafting, exchange of nailing, you can go for even arthroplasty also. Non-union, like varus, sharpening, rotation, you can assess and correct with the corrective osteotomy. AVN, of course, you can early stage you can go for bone decompression, later EHR, limb line discrepancy, and implant related complication already told that Z effect, KFM, with the optimal placement of the screw. Periprosthetic fracture also can manage with long nails or plates. So functional complications, as usual, we can assess. These are some of the research articles to support our study. So these are some few surgery cases where the neck with intertrochanteric fracture and neck undisplaced. This we have noticed during the surgery as involved with a single device implant, segmental fractures with the medial buttress plating. So my take-home message is complex femoral fractures, though it is uncommon but not easy to manage. X-ray evaluation must include one joint above distal to the fracture site. Supplement CT, especially in high energy trauma. Anatomical reduction with a robust fixation needed for early mobilization leads to optimal results. All types of implants must be available for fixation. Early identification of complication and frequent follow-up. Medical line of management not to be neglected, especially for the osteoporotic fractures. Thank you. And with the consent of organizing committee, I want to invite for this KMC-RI Ortho Alumni Meet, which is going to be held on November 8th and 9th, with academic discussions, cadaveric workshop, shoulder arthroscopy, and robotic ECAM. Thank you.
Thank you, sir. Sir, one question, sir. The implant that you choose, the fracture like a femur fixation along with the ipsilateral fracture shaft femurs, whether you opt for cannulated cancellous screw separate for the fracture like a femur and plate femur neck shaft, or you want long PFM implant, which implant you choose?
If it is undisplaced fracture neck and proximal shaft, better to choose single implant, that is long PFM.
Any other questions, please?
No questions, I think.
Okay, no questions.
Thank you, sir. Excellent.
Thank you.
We'll move on to the next speaker.
Thank you, sir, for your intuitive words on the topic. I now welcome Dr. H. Katti from Katti Hospital, Bagalkot, to present on primary arthroplasty in intertrochanteric fractures in elderly.
Even if you do osteoporosis, definitely it is not going to have better punches, definitely going for non-alien or implant failure. And already these patients have so many medical comorbidities, they can't tolerate the subsequent surgeries. So why can't you consider primary arthroplasty in such sort of practice? So already our elderly population is increasing. They have so many medical problems like osteoporosis and the poor bone quality, and they need a single safe procedure for their early population. So as already everyone knows, all these conventional fixations in such elderly populations have got a very high failure rates, almost up to 16%. We can't compare our Western results because Western population have got a better bone quality than compared to our Indian population. So definitely this primary arthroplasty in elderly population is going to help in early operations, and they will have a better rehabilitation, and medical morbidity can be managed very well, and it's single most definitely surgery for the elderly populations with a high success rate. Here I am discussing about unstable practice. Everyone knows all stable practice, even in elderly population, can be fixed with a conventional application like supplementary nails or DHS. Here I am talking about only unstable fractures. Those who having a severe posterior middle combination, and sometimes the reverse oblique pattern, and sometimes the lateral wall is totally thrown out, and sometimes fracture even extending into either neck or subthoracic area. These are some fracture patterns with the combination and overward fractures with the lateral wall fracture, and the fracture having an unstable geometry. Why fracture fixation fails in such a patients? Already my previous speakers have already discussed about this, because sometimes this kind of surgeries will operated by medial more surgeons without getting adequate reductions. So I think such, especially to manage these elderly populations, you need like very well experience to manage such kind of fractures. I will not go into detail because already it has been discussed. So, what can you consider arthroplasty for unstable external fractures in proximal femur in elderly populations? Dr. Lord has coined this term coxofemoral bypass. So many literatures are supporting the role of primary arthroplasty in elderly populations in unstable fractures. These are some papers also that are supporting the primary arthroplasty in elderly population. So what are the problems whether you are doing contemplating a THR or bipolar in an elderly population? Essentially femoral side, because there is a loss of bone slug in old populations, and then altered landmarks, and there is some discontinuity abductor mechanism because of the GP fractures. So you should have better fixation to get early mobilizations or initial stabilization. So some important steps to embark when we were doing this procedure. So first thing is to, whatever available landmark, you determine the length of the limb. Even sometimes even your opposite limb will guide you. And one thing is how much the implant should be sunk in, because once you sunk more, it's very difficult. When you make it proud, then also it will be difficult. So it's better to sink a little bit more so that it can adjust in the modularity. Even both the vertical and lateral offset should be restored to achieve the adequate soft tissue tension. Once unstable arthroplasty is very distracted in the elderly population. This, as already mentioned, the opposite limb can guide you to restore the length. And one more, how to determine the stem worsen in such patient, because already there is no bony landmark proximally, so you can rely on either femoral condyle or proximal tibia. You can draw a line from the tibia and perpendicular line, then you can make a 15-degree anteversion. whatever you should achieve at least your combined anti-rotation should be nearly to 30 degree. And to tell you precisely, this is a abductor mechanism repair is a main determinant factor whether your surgery is going to success or failure. So you can use many, like you can use wires to reconstruct the abductor mechanism. Sometimes you can use a ribbon, but sometimes if there is a very severely complicated GT fracture, you can require such kind of fixation like hook plates with the cables. So if you don't achieve a proper abductor mechanism, this is inevitable. So what are the types of implants, process you are going to use in such kind of patients? One is cemented calcar replacing processes when there is poor bone quality proximally with a very severely osteoporosis bone. That time you can think of using cemented calcar replacing processes. This is the cemented calcar replacement processes where it has got a proximal holes, so that you can use that holes to reconstruct your abductor mechanism. Same as we use in the proximal femur, humerus to repair the rotator cuff like that. So even if we get engagement implants. So these are some, this is 78 years patients, so having a unconditioned fracture pattern from the, conventional treatment. So we did the, so we use here calcar replacing, cemented calcar replacing processes. This is one more example of calcar replacing processes. Here I actually sometimes will use a lesser trochanter LT, or I will cut this one part of the neck and I will place the reverse manner in the calcar place, so that I will reconstruct the calcar portion. Such cases I am using conventional modular processes. Sometimes if you can get away with this conventional bipolar process, when there is not much combination in the fracture patterns, sometimes you are not sure about whether the fracture is extending into the neck. So, but when you have doubt, it's better to replace than to do it. These are the one more case. This fracture is not conditioned for the conventional methods. So I did a bipolar, I used here bipolar, regular bipolar, and reconstruct with the wires. This is one more case. Here also I used the bipolar, conventional bipolar, and abductor mechanism reconstructed with the wires. Sometimes when there is a pretty good cortex, so you can use the uncemented long distal fixing femoral stems to avoid the cement implant syndrome. When if there is so much comorbidity in the patient, that time you can't use cement, that time you can think of using this uncemented long distal fixing femoral stems. This is one example of such case. So sometimes you can consider primary THR as a primary treatment. When there is some pathology in hip joint, already existing pathology in hip joint, or especially in older patients, there is already so much cartilage degenerated, that time you can think of doing THR. Post-operative, you can ask the patient for full weight bearing, but usually I advise to use some kind of support in few weeks. So initially, it's better to discourage the patient to do active abduction exercises. When you are doubt of this one abductor, you can think of using the rotating cup. These are some complications, dislocation, wire breakage or sometimes cutout of implant. In conclusion, so primary arthroplasty is an acceptable option in carefully selected fractures in elderly populations. So it's technically demanding, so experienced surgeons can give a better result. When there is a proximal femur bone loss, you can think of using cemented calcar replacing process or uncemented distal fixing stems. In compare with the internal fixation, in elderly population with unstable fractures, this primary arthroplasty gives better result, lower failure rate, and give early mobilization to the patients. Thank you.
Thank you. Any questions, sir? So that last slide you showed, this, what did you do with it? I mean, this again the same problem, proximal bowing. Because most of our stems are, stem is outside. No, like you had this one of the complications.
This one, the first
yes,
one?
yes, this one.
Later I did converted to EHR.
No, some of these proximal bowing is another problem here because we already have, that we are trying to replace the proximal part of the femur, and you have to use a long stem.
Second slide or?
No, this second slide. This now. Second and third.
That is because of the poor reconstruction of the abductor mechanism.
How are you tackling that proximal bowing?
Yes.
Bowing?
Bowing. And many times we have this problem when you use long stem, and these stems are straight.
Here I use only regular pipe.
Still lacks of
not a long stem.
This is not a long stem. Regular pipe.
Anybody has any?
It's the most common thing, but in spite of affect the outcome according to the long-term study. So we don't have to worry much about the breakage of the wires.
We need to remove the wound.
Yeah, we have to do it, but in the final say mobility and function-wise, it doesn't affect. Second thing is most of these cases are done probably 80 plus, 85 plus age group.
It's above 75, above 75.
Later, what is the younger, what is the threshold for the age?
Why this one was 76? 76 years.
Yeah, even more than that. Probably they do it above 80, bone-part fracture, osteoporotic, high comorbidity, all these things. So as far as the bowing goes, it's a problem even for other cases also of total hip. Not only for these things. So we have to plan reoperatively and get the implant specific and put the proper point.
Even you cannot expect that bony area in that abductor mechanism reconstruction. It's just a bonus.
What is it?
Regarding the abductor mechanism, extension mechanism fixation, as Galgali sir had said, those were the days in 1960s and 70s when low friction arthroplasty concept was used and trochanteric osteotomy was done, and then you used to have those failure channeling. But in India, it's the Dolokia group, the Pachore Saab, and they have given a very nice paper. It is there in our Indian Journal of Orthopedics. trochanteric stabilization technique. It has very good result. The only thing, the difference is, and the crux is, what the hook plate which we use, there are special cables. These SS wires made, they don't have that much strength to hold it. And if still, even with those, if we even they do well, so that should be the message. Yeah, the trochanteric stabilization technique, wiring technique, around
what's the approach you will
normal procedure approach, and usually I will go through that fracture and
go through the fracture or you take a separate?
No, I will go through the fracture.
And the second thing to answer is one question. The shortest launch time is what is mentioned. 190 is the maximum you can. You are going more than 190, make sure that the goal is not significant. Because if you go to 255, 265 or 315, your lateral view has to be taken and the over has to be less.
In badly communicated, we can go into the fracture, through the fracture only. See from the neck.
Usually it's better
If
to
the
even if there is no fracture, create a fracture.
even like revision cases, that time you can create a fracture.
Thank you. Thank you, Kadi sir.
By going through the fracture, are we avoiding the damage to the structures, or what exactly is the thing communicated? Because already it is separate and it is easy, our approach is already done. But in some cases, I have gone, majority of the cases, I have gone through the fracture. But in one or two cases, I have gone from the procedure approach also. That is the reason I am asking.
If it's very well, you are doing the phase ID, when it has united, then you can go ahead posterior approach. But with a very high risk of it's as high as 40%. So that needs to be kept in mind.
Thank you, sir.
The main reason why the dislocation is very high is because the GT, when it unites, it's
Our next speaker, Dr. Hari Krishna sir from Hupalli, who will discuss current concepts in avascular necrosis of head of femur.
Good afternoon all, and thank you KOA and KOPPAL Orthopedic Association to give a chance to speak on the newer concepts on hip which we do nowadays. So the topic is on current concepts of AVN. So definitely we don't want to replace such a beautiful hip joint where the femur is so good. So I can't replace a beautiful femur if I can save the femur. So the concept of the AVN, we all know that depending upon the stage, we can save them and we can replace them. So the concept has evolved from don't replace to regrow. So the concept of joint preservation has been outdated after the replacement concepts has come. But with recent advances like stem cell therapy, arthroscopy, high tibial osteotomy, minimally invasive surgery has again taken back the concept of joint preservation. And as a mechanical cause of degenerative diseases are now recognized earlier with an MRI and advanced scatograms, so we can prevent them to become more advanced than becoming known. So if you see the two case scenarios, the same case which I have done for the left side is stage 2 AVN of the hip. I save the hip and the opposite side we replace the hip. So it's totally an artificial joint. So whether I do hip replacements, I regularly do the hip replacements, then why joint preservation if the hip replacements are good? We all know the hip replacement is a metal body inside the body and which requires revision surgery, and the cost if you go for a ceramic implant and durability, we all know that, we all tell our patients that it comes from 15 to 20 or 25 years sometimes if you do a ceramic.
But if you see a natural way of bone cell therapy, which is DGCA approved and it's a single stage procedure, and we can do that procedure and they do very well. Coming to one case scenario I start, this is the same case. He presented to me with the stage 2 AVN on the right side and the stage 4 AVN on the left side. I've done a total replacement on the left side and core decompression with the bone cell therapy. So he came after 2 years like this with a pouring pus in the hip joint, and it was a frank pus. Then I've done a spacer, and then after 9 months we revised him to a total replacement, revisionist with a stringent beads. So why joint preservation? Because it preserves the native joint, it avoids the complication of the processes, and especially is beneficial for endo patients. We don't want to do hip replacement in less than 40 years, what we tell. And AVN early stages, definitely prevention is possible. So coming to our talk today, the femoral head AVN. We all know that this is the most common cause of hip pain after the COVID, and we see lots of cases of AVN post-COVID because of steroid use. We all know the staging, and it's the luck of the patient or the luck of doctor. Diagnosing at early stage, it's important. I feel sometimes pity that when they come to us in stage 4, I cannot do a preservation, I should do a replacement in them. So that's why if they come early, we can save them definitely. We all know this mechanism of the pathway the alcohol and steroids does is, it alters the mesenchymal differentiation and reduces the ability to become osteoblastic lineage. So that's why our target should be a mesenchymal infiltration along with the core decompression or an osteoblastic infiltration. So if you see this diagram which was already presented, this is a microfracture which happens there in the subchondral area. So it prepares the present area there. So this fracture, microfracture should be avoided by drilling there, so that core decompression is done in this part, and then we inject our osteoblast there. So we all see some patients will be born to 5 years, 10 years, something they will be in stage 2 only. Because there is a natural way of repair mechanism happening in the body. It usually will be a 3 types, which is osteoblastic activity, which is already going on into the body, and the blood vessel formation of the dead bone, and fibroelastosis formation. But sometimes we see a patient which is already drastically gone into within 6 months, they go into stage 3 or stage 4. Because there is already a dead bone which is already forming, and there is no new bone is forming there. Already the dead bone which is occupying, and already the death is forming there, so already subchondral collapse happens. Then the more forces happens, and then it becomes stage 3 to stage 4. So that's where the concept of Osbro comes. And this is how we aspirate the 20 ml of bone marrow aspiration of the hip joint. I sometimes do in a prone position and sometimes in a lateral position. I aspirate around 20 ml of bone marrow aspiration. Some people does it the same sitting with the bone marrow aspiration and mesenchymal cells and injecting the hip joint. But what we do is usually is the osteoblast which are cultured for 4 weeks. So it's cultured for 4 weeks, and they give almost a 40 period of osteoblast, and then we do a procedure with core decompression, curating the dead bone, and then injecting the osteoblast. So this is a histological site of the osteoblast which were given by the company, and then we do target the superior and anterior part where the maximum forces of the hip joint occurs there, and that is where we concentrate our core decompression and debriding the hip there. So previously I used to do two drill holes. So I used to put a inferior like a DHS screw type, then I used a 4 mm reamer, and the proximal I use a 8 mm reamer, and then start curating the bones, which was a dead bone. This also again curating the dead bone there. Once you remove adequate around 5 to 10 cc of dead bone, we create a cavity there, then we inject the bone cell therapy with a needle. So this is the infiltration of the 2 ml of fibrin glue along with the 2 ml of osteoblast. Will be passed into the hip joint with a 2 cm of incision. Once we curate around the 8 mm, then I use an interference glue so that the interference tip is very small, so that the gel will not be backed out, and it sets in 8 minutes. We all use like in the knee joint like ACI, like autologous contrast and implantation. Same the method here also we do that. So once we do that, then we make them a protocol post-operative non-weight bearing for 3 weeks, then partial weight bearing for 3 weeks, and then we take X-ray after 3 months and 6 months. I am an arthroscopic surgeon. By not doing an arthroscopic surgery, which was recently done by lots of people for the AVN, then we started doing an arthroscopic procedure for all AVN cases, so that I debride the joint, I can stage the disease of the joint, so it reduces the pain. I've seen some 20 cases I have not done hip arthroscopy. Then I started debriding the joint. They feel better ROI post-operative because some synovial tissue which is already there, we debride that. So This is an under the traction, the scope is gone inside the trocar cannula, and this is an arthroscopic image where this is all thickened synovium. We remove that all with a shaver and RF probe, and then start grading. These are follow-up cases. This is one patient which is on the left side having a core decompression. There is one more on the left side having THL and the right side having core decompression. There is one more patient around 37 years which was already stage 4, so I have not done it. And here I have done the core decompression, it's doing very well. And this is the follow-up case same which I have discussed earlier, which was the THR, and the right side is doing very well. See, this side is already 5 years of time, he's already revised his hip. But the right side still is doing well. That's why preserving the natural joint is advantage. There is one more case where I have done a hip replacement on the right side and core decompression with the bone cell therapy on the left side. So this is the same case where the same patient, usually I do a total hip replacement first and then I take the bone cell, so the meanwhile the patient will be ready for the weight bearing, then do a core decompression along with the interference screw, then inject the cells in the femoral head along to the, you should target the superior and anterior area and the both AP and lateral views. So once you do that, this is the same patient on the opposite having a total hip replacement. So once I do a total hip replacement, once the uncemented will become better, so that because he cannot walk post-operatively for a non-weight bearing, so do a total hip replacement first, then do a bone cell therapy. So in the meantime, so this is a follow-up very well. This is again, she's very young, she's around 32. I did a core decompression, she's doing well. And this is a post-operative examination, is going very well with the post-operative movement, hip joint. And there is a paper which tells that arthroscopic synovium and core decompression with multiple bones has some effect with the pain relief as well as hip ROM. And this is a study which was published about the cultured osteoblast, which is already doing by the Osteoid company. So this shows better results in our case. This one more report which was present from Chennai, the biological therapy for the avian or the femoral head, same the Osguro. So we have failures also. So this is the same case, I have done a core decompression. It has gone into arthritis within 6 months of duration. I have done a total replacement in her on the right side also. So our experience after doing 50 cases in 5 years, I never selected more than stage 4. Stage 3 because sometimes I tell them that only 30% chance is there. Sometimes people tell try it. Then I tried it. In that no results were there. All are failed because we should not have the collapse of the femoral head. If we want to inject the gel, the head should be intact. Otherwise the gel will come to the joint. They will not stay there. That's why I now stop doing cases. I only tell them up to stage 1, stage 2, bone cell therapy or stem cell therapy. And then on the stage 3, stage 4 directly replace. The take home message in the current concepts of my talk is we should diagnose early is a critical point. Joint preservation is preferred in early stages. That's intraarticular pathology also is there. So stem cell biological documentation show promise, but some definitely needs long-term validation. I started doing since 5 years, and maybe lots of people start doing. Lots of people does mesenchymal cells, PRP and all. They have their own experiences, but I do most of the time because I require an osteoblast. When I'm getting a good cells, tissue also can bone also, but I require as a bone. I require a
DMRT advising DMRT
definitely steroid impairs the. We all know that steroid damages the mesenchymal cells. So I think there is no role of.
and Dr. Vijay Ghosh have been using those things. They say that it's control the exercise.
So in our practice, I have seen one patient for 5 years. So whether these drugs are yes sir, then I thought it's a steroids is not used.
DMRT is
DMRTs, I don't think so. Better you can use a bisphosphonates or a bisphosphonates.
Those are the other things, but even people are nowadays advising DMRTs for the
maybe HCQ is advised nowadays in everywhere.
Dr. Vijay Bose himself is using, off late he is not using coding compression, rather he is preferring DMRTs.
Maybe.
Sir, antibiotics for that methotrexate is using just like what we give in Thank you, sir.
Scientifically nowadays I'm doing for all cases because I have an advantage when I go into the joint. Yeah, definitely, because grade 1 is only synovitis. When we see the staging, when they have a pain, the grade 1 is synovitis. So if you debride the joint and just do a body compression there, if it's almost like 100 and 1% we can get a result if you have in stage 1. But in stage 2, definitely there is already synovitis developed there, but the head is definitely intact. And for us also we can see under arthroscopy the femur head is on, we can see that we can definitely tell that this head is going to become stage 3 or stage 2. So arthroscopy will aid in diagnosing the head also, as well as the removing the synovectomy will definitely increase the empowerment. Grade 3 I don't stop doing because grade 3 we have one more procedure we want to do. Maybe an arthroscopy we want to put a cartilage on the head and do a coating of the subchondrally, but it's technically very challenging because to put it in gel on the femur head and then do a coating operation. So in the future, we are trying some or 3 or 4 procedures where the femur head, like ACI, where the cartilage is lost in the knee joint, we just coat the cartilage cells. So same like that we want to do in a hip arthroscopically, do the head coverage with the cartilage cells and do a coating operation and put the stem cells. Like the roof is covered as well as the base is covered. But stage 3 we stop being at present because we all know it is already damaged. Almost 7 cases, sir, in my experience. 7 cases or more. In that case, one patient for 6 months, one patient 3 months only it has aggressively damaged. So what I tell my patients is at least 1 year we should wait. In 1 year, but some patients are not satisfactory. They come with 3 months only with you.
I think we'll stop here. Any more questions? I think you all can personally meet Dr. Krishna and discuss with him. I have a small suggestion for all the presenters and speakers that as we have most of the people here, delegates are postgraduates. So let's all try to talk on evidence, what the evidence says rather than our personal experience, because they're going to tell the same thing during their exam times and they're going to write that. So let's be more specific about evidence based rather than our opinions are definitely have a this thing, but they cannot give that answer in the exam. So thank you very much, sir. Thank you. Good talk. And invite the next.
Thank you, sir. Now I invite Dr. Shivraj sir from MRMC Gulbarga to share his insights on hip fracture, the lesser known area.
Kept in mind when we are treating the hip fracture. So what makes it more interesting is because of this precarious blood supply. So mainly the blood supply comes from the medial circumflex femoral artery, which is a branch of the medial circumflex artery, and it contributes to almost 60 to 70% of the head vascular supply of the head, followed by the lateral neck fracture. If it is undisplaced, you can probably try percutaneous if the associated case is not significant. If it is displaced, then we will have to do an open reduction either of Smith-Peterson or Watson-Jones. And then if it is, once you have a reduced hip, if it's congruent, no fracture, non-operating. If it's type 1 or type 2, but it's in place, there is a very good scope of conservation. If it's just like your GT fracture with the shoulder dislocation, if it falls in place, you can conserve it. So same way you can conserve the 15th 1 and 2 as long as they fall in place. If it's associated with posterior wall and it is highly unstable or stressful, then we'll have to fix it. If it is unstable, the approach, if it's posterior wall, you have to go posterior. And one thing always you need to keep in mind is when you're going posterior, don't go in with a concept that you'll be able to reduce and fix the pins without doing a safe surgical dislocation. It has to be kept in mind that if you are going to go with the pin fracture, you should have the necessary knowledge of the hip anatomy and how to do a safe surgical dislocation as advised by GANs. And then if it's, again, congruency is the most important thing. If it's incongruent, you need to explore it. Because there are multiple factors which can be contributing to the incongruency. And one of the most common thing I have seen in my practice is when you have an osteoperiasteal flap, which tends to go in when you do a close reduction. That also needs to be kept in mind. And if it is irreducible, most of the time you get an irreducible hip in a Pipkins, especially if the Pipkins type 1, if it is too big a fragment and it is rotated, you will have an irreducible hip. If you have an irreducible hip, you are not left with much option, you will have to go and do a total reduction. So what are the surgical management controversies? In the fragment, if it's a type 1 Pipkins and if it's contributing to less than 10 to 20% of the hip, since it is infrafoveal and most 80% of your hip is intact, you can access it if it's acting as a loose body. If it is more than 40% or 30% infrafoveal fragment, then it's always advisable to fix it. So again, what are the options? As I told you, you have only two options. If you are going anterior, you can do a Smith-Peterson. If it's type 1 Pipkins, you can do a Smith-Peterson. Try not to damage the lateral circumflex vessels if you can, but most of the time it's very difficult to get an access without ligating the lateral circumflex vessels. But still it's okay because lateral circumflex vessels contribute relatively less to the blood supply, so you can go anteriorly, especially if it's a type 2 Pipkins, big fragment, and if there is a need to fix, you can go anterior because you don't have to go posterior if there is no associated posterior wall fracture and a congruent reduction. But for any chance you need to go posterior, make sure that you have a good knowledge about the safe surgical dislocation. Why am I stressing this? Safe surgical dislocation is must because if you release your quadratus femoris for any reason, the whole blood supply of the femoral head is gone and you will end up with avian, or it's as good as sacrificing the head on the table. So you need to have this. So what saves the blood supply in GAN osteotomy is once you do a flip osteotomy of the abductor, then you external rotate, not internal rotate. You external rotate. External rotate. Internal rotation is the one which gives the vessel in the severe stress. So you need to external rotate, do a Z capsulotomy, then anteriorly dislocate the hip. Then you can fix the fragment with the anteriorly by using Harvard screws. So again, what is the devil complication? So 20% chance of AVN without intervention. With intervention, you have a 50% chance of post-traumatic arthritis, and on the long-term prognosis, there is even a good result. 10% always complain of some issues. So rehabilitation again, it's almost similar to this. You need to have a longer period of immobilization and a longer period of assisted weight bearing compared compared to the other neck fractures or the intertrochanter fractures. So for case example, this is a young female who had come with anterior inferior dislocation, type 1 15 fracture. Close reduction was done, and once we did a close reduction, in the CT, unfortunately, I was not able to play the video, that you can see that displaced 15 type 1 was lying posterior to the hip joint. So we had to go anteriorly, with even posteriorly, because it was lying in the posterior part. When you go posteriorly, again, the emphasis is to do a scan osteotomy, reduce the hip well, hold it, fix it with screws, and then fix the trochanteric clip with the 100 screws. This is the video. Unfortunately, it's not playing. This is another case. This patient has 15 type 4 fracture, that is, he had a type 1 head fracture along with the posterior wall fracture with dislocated hip. And this was a irreducible hip, so we had to go posterior. Again, we went ahead, then did a cal osteotomy, reduced the type 2, type 1 fracture with 3 Herbert screws, and then fixed the posterior wall with the plating screw. So, conclusion, high suspicion is extremely important when you are dealing with the diagnosis. Diagnosis is extremely important. If there is a need for multidisciplinary action, we need to take care of that. Thank you.
Thank you. Very nice presentation. Just for the sake of nostalgia, when and how do you find out that the AVN is already started? Because you already have an implant there. Doing an MRI sometimes may not be able to, conclude on that.
So using titanium implants, you can go ahead with an MRI. But the usual algorithm or the usual time frame to develop a AVN in the hip is considered to be between 2 to 3 years. If the head is not collapsed, your screws are not exposed, and they are not causing any sort of post-traumatic arthritis, usually it doesn't go to AVN for till about 2 to 3 years. So patients do well till 2 to 3 years, and then they might start developing this. And this is very common in, especially in type 3 and type 4. Less likely to break, so 20% in type 1 and type 2.
What about weight bearing? Any change in your weight bearing protocol?
Minimum of 3 months. You can't allow them to weight bear for 3 months, especially in type 2.
Good presentation. So that in the last case wherein you have posterior wall fracture or with the big case, would you able to do it without doing the same surgical?
Yeah, that's what I was trying to tell you. You can't do it. It's not advisable to do it because you will not be able to get the fragment out. The type 2 fragment, which is attached to the ligamentum teres, you can't get out without damaging your posterior muscle, basically your quadratus. The only way you can probably do is if you want to release the quadratus from the ischium, but it's still not advisable because you eventually tend to damage the vessel. The whole principle is not to damage the medial circumflex artery. Yes.
If there are no more questions, I think we can go with the next question. Thank you, sir.
So, X-ray what you showed you should do, what type of screw you use? It's better to use a Herbert screw.
It's always Herbert screw. I use Herbert screw.
Okay. And now one of the cases you said you went anteriorly and posteriorly. So can this surface?
No, I didn't go anteriorly. That I went posteriorly because even in the type, normally in your type 1, you have an option if it is well reduced. Type 1 is infrafoveal.
Yes.
So if it is well reduced, you can go anterior smooth itself. If it's well reduced.
No, not anteriorly. Can dislocation, can osteotomy between, so can upload, surgical dislocation.
Yeah.
So you were able to upload the fragment. You said because there was a posterior dislocation, the fragment is posterior, you had to go posteriorly.
Yeah.
What
the second one was an irreducible hip. That was the hip pad reduced posterior. They were dislocated posteriorly along with the posterior wall fragment. But the fracture of the head was type 1. So it was infrafoveal. So I can't get it out without doing a GANS. To get the head how tired of the things.
So all the times ligament teres has to be sacrificed, attached to the
If it
fragment.
is big enough fragment, then it is attached, you need to sacrifice. Because I can't get it out. You can't keep it in situ. If you have to do an in situ fixation, then it has to be reduced. Then you have to go and take it. You can't do post it.
Okay, thank you. We'll go with the next.
Thank you, sir, for sharing with us your expertise on the matter. Now we have our final speaker in this session, Dr. E. Venkateshalu, Professor and Head, Department of Orthopedics, WIMS Bellary, who will talk on neglected hip dislocation. Why do they fail?
Now it's not WIMS, it is BMCRC. Distinguished professors, chairperson, delegates, my dear friends, beloved postgraduate students, warm welcome to KOICL KOPPAL HIP-360. KOPPAL HIP-360 Bellary, within a distance of 90 kilometers, 3 districts are there. What is common here is paddy fields, Tungabhadra water, sponge iron and steel plant. So I don't feel that I am away from the home. So neglected hip dislocation. I am supposed to talk on neglected hip dislocation, and the time given was 9 minutes. Not possible. That's why I added traumatic and adults. Otherwise it would go on for hours together. So what exactly refers to the neglect? Some people say it is beyond 24 hours, some people say it is 72 hours. Of course, the golden period for any hip dislocation is 6 hours. Beyond which the chances of avascular necrosis is 54. So, 3 weeks, 21 days is now referred to as beyond which we call it as neglected hip. After which the structural changes takes place like soft tissue contracture, capsular fibrosis, acetabular changes, compromised blood supply. Hip is a very major joint, and dislocation is a very dreaded traumatic, major traumatic event. To miss neglected hip dislocation is very rare, but still it is more common in developing countries where there is limited access to timely orthopedic care thanks to traditional bone setter. They rely more on the traditional bone setter than qualified people. And another reason is high pain tolerance and cognitive impairment, which leads to unrecognized injury. And these kind of dislocations you come across more in the ICU with polytrauma patients. So that's why you should always take all pelvis X-rays, very important. This is a small exercise for postgraduates, food for thought. Which vessel provides the principal blood supply to the femoral head, making it most susceptible to vascular necrosis or traumatic port? Is it lateral femoral or middle femoral or ligament teres or inferior lateral? Anybody? Postgraduates. It's medial femoral circumflex artery. It supplies more than 80% of the head of the femur, and it arises from the profunda femoris artery. The theoretical classification based on time since injury, it's acute dislocation is acute if it is less than 24 hours, subacute 1 to 21 days, and chronic or neglected. This is today's topic, more than 6 weeks. So based on the status of the hip, prosthetic and native hip, in prosthetic, again total hip replacement could be positional, implant related, soft tissue related, traumatic. Position in the sense the acetabular placement, correct version and inclination should be maintained, and femoral choice of implants also should be good. And soft tissue tension is also very important to prevent post-operative dislocations. So based on the direction, posterior dislocation is most common, 85 to 90%. Whereas the anterior it is 10 to 15%. If you see all these 3 images, the head is out of the acetabular. But whether it is anterior or posterior, postgraduates, how do you say? I say in the upper image it is posterior. Why? But in down it is anterior. Don't look at the joint, you look at the shaft also. If it is adducted, it is always posterior because of the anatomy, it is posterior. If it is abducted, it is anterior dislocation. Anti-dislocation is again of two types, high level and low, that is pubic type and observatory type. This is asking question, image asked in DNB exam. A 32-year-old male brought to the emergency ward after high speed road traffic. The limb position is shown as swan columns, abducted, external rotated. This is a pubic type of anti-dislocation. Pubic type of anti-dislocation is the only traumatic condition I think will have the lengthening of the limb, whereas in all other fractures around or dislocations around the hip, this gets shortening. So what exactly happens after 21 days? Why 21 days is fixed? Means 21 days is the inflammation will converted into granulation tissue and fibrous tissue. So the neglect leads to the fibrosis of the capsule, contracted surrounding muscles like short external rotators and impairment of the iliac veins. And also because the lubrication of synovial fluid is not there with the cartilage, the loss of cartilage will be there, filling with fibrous tissue leading to difficult reduction, and if you leave like that, there will be attempt to form a pseudo-astaba. And also the femoral head changes, avian, flattening, osteophyte formation. And sometimes if the patient comes with the history of massage, to rule out myositis aspirans also. And a very important related complication when you are contemplating or planning for any treatment, you should always keep in mind neuropraxia. Sciatic nerve palsy is very important. So that is why you may do lot of time many high dislocations, you have to shorten the limb by self-appointed shortening of the. So the dislocation is associated with fracture. It's classified as Thompson and Epstein. In type 1, there is no fracture. In type 5, it is associated with head fracture. In type 2, 3, 4, posterior acetabular fracture depending upon the combination. Any neglected dislocations, patient usually will be referred or from pain, limb history, and if it's more pain which comes down, patient may have androgen gait later, Renelberg gait, then there will be fixed deformities like what I have got, limb length discrepancies and decrease the length of movements. So deformities you should always keep in mind. Anterior dislocation, pubic type, limb is abducted, external rotated and extended. Anterior dislocation, obturator type, that is inferior type, it's the only condition where you get lengthening. There also it is external rotated and flexed. Posterior dislocation is very common and is abducted and internal rotated and flexed. Shortening, cross shortening. Investigations, AP and cross-table lateral hip exercise should be taken, wherein the hands of the patient should be kept over the chest. The median cervical plane should be perpendicular to the casket, and the casket is placed with the bucket plane. We take exactly lateral view to see any fractures or any fragments inside the acetabular. CT scan is sometimes needed to rule out any minor cartilaginous fragments inside the joint and also to rule out any acetabular fractures or head fractures. MRI is always mandatory before you take up for surgery or for close reduction to rule out to see any avian or labrum, capsule or surrounding muscles. Helps in preoperative planning. So if you leave like that, what are the complications? One is avascular necrosis of the femoral head, secondary osteoarthritis, heterotropic ossification, especially the history of massage is there, chronic pain and still disability, and nerve injuries. So what are the challenges when you take up for open reduction or total replacement? Because soft tissue contractures is very much. In acetabular fibrosis, bony chances are to be there. And there will be osteopenia of the femoral head because it is lying outside the acetabulum for a quite long time without any nutrition. Difficulty in achieving stable reduction without damaging the neurovascular structure. This is very important. You do very beautifully reduction or do THR come out, lengthening you have done, the patient will post-operatively have a sciatic nerve palsy and everything will be lost. And also high risk of redislocation. So your principle of treatment is pain-free, mobile and stable hip like any other condition, correction of limb length, prevention of complications. So there are many options, close reduction, open reduction, salvage procedure, THR, and as old when we were students, the Gupta setas was a very famous, like used to put skeletal traction for 18 kg skeletal traction, gradually used to decrease the weight and gradual abduction. He had got many series and dislocation got reduced and he had got very good results, more than 70 to 80%. But now it's not like that. Many times total hip replacement is required. Flow reduction should be always tried if the patient comes less than 3 weeks. After 3 weeks, better not to try because of complications of fractures. Open reduction is viable only if the patient is very young. And salvage procedure, Hutchinson arthroplasty still has got a role in a low demand patients and bedridden patients. Total hip arthroplasty is the now treatment of choice for many neglected disorders. So this is the algorithm for treatment of neglected. If the acetabulum is intact, if it is less than 3 weeks, flow reduction can be tried. 3 to 12 weeks flow reduction may be attempted with good muscle relaxation. More than 12 weeks, better go for open reduction. But if it is associated with the fracture acetabulum, the treatment is different. There are many methods of flow reduction. Bigelows is a very famous method, but the basic principle is you have to give traction along with the direction of deformity. So many modifications are there, walker modification, so many, more than 100 types of things. For anti-dislocation, you better apply sling over the thigh and somebody has to give traction and sling has to be utilized for reduction. And with the Stinson's method is doing reduction in prone position. So open reduction, as I told, the indications are young patients that less than 40 years, neglect is again less than 3 months, no avian changes. Open reduction, if it is posterior, Cocker-Langenberger approach. If it is anterior, Smith-Peterson or Watson-Jones approach. Langenberg approach should be very careful, should follow 3 principles. You should not violate quadratus femoris, as speaker has told, and you should cut external rotators 1 centimeter, 1.5 centimeters away from the program, so that you should preserve the head circulation. Sometimes you may slip the vastus lateralis and trochanteric, and you can do both femoral and acetabular in anti-dislocation PHR. See, in open reduction, you have to follow the extensive capsular release should be done, the removal of fibrous tissues from the acetabulum, gradual soft tissue stretching. That is, it has to be done previous to take the patient for surgery. You have to do traction for 2 to 3 weeks so that you have to stretch the soft tissues, and later you have to take the patient for open reduction. Again, MCQ, which intraoperative maneuver are very important to prevent damage to external rotation. Is it internal rotating the hip or external rotating the hip and flexing the knee or extending the hip and flexing the knee? Anybody? Postgraduates? Actually, this program is for postgraduates. No postgraduate is contributing. All consultants are not, in my view, not teaching the postgraduates. Extending the hip and flexing the knee is the standard method where you can prevent sciatic nerve. So total hip arthroplasty, the indications, again, more than 40 years, don't aim for open reduction, and significant cartilage damage or labia if it is noted in MRI, and if there is a lot of acetabular erosion, you have to go for PHR. The challenge is while doing PHR is shortening. Shortening is very stubborn block to your reduction. The risk of sciatic nerve injuries, if it is more than 4 centimeters. Bone loss of acetabulum may require augments, cages. A need for subtrochanteric shortening osteotomy in high dislocations is very important. And outcome, a good pain relief and function in most of the cases. Slight higher complication rate than primary case, I think normal. This is a total hip arthroplasty done in anti-dislocation. Subtrochanteric shortening osteotomy is done when femoral head is positioned too high, that is more than 4 centimeters, be reduced without excessive stretching, allows reduction without stretching the sciatic nerve, fixed with long stem or cradle. Indeed, as I told, excision arthroplasty still has a role in a low demand patient and bedridden patients. Again, a question that one presented after 2 years, very gross shortening, and his Harris hip score is very, very poor. The answer is constrained total hip arthroplasty. No dual mobility, nothing. Or snap fit. because the post-operative dislocation complication is very, very, very high. Whatever the surgery you do, whatever the type of PSR you do, so should always keep in mind the constraint type of. So post-operative highly mobilization, first always static quadriceps exercise should be done, then dynamic, then weight bearing gradually should be started after 3 weeks. So these are the hip precautions after surgery. So you have written the exam, you are waiting for the results. It all depends on duration of the neck leg, condition of the humeral head, surgical expertise. THA gives best long-term responses. Open reduction can give fair results than early in the period and in any patients. You can still improve the results of the neglected posterior dislocations or entry dislocations with very gross shortening with recent advances like 3D preoperative planning, patient-specific cutting beds, robotic-assisted THA, modular implants. All these are all may in future may cut down the complications of surgeries on posterior hip dislocations. So take-home exercise and key points are prevention via early diagnosis is critical. Chronic dislocation is a reconstructive challenge. THA with or without shortening osteotomy is preferred in most chronic cases. Each case must be individualized. Thank you.
Thank you, sir, for excellent presentation. If there are any questions, I would allow only one question because we are very falling short of time. If there are no questions, I think you can ask during the lunch hour or when you meet personally. So thank you, sir. Excellent presentation. Lots of tips you gave most videos. Thank you. Thank you very much.
I would now like to call all the speakers of session 2 on the dais to be felicitated by our respected moderators and chairpersons.
Sir, hello. Raga, one nimsha.
Let us now take a moment to felicitate our moderator, Dr. Gururaj sir, and our chairperson, Dr. Anil Patil sir, Dr. Kanaka Chalapati, and Dr. Girish Vasanath sir by our organizing team, headed by Dr. C.B. Chiliwal sir, for their valuable contributions to this session. We will now have the inauguration ceremony to KOPPAL HIP-360 under the aegis of Karnataka Orthopedic Association and Department of Orthopedics, KIMS KOPPAL.
Your presence and excited for the occasion that brings us together. This event is a testament to our shared values and collective efforts. It's a time to connect, reflect, and celebrate the journey we have undertaken. Your participation means a great deal, and we hope today will be inspiring, engaging, and memorable day for all of us. Let us make the most of this opportunity to learn, share, and grow together. First of all, I would like to welcome our respected Director Sir, Dr. Vijayanath Vidigi Sir, who has spared time during his busy schedule to attend this program. We welcome you, sir.
Okay, sir, ready? Smile, sir.
Thank you, sir.
We welcome Dr. Manjula P. Salmani, Medical Superintendent, District Teaching Hospital, Koppal. We welcome you, sir. I would like to welcome Dr. Anil B. Patil, President, Karnataka Orthopedic Association. We would like to welcome Dr. Harish Murthy, General Secretary, Karnataka Orthopedic Association. We would like to welcome Dr. C.B. Chinuwal, President, BBC Trust and Koppal Orthopedic Association. We would like to welcome Dr. Basavaraj S. Carter, Chairman, KS Hospital, for this function.
Sir, later.
I would like to welcome Dr. S.S. Kamalan, Organizing Secretary, Koppal Orthopedic Association.
Hey, Raghav.
I would like to welcome Dr. Vijay Mantesh Sonkar, Organizing Secretary, Koppal Orthopedic Association.
I request Dr. Sajanand Rai sir, who is the President-elect, to come on the dais. Thank you, sir. I request Dr. Gurraj to take over the chair as an organizing co-chairman. I request Anirudh Kulkarni, who is the treasurer, KOA, to come on the dais. I request Dr. Anand Galgali, who is a scientific chairperson for KOA, to come on the dais.
Thank you, sir. The lighting of the lamp is not just a ritual but a symbolic act. The flame of the lamp represents knowledge, wisdom, and positivity.
Today, as we kindle this flame, we are reminded of our commitment to walk the path of truth, learning, and service. It signifies the triumph of good over evil, light over darkness, and hope over despair.
I now take this opportunity to invite our esteemed dignitaries to come forward and light the lamp, marking the formal inauguration of today's program. I
would also like to invite Renuka to bless us with a prayer song.
Sir? Hello, sir. Hello.
जय मंगल शुभ मंगल देवी शारदे भगुदियली कुसुमनिन्नाडिय सेरिदे जय मंगल शुभ मंगल देवी शारदे भगुदियली कुसुमनिन्नाडिय सेरिदे विद्ये बुद्धिगळिगे नीने आदि देवते विद्ये इट्टु ಪೊರೆಯ ತಾಯಿ ದಯವ ತೋರದೆ ವಿದ್ಯೆ ಬುದ್ಧಿಗಳಿಗೆ ನೀನೆ ಆದಿ ದೇವತೆ ವಿದ್ಯೆ ಇತ್ತು ಪೊರೆಯ ತಾಯಿ ದಯವ ತೋರದೆ ಜಯ ಮಂಗಳ ಶುಭ ಮಂಗಳ ದೇವಿ ಶಾರದೆ ಭಕುತಿಯಲಿ ಕುಸುಮನಿನ್ನಾಡಿಯ ಸೇರಿದೆ ಶ್ರೀತಾಂಬರಿ ದಿಗಾಂಬರಿ ಅಳಕಾಳಿಯೇ ಮನಸ್ಸಿನಲ್ಲಿ ಮನಪೆ ನಿನಗೆ ಮಂಗಳಾರತಿ ಶ್ರೀತಾಂಬರಿ ದಿಗಾಂಬರಿ ಅಳಕಾಳಿಯೇ ಮನಸ್ಸಿನಲ್ಲಿ ಮನಪೆ ನಿನಗೆ ಮಂಗಳಾರತಿ ಜಯ ಮಂಗಳ ಶುಭ ಮಂಗಳ ದೇವಿ ಶಾರದೆ ಭಗುತಿಯಲ್ಲಿ ಕುಸುಮನಿನ್ನಾಡಿಯ ಸೇರಿದೆ ಜಯ ಮಂಗಳ ಶುಭ ಮಂಗಳ ದೇವಿ ಶಾರದೆ ಭಗುತಿಯಲ್ಲಿ ಕುಸುಮನಿನ್ನಾಡಿಯ ಸೇರಿದೆ ಭಗುತಿಯಲ್ಲಿ ಕುಸುಮನಿನ್ನಾಡಿಯ ಸೇರಿದೆ. ಥ್ಯಾಂಕ್ ಯು.
Thank you. I would now like to invite our esteemed director, Dr. Vijayanath Ittigi sir, to speak a few words on the occasion.
Good afternoon, everyone. I hope I am audible to all of you. Good afternoon, everyone. Very good afternoon to the dignitaries of the dais, and delegates of today's gathering, and the students community also out here. And I take this opportunity to thank Karnataka Orthopedic Association and KIMS chapter also, and also the KOPPAL district chapter also. On behalf of KIMS Parivar and KIMS Institute, I heartily thank the members of the esteemed organization for choosing this institute and giving an opportunity to coordinate with all of you. And I'm very thankful to the association, state association and district association. And without taking much of your time, I would like to underline all of you, especially the young colleagues out here. And all this type of gathering is only the motto, the objective of the gathering is to enlighten, to get the new latest editions in our journey of a medical field. Because we are in a journey, and definitely I don't think so any other profession deals like this. And after this tremendous, I mean the toughest journey, we all walk with huge stress out there. Still, hardly we get any thanks from any corner of the society most of the time. But still, we're all profession where we believe in our own disciplines and own commitments out here. And it's a gathering where we are here to learn and adapt the new skills, new technological and innovations, short of methodologies, whatever been added in our journey. And that updation is required, and this type of gathering brings all this added polish to our approach towards the patient, and ultimately the patient care will be improved. And this is the one basic things what I remember, and I always keep on putting my own colleagues into the task of doing all these types of CMEs, conferences and workshops. and since 2-3 years I think I am behind Dr. Gurraj and his team, but today they have responded after 3 long years. I am always behind to go to any level of your support system. Dr. E.D. is here as a teammate, not as any time as a director of the institute, because that is a temporary assignment for me. I don't believe in all those things. As a colleague to him, since I think 3-4 years, Doctor, I am behind you people, and today I am very happy. And I thank all the audience and the delegates once again. Good time. Any shortfall from the institute, I apologize for that. Thank you. Good time to all of you.
Thank you, sir, for those inspiring words. I now request Dr. Anil P. Patil, sir, KOA President, to address the gathering.
Good afternoon, everyone. Dignitaries on the dais and off the dais, and my dear postgraduate students. Indeed, it's a great feeling to be here today. This beautiful college auditorium. So outside, I would like to thank the management, the principal, and the head of the department for having given this wonderful place, and then they've sacrificed their time and then a lot of other things to make this possible, and I'm sure it will be a grand success. Having witnessed this since morning, and the KOPPAL Orthopedic Society, well, you have done a great job. I mean, I would really congratulate you. When we even announced that the ICL is going to be in KOPPAL, there was some doubt for a few people. But then all of us, we were very confident that they have a great team and they will do it. And in between, they had some small hitches, and they chose a beautiful topic. They were worried what to choose. Since this program is going to be more for the postgraduates, we said we'll try to play something around the hip. Why? Because your major case in the exam is going to be around the hip joint. So I want all the delegates to try and concentrate, get maximum knowledge. These people who are here are or will be your examiners. So having seen them, so you will not have the fear. Having heard them, you know what their answers are going to be, and then having observed the way they have they've interacted, you can guess what their questions are going to be, and then how you need to interact. Well, you need to not just that, having met the faculty there, attending these ICL, CMEs as well as the conferences. If you cultivate this habit of attending these programs when you are postgraduate itself, well, you will learn how to mix up and how you can take maximum help from everything, from the teaching program, from the faculty who are here. You can get introduced. Who knows, tomorrow you might be interested in getting into some super specialty training, and then having ever met him, him or her well in advance, it would be very easy for you to go and approach them later on, so that you can pursue your training in that specialty where you are interested. And of course, very thankful to the exhibitors who have supported us for this program. Without them, it was very difficult. I mean, they were all worried whether we'll have money to do such a program, and very thankful to them. And to the postgraduates, see, don't miss to go and see all around all the stalls. Why? Because, see, this is the time you get chance to see the instruments, the different type of medicines stalls which have been put, because that also is knowledge, because you will get a practical hand of what is new, and you all know that there is going to be one recent advances paper. So who knows, something concerned with that is always going to be there in your recent advances paper. So having said this, for the postgraduates and for the other members who are here, all those who are not KOA members, I request them to become KOA and IOA members. There are lots of benefits for having being the members. You get a chance to be part of the website. You can give your publications in the journal. You can attend the conferences and the CMEs. You know what activities are happening around in Karnataka as well as in all over India. So the postgraduates can become associate members. That is, you pay a small amount The fractional amount probably it is around 1,500. Yeah, and the secretary sir will definitely brief on that. And you can pay the remaining amount the moment you have done with your, your MS. You can become a full member. So take the benefit, make maximum use of these 2 days. And then I once again thank you all for having come here in your busy schedule. And all the best to you and all the best to the organizers. Thank you very much.
Thank you, sir. We appreciate your grateful insight on the occasion. I now invite Dr. Harish Murthy, sir, Secretary KOA, to inspire us with his words.
Good afternoon, everybody. Dignitaries on the dais. Karnataka Orthopedic Association ICL is one of the very important events in the calendar of events of Karnataka Orthopedic Association. The annual conference is the first state level event and KOA ICL is the second state level event. And the history all started in Gulbarga. The first Karnataka Orthopedic Association ICL was started in Gulbarga. It so happened that all the state conferences used to be conducted either in Bangalore, Mangalore or Hubli or bigger places, and smaller places and smaller districts they are not getting any opportunity to conduct any activities. With this in mind, the Karnataka Orthopedic Association decided to start this event, and the first KOA ICL was conducted in Gulbarga, and I was part of that, and we had great speakers like Shiv Shankar, Kottadia sir. They came to Gulbarga, and it was a very nice event. Afterwards, KOA ICL was conducted 2 times in Raichur, once in Ballari, once in Bagalkot. The last KOA ICL was in Sirsi. So it is rotating in majority of the places, especially in North Karnataka. But usually we are choosing those places where the logistics is not sufficient to conduct the main state conference. I am happy that KOPPAL Orthopedic Society, though they were initial hitches, what the President sir told, they have conducted an excellent Karnataka Orthopedic ICL. I should say, I all request you to give 3 cheers to KOPPAL Orthopedic Society. The activities conducted from Karnataka Orthopedic Association so far. The last year we have hosted 3 national conferences, one being the IOACon, one is foot and ankle and one hand surgery. But coming to this year, we have already finished the BOSCon under the aegis of KOA, that is the Bangalore Orthopedic Society. Just recently we have finished the WinterCon, which is the KOA BOS Winter Meet. This year we conducted the WinterCon in Russia, where the speakers from Ilizaro, there were almost 3 speakers, and there were blend of Indian and Russian speakers. We had a nice time in St. Petersburg in Russia. We also conducted the Bone and Joint Week celebration according to the guidelines of Indian Orthopedic Association. We are happy today that the Indian Orthopedic Association CSRC chairman is there with us today, Dr. Bharat Raju, and he has guided us in conducting all the Bone and Joint Day activities. And I am also happy that KOPPAL Orthopedic Society also participated in a nice way in conducting the Bone and Joint Day activities. We also conducted ESI Revision TKR workshop in ESI Hospital, Bangalore. We have done OSS Advanced CME in Tumkur. KOA sponsors 4 programs, out of which 3 programs are CMEs, 1 is KOA ICL. So already we have conducted 1 ICL and 1 KOA sponsored, that is OSS CME in Tumkur. Under the leadership of Dr. Anil Patil, this year we have tried to concentrate on North Karnataka. So as far as possible, we are trying to give majority of stimulation for North Karnataka people. As already told by Dr. Anil Patil, we request all the members to become, all the consultants to become the members of KOA and IOA. Only when we are members of the KOA and IOA, the Karnataka can compete for the best state chapter award and A.K. Gupta award. For this, maximum number of membership drive is very much required. So not only the consultants, even the postgraduates can become the affiliate members. Earlier it was 1,500, but now the fees has been made 3,000. The only thing that will be done is after you complete your post-graduation, you are supposed to submit the pass or the degree certificate, and then you will get the life membership award. You will get a temporary membership number now, and after you complete your MS Orthopedics or whatever postgraduate degree, you submit the degree and you will get the permanent membership number. There are, as told by our president, there are a lot of benefits of becoming the KOA member for yourself. Our KOA journal is also doing very good. I request all of you to participate and actively submit papers for the KOA journal, because it is on the verge of getting enlisted, and it will be indexed shortly. And for us to get indexed, only if the number of publications are good from your side, so we can get indexed. The coming Karnataka Orthopedic Association conference will be in Bijapur. The team is getting geared up under leadership of Dr. Nandi and Prakash Sastro. They are the organizing secretary and chairman for the KOM1, and I am sure they will do a very wonderful job. I request once again all the members to come to Vijaypura and enjoy the hospitality and academic fees in Vijaypura. Our KOA website under the leadership of Dr. Ramachandra has got a new overlook, and every member can log in, and all those members who have not logged in, you just log in the KOA website, koaindia.org, and look, and you can post your individual blogs there. So I request all of you to utilize the KOA website. With these few things, I would like to ask Dr. Anil Patil to hand over the check of 50,000 rupees to Dr. Kamra. Already we have transferred 1 lakh rupees, so another 50,000 rupees check we are handing over it now. And I also request Dr. Anil to come in.
Hello, sir. Yeah. Smile, sir. Sir, hello, everybody. One second, sir.
I have once again thanked the KOPPAL Orthopedic Society for having conducted this program in an excellent way. Thank you once and all.
Sir. Now I request Dr. C.V. Chirivav sir to felicitate our beloved director, Dr. Vijayanath Igli sir. Sir, please do come, sir.
ಸರ್. ಸರ್ ಪ್ಲೀಸ್ ಆರಾಮಾಗಿ ನಿಂತ್ಕೊಳ್ಳಿ, ಬರ್ತೀನಿ, ಎಲ್ಲರೂ ಬರ್ತೀನಿ. ನೆಕ್ ಪೇನ್, ಬ್ಯಾಕ್ ಪೇನ್, ಜಾಯಿಂಟ್ ಪೇನ್ ಎಲ್ಲ ನಮ್ಗೆ ಬರ್ತಾವೆ, ನಮಗೆ
And I request Dr. Kamran sir to felicitate Anil Patil sir.
Yes, sir. Yes, sir. Hello, sir. Hello, sir. Yes, sir. Thank you.
Thank you, sir. I request Dr. Guraj sir to felicitate Dr. Harish Murthy sir.
ಒಟ್ಟು ಹಾಕೊಂಡು ಏನು ಇರ್ತಾ ಇಲ್ಲ ಅದು ಊಟದ ಕಾಯಿ ಮಾಡಿಸ್ಬೇಕು ಮಾಡಿ. ಹಲೋ ಸರ್. ಥ್ಯಾಂಕ್ ಯು.
Thank you, sir.
ವಾಟ್ಸಪ್ ಅಪ್ಡೇಟ್ ಆಗ್ತದೆ. ಇವತ್ತು ಸಂಪಾದನೆ ಮಾಡಿದ್ದೀನಿ.
Basalaj Cater sir, please do come sir.
ಮುಂದೆ ಮಾಡಬಹುದು. ಹಲೋ ಸರ್, ಸ್ವಲ್ಪ ಈಗ. Yes, sir. Thank you.
Thank you, sir. I request Dr. Srivaram sir to felicitate Dr. Anirudh Kulkarni, Treasurer, Karnataka Orthopedic Association. Please, sir.
Hello, sir. Smile, sir. Yes, sir.
Thank you, sir. I request Dr. Suresh Koppadi sir to felicitate Dr.
ಇಲ್ಲ ಆ ಕಡೆ ಹಂಗೆ ಈ ಕಡೆ ಬರ್ತೀನಿ ನಮ್ಮ ಕಡೆ ಸರಿ ನಾನು ಸ್ವಲ್ಪ ಸ್ವಲ್ಪ ಈ ಕಡೆ
ಸರ್
ತಿಳಿ ಕಟ್ಸ್ಕೊಬೇಡ ಹೆಂಗಿದೆ ರೆಕಾರ್ಡ್ ಆಗ್ತೀವಿ ಹಲೋ ಸರ್ ಸ್ಮೈಲ್ ಸರ್
ಆಗಿರಿ
ಥ್ಯಾಂಕ್ ಯು ಸರ್ ಒಂದು ನಿಮಿಷ
ಟೈಮ್ನ ತೊಗೊಂಡಿಲ್ಲ
ಹೊಡೆದ ಬಿಡ್ತಾರ ಒಂದು ನಿಮಿಷ ಅಂದ್ರೆ
I request Dr. Mallikarjun Nitli sir to felicitate Dr. Anand Galgali sir.
ಅವ್ರು ಯಾರು ಬಿಡಿ ಪ್ರೊಫೆಷನಲ್ ಡಾಕ್ಟರ್ಸ್ ಅದೇನು ಅಲ್ಲಿ ಬರ್ತಾರ ಬಿಡಿ ಯಾರೋ ತೆಗಿಯಂಗಿದ್ರು ತೆಗಿ ಬಿಡಂಗಿದ್ರು Hello, sir. Sir, excuse me. Yes, sir.
Thank you very much, sir. Now I request Dr. Boomereddy sir from Gadak to felicitate Dr. C.P. Chiniwala sir.
Hello, sir.
Thank you, sir. Thank you, everyone, one and all. Now we'll head on to lunch, and I think most of the people are hungry. And another important announcement: there is a workshop on PFN A2 going on just behind this auditorium. There is a hall over there. We will guide you for the PGs, postgraduates, and anyone can attend. Especially it is for postgraduates, and request postgraduates to attend that workshop. Dr. Shankarling Sajjan will moderate the session. And there are two workshops. One is PFN, proximal femoral nailing A2, and another is total hip replacement, primary total hip replacement. Dr. Vivek Patil from Hubli will moderate it, and Dr. Shankarling will moderate PFN A2. All the PGs are requested to attend that, and you can have lunch simultaneously, whichever is convenient to you. You plan according to that, but the both will go simultaneously, lunch and workshop. Thank you. And one more announcement, please be in time. We have got 1 hour from 2:30. By 3:30 we will assemble again here.
I request all EC members of Karnataka Orthopedic Association to join at Directors Conference Room, Directors Video Conference Room for the EC meeting. It is just next to this hall. The EC meeting will be now only before the lunch. We will complete the EC meeting and then we will go for lunch.
EC meeting ಅಂತ
ಕೇಳು ನೆಕ್ಸ್ಟ್ ಎಲ್ಲಿ ಹೋಗ್ಬೇಕು ಕೇಳ
ನಾನು ಸಬ್ಬಣ್ಣಿಗೆ ಇದ್ದೀನಿ
ಓನರ್ ಕಂಡಂಗೆ ಕಾಣ್ತೆ ಅದಕ್ಕೆ ಹೇಳಿದ್ದು ನಾನು
ನೀನು ಎತ್ತಿಸ್ಕೊಂಡಂಗೆ ಕಾಣ್ತೆ
ತಗೊಂಬಿಡಂಗ
ಯಾವುದು
ಇವರ ತಗೊಳಂಗಿಲ್ಲ
ಹೊರಗೆಲ್ಲ ತೆಗೆದಿನ
ಆಫ್ ಮಾಡುತ್ತೆ
ಹಾಂ ಆಫ್ ಇರುತ್ತೆ ಅಲ್ಲ ಎಲ್ ಇ ಡಿ ಹಾಕೋಬೇಕಲ್ಲ
ಮತ್ತೆ ಚೇಂಜ್ ಆಗುತ್ತೆ
ಅರುಣ್ ಭಾಯ್ ಹೇಳ್ರಿ ಭಯ್ಯ ತೆಗೀರಿ ಅದನ್ನ ಅದು ಕೊಟ್ಟೆ ಇಲ್ಲಲ್ಲ ಅವ್ರು ಏನು ತೊಂದರೆ ಒಂದು ಕಡೆ ಅಂದು ಅನ್ನ ನೋಡಿದ್ರೆ ಏನಿಲ್ಲ ಅಂತಲ್ಲ.
it reduces the operative time and improved outcome of the total hip replacement and reduces the surprise. But what is the in reality, where we stand in planning in clinical practice? There is inconsistent adoption in planning for the only simple reason of excuse of not having enough time, bad or ingrained habits of not planning earlier, and certain misconceptions. And younger surgeons are always in a rush to finish the surgery. And most importantly, what I feel is a problem with the company guys. They do not provide templates for small setups and low volume surgeons. If this gap of ideal planning and current practice is filled up, the outcome certainly would be better for a longevity of the implants. So the functional goals of the hip replacement, pain relief, improved gait, and limb length discrepancy correction, and achieving good mobility. So, but the planning of hip replacement goes beyond the surgery in terms of anesthesia consideration, evaluation of systemic illness, and local anatomical factors. Involving your anesthetic colleagues much in advance, as hip replacement being an elective surgery can save you lots of time and anxiety in perioperative management. And in certain orthopedic conditions like ankylosing spondylosis, your coordination for difficult spinal and difficult intubation, in addition to planning appropriate cup placement in ankylosing spondylosis, goes a long way. Systemic illness, well, like endocrine disorders, renal osteodystrophy, neurological conditions, so as to plan and have a backup of dual mobility in case of illnesses like Parkinson's disease and otherwise. Rheumatological disorders, of course, the positioning in ankylosing spondylosis, as I mentioned earlier. So, preoperative infection screening is a must. Zero tolerance for distant site of infection definitely helps to reduce the post-operative anxiety among the surgeons and prevent potential disastrous complications for the patient. So, a simple screening test of CRP raised, you have to put on alert to look for oral cavity, for dental caries, urinary tract infection, pulmonary system, any cough and cold, or some consolidation and GI infections. And not to forget, always have in mind, or in spite of your busy practice, take a look at the operative site or a gluteal region, especially in cases where he has been operated for some other reasons, to include the further planning of the scar, and if the scar has healed with or without any secondary infection. More commonly, you tend to see in chronic cases, surprisingly, you will have an injection abscess. And this part of a region is very common to have extensive fungal infections, and there can be sometimes psoriatic patches. All these have to be seen pre-operatively only to avoid surprises in the theatre. So a good X-ray pre-operatively goes a long way in planning your component placement. So what is a good X-ray? This a circular inlet view, symmetrical obturator foramina, and a teardrop. So these are the key landmarks, and most importantly in these two lines, ilioischial and iliopectineal lines, in case of acetabular deficiency, we operated previously for fractures or in CDH. So biomechanical restoration principles is a primary goal. So how do you do that? Have a circle drawn on a simple, all these are based on X-ray or a PACS. So simple, you can do it on your mobile phone as well. Draw a center of the circle of the femoral head, long axis of the femur, perpendicular to that center, and the long axis is your femoral offset, and vertical offset is interischial line. I mean the the line drawn touching from the base of the descent trochanter and the distance of the center of the head from that. And similarly on acetabular side, you have acetabular offset. So, as I said before, most importantly, look for your teardrop. Teardrop is one go-to marker pre-operatively for your placement or acetabular templating plan that will decide the height of the cup, and your ilioischial line decides the medialization of your cup. So it starts with the templating of a cup, positioning like this, and then mark a center of that. That is the center of rotation of the acetabulum. Then go to the femur side. Of course, I am talking of the uncemented implant, uncemented hip replacement. Fit and fill in the proximal hip, and most importantly, this has to align to prevent the valgus and varus stem positioning. The center of the femoral head lies there. So whole idea is it has to become coaxial. I'll come to that in the next slide, where you can see this is the acetabular center of rotation and this is your center of rotation of the femur. So once you reduce, that is the ideal center of rotation of femur. So this, if it is placed lateral, once you reduce, you will achieve a lengthening. But if it is desired, which we have got it from pre-operative measurement of limb length discrepancy, then that is okay. But otherwise, there are other various tips and tricks to correct the shortening. So use the longer length, up to 4 cm shortening we can achieve without any neurovascular deficits. So how do we do that? We do it with a longer neck length of the prosthesis, higher neck shaft angle, that is a valgus, then higher neck cut. On the contrary, to correct the lengthening, all are on the reverse side. So the planning, of course, happens in, there are 3 different ways of doing it. Many of my senior colleagues will be knowing we used to do on acetate templates. But here the problem is acetate templates are having a fixed 15 to 20% magnification, but getting the X-ray to that magnification was a lot of difficulty for us. But with digital X-rays and packs, we can do it digitally. Of course, 3D planning and one good software is the TraumaCAD, which might not many of us can have an access. Of course, for difficult primary and complex revision, 3D planning would be helpful. What we look for in X-rays, again, a femoral morphology. My subsequent speakers will talk on this to choose the right implant. And what do you look for in acetabulum? Most importantly, you have to look for the inferior osteophyte and the medial osteophyte. In a degenerative osteoarthritis and in a protrusio, this matters most importantly so as to avoid either too much of medialization or too much of lateralization of the acetabular cup. So I'll come to 1 or 2 similar situations in protrusio. In protrusio, we have to be very wary of getting dislocated like a regular primary. Even with 360-degree release, we might not be able to dislocate the hip. In such situation, you might end up doing a in situ neck osteotomy, or you might very likely have a around fractures of the femur if you are hell-bent upon dislocating the femur. And of course, peripheral reaming has to be important, because unlike in other regular primary, you ream medially. In this case, if you start reaming medially, then you are very likely to perforate the medial wall. So peripheral reaming has to be kept in mind. And medial bone grafting only to build the medial wall. Another triangle is one I have just quickly rushed. This is when there is no teardrop visible on your X-ray. This is a sentence line, ilioischial line, just 5 millimeters lateral to that. 20% of that you will have an isosceles right angle triangle. Center of this is your center of acetabulum. Similarly, in CDH, we have to think of whether to place in anatomical center of rotation, or if the bone is not good enough, whether to accept a high hip center. So in the bargain, you will end up in having an uncovered cup, so you might end up in requirement of the bone grafting. So on the femoral side, of course, you get a lot of modular implants to correct excessive anteversion, which is a definite pre-existing pathology in CDH. In acetabular fracture, so always look for scarring and entanglement of the sciatic nerve, and most importantly, any deficiency if the fractures have ununited, and hardware obstruction if you are putting screw for the acetabulum. For prior fractures, you have to have a custom-made implants on the femoral side and look for any hardware, or sometimes if there is a thick callus intramedullary, you might find difficulty in entering the canal. So my standard, these are kind of a emergency drug card for anesthesia. These are the things which you will have to have most of the times to avoid some surprises. SS wire, cable, K-wires and screws. Cement, of course, when you have to change the plan from uncemented to cemented. These are advanced backup plans to have in complex primary situations. These are some of my cases. So finally, few minutes of spending time on pre-operative planning can definitely save you from untoward incidences or unexpected surprises intraoperatively. Thank you. Of course, I had too many slides. What I did when I came in the morning was to delete too many slides. So spinopelvic alignment has to be an important thing, and taking other joint x-rays also will matter. Just to fix up, maybe as I can see there are subsequent speakers will talk on that.
Okay. Any questions from the audience? Hope there are no questions. Dr. Hoskandi sir has clearly demonstrated preoperative planning and is very crisp and clear about different conditions and how we need to do the preoperative planning. Then I request the next speaker to come on, sir.
Thank you. Now I will call upon Dr. Anand Galgali to speak on key preoperative consideration for THL.
Good afternoon, everybody. Respected chairpersons, moderator, at the outset, a big thanks to the organizers, Srinivasa in particular, and KOPPAL Orthopedic Society, President, Secretary, KOA. Nice to be here. The dreams come true for our Secretary and President who are trying to organize this since 2 years. Yeah, now as we talking on the preoperative consideration, I am not going to touch on the per-operative like the previous speaker, Rosandi, has very clearly said about the planning, preoperative planning as per the X-rays and the offset and the limb length discrepancy. And so this is not in the purview of my talk. I am going to talk about how do you decide whether you are going to operate a patient. Suppose a patient comes to you saying, I want to get a total hip replacement done tomorrow. Are you going to accept? Or are there any red flag signs? Or is there any patient who should take some time to operate? Because most of us are in a hurry. Suppose a patient comes to you and says, tomorrow I am ready for total hip. Are you ready to go ahead and do it? So what are the pre-operative considerations? Apart from the planning part, the radiological part. So, whatever we decide has to be evidence-based. One for the postgraduate perspective. So suppose the patient says he's got sugar of 250 or something, we need to operate on it. So for all, it's not anybody's random decision as to what should be the sugar level before you decide to operate. We have several studies like this one. It's called the enhanced recovery of the surgery. This is a consensus statement was produced after going to 2019, after studying all the meta-analysis, after studying all the systemic reviews, after discussing with the world prime surgeons all over the world. So they have come to some consensus as to what should be the major factors that you consider before you take up a patient for surgery. There are a lot of factors, right from age, right from the etiology, right from the metabolic status, right from the lifestyle. So so many factors were said, and they have come to a consensus. They have produced evidence, strong evidence, moderate evidence, and their recommendation also. So as per this era's recommendation, they have stratified the risk of the patients depending on several factors. If the 2024 very nice risk assessment score by Sharma, Bernard Sharma is called. A patient comes to you 70 years with intracapsular fracture femur. Whether you are going to do a heavy replacement or a total hip. So this is a big question in almost all surgeons' mind. If it is 90 plus, 80 plus, there is no doubt. Suppose it is between 60 and 70, or in the age group, we can go for a total hip. But somewhere in between, again, this score helps definitely. So we are going to go through this. So according to this era's smoking and alcohol, suppose the patient is a chronic smoker or alcohol, smoking in Western countries, they say you have to stop smoking for 6 weeks before you take up for surgery. In India, it's a different thing. We hardly give much importance to smoking and alcohol because we know it's difficult to make them stop and wait for 6 weeks. And suppose the patient has got anemia. What is the anemia that you do? Most of us say it's okay to do a total hip. And what are the metabolic parameters? Sugar, HbA1c. Usually it is better to have a multidisciplinary approach, that is cardiac status, that is hypertension, diabetes, everything to be investigated before you take him up for surgery. This is the list which I follow routinely before the patient gets admitted, so that once after admission the case should not get postponed. This is the thing, all of us do this, right from prothrombin time or the serology or the cardiac status. So, sugars, I am telling you as per evidence, it's not my thing, less than 200 is okay. That is what the evidence is, literature says. HbA1c has to be 7.5 to 8%. HbA1c. Anything more than that, try to get it under control. The sugars, more than 200, don't you even try to do a elective surgery. Hemoglobin up to 10, minimum 10 grams, anything less than 10, give them iron, give them transfusions, and then take up for surgery. If they have urine, routine is a must. If not just routine, culture is a must. If they have certain number of colony forming organisms, you have to postpone. And if it is asymptomatic, 1 dose of ciprofloxacin 1 hour before surgery is recommended. The patient comes with rheumatoid arthritis. And these are some burning questions all of us have in our mind. Do you stop the DMARDs? Do you stop methotrexate? Do you stop HCQS? Do you stop SAS? So this is the latest I would like to share with you. Any DMARDs you need not stop. You can continue. Even the day previous to surgery, you can continue the methotrexate, you can continue the HCQS. Steroids also you can continue. And leflunomide, you have to withhold for 2 days before the surgery. And anything biologicals have 1 dose has to be stopped. The TNF alpha antagonist. And I think somebody has told about infection prevention. Dental and urinary infections have to be ruled out. skin assessment over the fracture site or anywhere near the knee, put anywhere near the operative site should not be taken for granted. Those have to be treated. We usually give a scrub of betadine and alcohol pre-surgery. Most important is we have to inform the patient, educate them about the procedure that we are doing and counsel them. In Western countries, they have a social welfare department who talks to the patients, their relatives, they see what are the backup for the rehab, what is the type of bathrooms they have. They visit the houses also and check whether there is a bar for them to get up from the squatting position, the commode they are using. Everything has to be told to them free of, because these are all the free of considerations I am discussing in detail with you. The most important is the psychological and social assessment. Like what was the preoperative mobility before surgery, what was the limitations of daily activity, what was the baseline. If they are bedridden for 1 year in a decubitus position, we just don't be in a hurry to go and replace a fractured hip, because they are going to dislocate the next day. So these background, social factors and functional factors have to be taken into consideration. And is there anybody to take care of the patient before surgery? This should come as a routine. It's not just the surgery or the rehab that is important. The counseling part and the education part has to come as a routine, and the patient should know what to expect after surgery. You have to tell them that you cannot squat on the ground, you cannot sit cross-legged. Suppose they are farmers, suppose they have to go into the fields, then those things they have to be mentally prepared post-surgery. Some of the things, there can be a limitation. Antibiotic prophylaxis, all of us know what to do. Usually I give 1 dose pre-op, and about, in our setup, it's about 5 days post-op, I have to confess that I give. Antithrombotics and blood thinners have to be stopped. But be careful. I have burnt my this thing. Aspirin can be stopped 1 day before, anything clopidogrel and has to be stopped about 5 days before the elective surgery. DMARDs can be continued. You have to make assessment of the renal and the immunosuppressants. And I don't know how many of you give Clexane or antithrombotics after surgery. Anybody gives very routinely? All patients? All patients? Yeah. I don't give. I have my own protocol. Only those who are really indicated, I give. I got certain fixed criteria. This is about antibiotics. We do screen for MRSA carriers, or else 1 hour before surgical incision, and then 6 hours later, 12 hours, and then for 5 days oral after discharge. More than anything, this is a strict no-no. This was taken last week in our hospital. It's a teaching college. OT discipline is the most important thing. No overcrowding, and then the people who are going to enter the OT or exit from the OT has to be restricted, and there is no compromise on this. In summary, so it is a multidisciplinary, you know the cardiologist, you know the physician, you know the physiotherapist, you know the nursing staff. So it's called, anything which is not within the normal limit, it's a compromise, and this is called the optimization of the compromise. You can't bring it to full normal, you have to optimize the compromises. So every individual assessment has to be different, and education and counseling does improve the outcomes post-operatively. Thank you very much for this. These are the references. Questions I would like to answer them.
So I would like to ask a question. How long, after patient has taken intraarticular steroid injection, how long you want to postpone the knee replacement for the patients?
We have a very good study. Okay, any intraarticular steroid, they say you should not do the surgery for 6 months. And any OP procedure, Usually they say don't do for 9 months. We have a study.
Yes, sir.
Okay. And I see. I feel that anticoagulants post-op. What I feel, my cardiologist also feels the same way, and we have some evidence that the complications of thrombolytics or anticoagulants in an elderly person is more than the benefits. So we usually put them on aspirin at the time of discharge. As a medical legal, we make a point, say that in case they get embolism or so, as a thromboprophylaxis, we have put them on aspirin for about 6 weeks. But having said that, we do not hesitate to give anticoagulants in patients who have history of deep vein thrombosis, who have history of pulmonary embolism previously, who have history of malignancy, yes, who have obesity, BMI more than 40, yes, where the surgery time extends more than 2 hours. Again, it's indicated. So there are some conditions like this, and who have been mobile in the bed. Most of our patients start walking the next day. But if there is any reason, if we delay the mobilization, then we have to do that.
In case of urinary infection, you want to take second culture once you give an antibiotic. How long will you wait?
Okay, one thing is symptomatic, other is asymptomatic. Symptomatic you cannot do obviously. There is fever, chills and dryness. Second thing is, if there is a definite growth in the urine, any bugs you are able to identify, depending on the culture, you start them on antibiotics. At least I think you should give it for about 6 weeks. We wait for 6 weeks till the CRP and the other metabolic parameters come down, and then I think we should be able to do it.
Second culture will do or?
Yes, yes.
What about routinely hepatitis C? Will you advise?
Yeah, I visit 3 hospitals. One hospital insists that it has to be done. I don't like to do it. I just do hepatitis B and HIV.
Actually, the patient is on anticoagulants like clopidogrel and phosphate.
Fracture, if a patient on anticoagulants develops fracture like femur, that's the question. Correct? Yeah, there are some emergency procedures which we do overlook. Like in a fracture like femur, we don't wait. We don't wait for 5 days, stop it and wait for 5 days. Because the best time to fix a fracture like femur is within 24 to 48 hours.
If it is a replacing case?
Pardon?
If you are replacement, not fixation.
Replacement?
Yeah.
Yeah, I'll tell you. The only problem is, I don't have any problem because we get the blood or blood products ready. The only problem is with the anesthetist who refuse to use spinal or epidural. They change over to general anesthesia.
Screening issues. In case of osteopetrosis and pregnant diseases.
Yeah, we have had one or two cases, but I think there are other speakers who are going to talk about it. The main problem is, as you said, finding the canal in the right direction and the reaming part. It is an issue, but we have to plan it before, and we have to get all the equipment ready. Usually I keep for the femur, I keep that, what you do it in the trauma, the guide wires and the reamers, for the isthmus part to be reamed. That's the most difficult part in osteopetrosis or cases where there is a medullary sclerosis. So that's the only thing. And in the acetabulum, I think it will be a little more hard than usual.
Thank you. I think we'll call upon next speaker.
Thank you very much.
Thank you, sir, for your thoughtful opinion. Next, I invite Dr. V.V. Patil from BK
Koppa Specialty Hubli to share his insights on decision making and how to choose an implant.
Everyone, yeah, we already had 2 talks on the similar topics, but I thought we have to, once you are being given an X-ray in your OPD as a postgraduate or a consultant, always it comes to decision to take on the spot. You will not be allowed to wait and take a decision for you whether I have to operate you or not operate, what implants, the cost. That is the scenario everywhere. So you have to take decisions as early before going into the operation theatre in the OPD consultation, whether you are going to operate and the price costing, the implant choice, whether you are going to operate or not operate, the decision will be on spot. So you have to be mentally ready of what your knowledge is to the present trending scenario. The consultants around you or Bangalore or metropolitan cities would have given a choice. The patients coming to you will have already had an opinion coming to you. So this becomes a very important to take decisions. So the right implant choice today decides the patient's mobility for decades. It's not going to be a day one you fix a fracture, it's going to heal within 6 weeks and not going to come back. The replacement is where they're going to come to you for decades. Even the revision, if you are a young surgeon, you might get your revisions back in another 15 to 20 years. So the decision lies on decades, not just 1 day or 2 days. So choose the hip right. Every hip replacement is more than a surgery, it's a lifelong partnership between the patient and implant. The choice of fixation, bearing surfaces, system design determines the durability, function and the revision design. Thoughtful decisions making outcomes. So avoiding early failures and ensuring decades of pain-free mobility. So with this, I'd like to discuss about the implant choices, what are the patient-specific factors, implant-specific factors, cemented versus uncemented with evidence, bearing surfaces, register evidence based, and Indian and imported implants, what we are still ahead of talking now. Templating softwares, future trends, and practical algorithms. So you have heard so much, so in 5 steps I would like to give you algorithm where you can take your home concluding messages. So this is a present scenario where from 1915 till 2005 you can see Smith Peterson, Wills, Morse, Judet implant, Charles, etc. Thanks to many improvisation of etc. Charles came out with types of cup being produced till now. Presently, whether AI based to anatomical implants are available. So this is where the development of hip has gone through. So once you are in, these are there in invariant which are available now. So you can see the type of cups. So there is no perfect implant till now. If there are so many inventories available, so there is no right implant right now. So everything has to be patient specific and your right choice and what patient you are going to do. So these armamentarium, you should be knowing what each implants are, what they can do and what is the right to fit in. So these are the cups available, from the cemented cup to the revision cups, from the cemented cups to liner constraint cups. So from the stainless steel head, cobalt chrome, ceramic, data ceramics to dual mobility and prime Mobilan cups. From your proximal fitting to distal fitting and revision cups with trabeculometals are available nowadays. So why implant choice still matters today? It's the operation of the century. Despite advanced implant failures and revision burdens remains costly. So still patients can't afford a revision right now. So registered data still shows there is analysis of 10 years failure, 2% in cemented and 2.5%. These are in high volume centers. In low volume centers, hip replacement revision is seen around 8 to 10%. So revision, like low centers are doing less than 100 hips per year. You have to consider yourself still a low hip center. So as many of the speakers have spoken, I would just like to add 2 things in this, which is age, patient specific factor, that is age. Above 65, always keep in mind a cemented has to be your backup, and fragility fractures, if you are doing uncemented, always be careful that you are going to fracture in 10% of the patients. If you are trying to go more than 5 or 6 numbers of the hip, in femur or trying to bang uncemented cup above the 65, you're going to have a fracture. So always, if you feel a bit of loose, a bit of wobbling in the acetabulum or the femur, right away go to a cemented. These are, I'm talking only directly to decision-making type of statements. So next, as bone quality, dose classification and DEXA. I will discuss on the next slide on that. And we have to talk about spine mobility. All spine and pelvis mobility is a very important topic where once you see a patient walking, if he is walking with a huge lordosis, if he is a gymnast or he is a sportsman or he is being operated for spine, if you look at him abnormal walking, stiff gait, always consider that you would need a dual mobility backup in your operating. So you have no chance of missing these implants before you go to the OR once you think that these patients are going to give trouble in the OR. So risk management, as you are thinking of cemented organ, always tell your anesthetist that once you are implanting a cemented hip, the chances of a cement emboli or of embolus are going to be there, and always take a written consent in your that specific for cement syndrome, because that patient is not been explained of cement implant being put, has been a litigated proven fact that can be put on a liability. So as you know, dose classification type A, type B, C, these are most classically seen. One is you can see a flute type, a tubular and a cone completely open up. So this, try to remember this marking diagram. So you can see a V, this is how your cemented stem is going to go. So once you remember, you try to put that V inside any X-ray, you see that uncemented implant is going to fit in that. So if you feel it's going to wobble somewhere, then you are going to go into a cemented implant. I'm trying to simplify things because to get into complex is going to be very high. So if you feel that it's not going to fit in the 10 centimeter below, you would need a diaphyseal long stem implant. And if you are trying to see the last third part where you're going to see that proximal fit implants, if you can see it's wide, none of your cemented proximal implants are going to sit there. So all the presented uncemented implants are all proximal fit implants. So if you see wider gap there, so none of your implants are going to sit there. So you need a cemented implant for this. So DEXA if available, you can get it done. Anything above 1.5, that is T-score above 1.5, you would need a keep a backup of cemented implants. So presently available uncemented implants, I'm trying to say because it's all are proximal fit implants. Until unless you're going to go for a revision which is diaphyseal, when there is a proximal IT fracture or a revision hip, you're going to go for a type 4, type 5, type C implants are only meant for revision, not for primaries. So don't try to put a uncemented stem for primaries. Try to do before proximal fits. These are easily available, which are presently in the market, are trying to be proximal fitted. So uncemented option from Chanlace to the present, the best implants of Depus and Exeter or Striker. These are the present available standardized cemented hips which can fit nicely central canal, can be fitted into any type of canal possible. So cemented versus uncemented, you can see the fixation models is a fast in cemented, uncemented. Longevity has been shown. So register-based evidences for cemented performs best in older and fragility cohort. Cementless favored in younger patients. Overall survivorship is both high when indicated matched. So younger patients uncemented, elder patients cemented, both survivorships are equal. Present and you can see stems resides perioperative above 70 years are very high in uncemented. Be careful when you are using uncemented engines. So bearing and longevity. So this is a main discussion. Always patients ask, we are going to put a ceramic dual mobility, or you are going to put a poly cup, highly cross-linked poly, vitamin poly, X3 poly. These are the statements the patients nowadays will ask you right forward in the first question. So you should know what we are talking about. So once you use a ANB, because the Indian implants highly cross-linked poly, still many don't have patents, they are using regular polys. So be careful once you are using a lower quality implants. Highly, if they are having the cobalt chrome with a poly, you can see the wear rate. Cobalt chrome with highly crisped poly, the lower wear rate. And secondly, with highly crisped poly with ceramic, and ceramic have less fragility rate. So you have to be knowing on which the cost of implants you are going to put. So to conclude on that, highly crystalline poly have shown long-term results and markedly lower than conversion rate. And headliner ceramic is always an option, and oxygen zirconium heads have shown lower wear rate as compared to anything. And dual mobility present consideration reduce the dislocation, and even with a new polish has a better rate. So complications are many, but most common complications is dislocation in total hip replacement. That still amounts to 1.3%. So others are different, but I'll try to overall talk on dislocations right now. So most common is a surgeon's mistake, where they ideally miss position of the implants. So other things like spastic neurovascular disease, blood alcohol, have abuses always, and prior spinal fusion or fit pubic angle. So these are the range of motions you have to test intraoperatively. High flexion, extension, internal rotation, external rotation. Just not by seeing that your external rotation doesn't dislocate, don't let it. Anti-dislocations because of over anti-motions have been seen intraoperatively. So these are, you can consider once you don't go into spinopelvic angle interface way. 40 degrees is your benchmark. So once these are high hip users or the spine users, so anything the angle is above 40 degrees, think of using a dual mobility. Presently, the constrained hip implants are not so much available, so dual mobility works better in these. So spinopelvic angle, always just remember this 40-degree angle. Once the spine is stiff, the pelvis is moving at 40 degrees above, so the chance of dislocations are very high. So considering the standard bearing to modular, the dislocation rate is reduced by 100% from 3.1 to 1.5% in dual mobility. So Indian versus imported implants. Imported implants are long-standing, international standards are there still, and it is advanced technology. Lack of scientific evidence for Indian implants is a major challenge. Disadvantages, its higher cost, anatomical mismatch of imported implants. So this is about the Indian implants, what sizes they all have. And the best is templating software. It's a mandate to have a templating software in your CAD because all are using digital express. So you get to know free of which cup you are using, stem you are using, the sizes, ChromaCAD, and many companies give them free company software. Kindly ask your company's guys to give you software in your laptop. So templating is evidence-based medicine and has shown better results if you are doing a templating. From all the possible CT, MRI can be done pre-operatively. So 3D printed implants are available on many other cases. AR and robotics is gaining a very high rate of recognition for marketing purposes, but some results for unindicated complex cases, they are shown to show good results. So these are some studies which you have to know present scenario, where one stage or two stage hip replacements, they always put 2 weeks of gap is needed. And hemiarthroplasty or THR has shown to be proven better results. So cemented versus dual mobility, even cemented dual mobility has gained good recognition. These are all studies for 2005 which are taken a very good importance. AI assisted has shown to give you a better implant choice. So step 1, assess the bone, age above 70, below 70. Step 2, by default ceramic and auxiliary based on your primary choice. In younger and high activity, consider ceramic on ceramic. Elderly, metal on ceramic, the cost effectiveness is better. Step 3, always see the spine mobility. Spinopelvic stiffness, always shift to a dual mobility. Templating becomes a mandate at present scenario, and revisions try to keep all the environment okay. So take home message, cementless ceramic, highly placed gold standard in young patients. Cemented stem remains best for elderly osteoporotic hips. Dual mobility is a game changer for instability risk. Digital template and 3D is essential if available. Always match implant to the patient, not other way around. Thank you.
Any questions from the audience? If there are no questions, thank you very much. We call upon next speaker.
Thank you, sir, for your balanced perspective on the topic. Now I welcome Dr. Anand Gargari to share tips and points on cup placements.
Chairpersons, I'd like to give you some tips and tricks on the placement of acetabular cup replacements. I think it is very important because the maximum number of complications, loosening and revision happen because the acetabular cup zone. This is a very interesting topic, and feel free to take photographs or whatever I would like to share it with everybody, because I have got three things in it. Every position, every slide, we got the per-operative picture overlapped with the bone model and also how you see it in the X-ray. So you can make use of it. See, we have been discussing the offset, the leg length, the center of rotation pre-operatively, but nothing works on the table. You don't know where is that teardrop. Can you make it on the table? You cannot make it. You don't know where is the center of rotation. So there is a lot of fallacies when you are actually operating on the acetabular. So for this reasons, fear of dislocation, fracture, impingement, we definitely need to know how the acetabular cup has to be placed. Okay, and what is the cause for the error in placing the acetabular? The high BMI, fat ladies, fat patients, very difficult. You need 2 or 3 assistants to retract. Inadequate exposure is another reason. Anatomy can be different in different persons. The guides that the companies use, I have never found a single of them useful on the table. To know the anti-version, or to know the offset, and also the improper patient selection. So, by and large, these are the guidelines, gold standard as you call it. You need to place it in 40 to 45 degrees inclination, 20 to 30 degrees anti-version, 15 degrees humeral anti-version. Again, this is all general guidelines and theory, but how do you exactly do it on the table? I would like to share my experience. 90% of them do it through the posterior approach. Whether it is posterior or anterior Smith-Patterson, the key is we need a 360 degrees exposure of the acetabular. Okay, this is the posterior approach, skin incision, and then as usual, all of us do this. And this is where you need to identify the tile. You need to see this tile, you need to see the anterior list, and you need to see the superior. And here, sometimes we put the spike here, and the space between the anterior leg and the this is the danger zone. Be careful here. Because all the neurovascular structures come here. First thing is you need to go into the floor. I will tell you later the practical point, what you have to do, how you have to read. Okay? Coming to the position. This is the most important part of the surgery. You put one anteriorly, you put one support to the pubic symphysis, and back you put the sacrum. You should see that the hip goes into flexion, extension, abduction, all in a free way. You don't have to struggle after breaking. So in this position, ideally, if you are in the correct position, this has to be the 45 degrees reading to the body. This is the body, this is the legs, this is the upper part, this is the groin, this is the overlap or the pelvic model. This has to be 45 degrees. And as you see from the foot end, the femur has to come 20 degrees anterior. But most of the times, and how you see it on the X-ray, this is the posterior border, and in the lateral view, you see this is flush against the anterior part. Okay, there can be a little overlap on the posterior, acceptable. Okay. This we will see when you do wrong reaming or in a different position. What happens if you ream more than 20 degrees or less than 20 degrees? So many times all of us have faced this issue. This is a normal. This is exactly the pubic symphysis, anterior peripheral. When it goes forward, the patient on the OT table going anterior, this is the greater tuberous. So when you start thinking that you are leaving at 20 degrees, okay, when it has rolled forward, your angle will be wrong. right? Then the cup becomes retroverted. Okay? So you can see this is the anterior leg. This is come forward to the anterior leg. Okay? Here. So how do you see it on the X-ray? This is the lateral view. This is the anterior, in line with the anterior column. So when you read, when your body is rolled forward, this comes a little front. Whole cup is retroverted. Here, in the correct AP, this is the posterior leg and this will be the anterior. Here it will be exactly inclined, 45 degrees. This is not right. You see, if you think that this is the correct X-ray view in the AP view, this is not. This is the retroverted cup. This is the correct. It has to be a little oval if you have done it right. And what happens if it rolls back? This is a normal. This is gone back. You can see that? This is the gap. The whole body has twisted to the back side. And you start dreaming, thinking that you are at 20 degrees. Okay? And the whole cup, instead of leaving here, you will be another 20 degrees will be adding. It's already rolled back. And the whole cup becomes anterior. So this, there is a proud anterior column. This is a normal one. This is excessively anterior. So these corrections you have to make once you realize after draping that the whole body has shifted front or at the back, you have to make a little correction. So this has become more anterior. The cup has gone sunk into the anterior column. You see that? It has come here, it has gone here. Again, inclination. The cup has to be on the tal. This is where transverse vestibular cup. Suppose it is more vertical, it is away from the tal. This vertical is not accepted. So what happens if it is vertical? You will have more loading on the edges and this is going to happen to the line. So practically what you do, how you avoid this and how you go ahead once you know that what is the position of the patient. Step number one is you have to find the medium one. Usually there are a lot of osteophytes just above the tal. You have to take it out. If you don't take it out, your cup will be lateralized too much. So take a small ring, smallest you have, 44 size, and go vertically down. Go vertically down and take out all the osteophytes, find the medial end of the sternum. Take out all the fatty tissue there and the ligamental fluid, everything comes and you have to sit on the base of the sternum. And as you progressively read the increment, then you come down to that 45 degrees flexion and 20 degrees anteversion. The correct appropriate inclination anteversion. Once you go off the sides. Once you get a proper fit, usually the fit is between the anterior column and the posterior column. But never take the fit of the bottom. It's maximum the fit will be between the anterior. That is when you know that you have got the correct size. And that is the size of the cup that you have to choose. Then you put in the liner, then you take out the osteophytes, and just check the locking mechanism. So in conclusion, this placement is very, very important for the long-term survival. So you definitely need to know the surgical anatomy and follow the basic principles. Positioning on the table, before draping, after draping, and correcting the subtle angle, flexion and anteversion will definitely help you get the right alignment with the cup. Thank you very much.
Any questions?
Sir, to prevent patient rolling over, can you put the post over the anterior leg spines, anterior post over the anterior leg spines?
We do that. We have a lot of things. Many times that side support, it is not actually correctly holding the patient together. Many times we use sandbags, we use 2-liter saline bottles, we use that bolsters. So many adjustments have to be made. The ideal fit will never be there.
Thanks.
Any questions? Not good.
This is an important pre-operative consultant. Surgeon is suggesting that operative surgeon should be there at the time of dosing the patient. Especially in these patients, if there is a small error in dosing, it leads to wrong placement of the cup. And especially when you are doing the angular responsibilities and distressing, it is very much important. It's a very important consideration that has to be done.
I agree 100%. I mean, we have to be there personally, we have to position the patient, we have to see the knee joint, the lengthening and all, the opposite knee has to be in place, knee and ankle and the foot, to check the limb length at a later stage. Everything has to be correct.
We have to have the mental picture of the assessment of the leg, positions of the knee, especially to avoid the leg length discrepancies, and also be aware of thin patients. In the leg, the operating leg goes into aided action, and if we're checking for the leg lengths, comparing the opposite side, then if you match it to that, we'll end up actually lengthening because of the apparent adduction than the leg occurs.
Very, very important practical point.
In very high volume centers, surgeon will be knowing whether he is operating on a male patient or female patient. That's what happens in most of the high volume centers. After surgery, patient will be knowing it's a male or female.
Okay, if there are no questions, we call upon this speaker.
Thank you.
Thank you, sir, for your valuable insight on the topic. Our next speaker, Dr. Shankarlika Sajjan, sir, from KS Hospital, Koppal, will discuss about stem placement and also share few tips and tools.
Good afternoon to all, and first of all I want to convey many thanks for KOPPAL Orthopedic Society and ICF for giving the opportunity to talk. And today I am going to talk about stem placement kits and bulbs. So to get a proper stem placement is critical for long-term teeth function, and to get that one key consideration is to see the anatomy, biomechanics and the implant device. The aim should be get a stable fixation and proper leg length and to achieve optimal biomechanics. In order to achieve the aim, we have to do a proper pre-operative planning as previous speakers spoken about the radiographic templating, and we have to assess the femoral canal size and shape, and we have to assess the anticipate leg length, the discrepancy, and we have to identify the femoral function and offset requirement. So pre-operative planning, as previous speakers say about ideal X-ray distillation we have to take, where the topic should be 3 cm distance from the peeling symphysis, and obturating foramen should be in the equal shape. And leg length we have to assess by passing a line which connecting the two clear points, or can pass from the base of the obturator foramen. From there we have to pass take a perpendicular line which attaches to the set protector and assess the distance between the two affected and normal limb, and thereby we have to assess the limb length discrepancy. And coming to the offset, that is the horizontal offset and vertical offset. And horizontal offset will take from the center of the femoral leg to the canal axis, whereas vertical offset from the center of the femoral leg and imaginary line which attaches the base of the obturator initial tuberosity. And coming to a femoral canal and suggest and shape, based on the dose classification, we can classify it into type A, type B, and C based on the quality of the bone and diameter of the canal. Type A is where there is a deep cortex and narrow canal which look like a flute shape. As a type B, there is a moderate cortex and moderate canal diameter. As in type C, we can see that there is a thin cortex and wider canal. And based on this, we can assess whether we have to go for cemented or uncemented stem, whether we have to go for serial weaving or customized stem. These are the pre. And one more is the canal plane index. We have to assess the canal width. We have to assess the canal width 20 mm above the left side protractor. We have to take the canal width of the metaphyseal region, and one more canal width we have to take at the isthmus level. Based on the canal flare index, we have to know that whether if it is index CFI is less than 3, we can get a stroke pipe canal, and if it is 3.34 to 7 and normal canal like type B dose classification, and as more than 4.7 like fluid canal, it's like type A. So this will help in designing, assessing the stem size and designing the implant. This femur templating panel to sum up, we have to assess the stem size. The stem should fill the canal, it has to fill the metaphyseal part. Most of the regular THR we use as a metaphyseal fitting, fitting stems, and we have to assess the offset. Then we have to assess the varus or vulgus alignment. And neck cut to determine the pre-templating neck cut is helpful in getting a functional outcome. And type of the stem based on the dose classification, we have to use cemented or uncemented. Coming to the surgical approach, once we did a pre-operative template everything, then we have to surgical approach based on the surgeon preference and patient anatomy. And most commonly used approach is posterior, which is where we get the easier femoral exposure, whereas the anterior and anterior is technically demanding and muscle sparing, whereas lateral reduces the chance of dislocation. So once we expose the femur and we have to then determine the neck osteotomy we have to do, we have to use the pre-templating. Then once we did that osteotomy, we have to assess the tooth canal entry point, or we can determine piriformis entry point. That is a important step in making the canal entry. So once you made a canal entry, then use the box chisel or bud to open the canal, and you have to direct the canal reamers or anything in the posterior medial to avoid lateral cortex perforation. So once we started the canal finder and everything, and we have to do a broaching technique like the sequential. We start from the small rasp or broaching, and to go on like increases the size, and we have to each sequential broaching. We have to follow the femoral axis and don't go for hard malleting. You have to go with the gentle mallet taps till you achieve the axial and rotational stability. As version control, this is an important step in making the. We have to achieve the 10 to 15 degree of anti-version related to the femoral organs. And usually this will be taken in a lateral position where most of the posterior approaches will do. Anti-approach where you have to keep the hip in slight flexion and the knee in an anti-degree flexion. You have to do the rasping or broaching parallel to the femoral condyle axis to achieve an anti-version of the femur. So once we did a serial broaching, then we have to try for a trial stem, and we have to assess the leg length compared to contralateral side, that is a shortening or anything. Then we have to assess the offset or adductor tension. And stability test is like we have to do a flexion internal rotation to assess the dislocation bricks, and extension and external rotation. This will help in checking the posterior stability. So once a trial implantation, then we have to do with the implant insertion. If it is uncemented, we have to achieve the firm axial and rotational stability till achieve the chapter sound, and avoid undersizing or oversizing. Undersizing will cause loosening of the implant, and oversizing, the chance of fracture will be there. Whereas in case of cemented stem, you have to maintain the cement mantle between the stem and the cortex are 2 to 3 mm, and use the cement restrictor and retrograde cement gun. Insert the stem centrally with the pressurization and hold until the cement sets. So key insertion in the intraoperative is avoid varus mala alignment, prevent the fractures, and avoid the stem subsidence like don't go for undersize or oversize. At least if you have a doubt about the approach or stem orientation, stop it and take the X-ray before going for final implantation. So in the intraoperative X-ray, we have to assess the femoral cut level and stem placement, whether it is in varus or valgus, and we have to check the offset from the lesser trochanter to the shell porosity. Once you confirm and satisfy the reduction, then you go for final implantation. Post-operative evaluation, we have to do vertical offset and limb length. This will assess by drawing a line base of the ischial tuberosity, and we have to check the distance from the lesser trochanter to the ischial tuberosity. Both should be equal. If less than 1 cm is acceptable. If it is more than 1 cm, limb length distance will be there. And check for the offset from the lesser trochanter to the lateral border of the ischial tuberosity. Both should be near to equal. And coming to the varus or valgus stem placement, we have to draw a line from the tip of the retrograde to the center of the femoral leg. It should be horizontal line. If the center of the head is below the horizontal line, we can consider as a varus position. If it is above that, we can consider as a valgus position. And assess the femoral stem and cortex intact. It should be press fit, and it should be 80 to 85% of the stem should cover the metal canal. So in case of a difficult anatomy or difficult anatomy, in case of a narrow canal, use modular or tapered stem, or in case of a narrow canal, you can go for a serial weaving instead of going for a broaching technique initially. Then in case of osteoporotic bone, go for cemented fixation, which helps in getting a better fixation. As in dysplastic hip, you have to go for custom stems or high offset designs. In case of previous deformity, then careful version and leg assessment you have to do in a pre-operative not to prevent intraoperative complications. So summary is accurate stem placement ensures stability and longevity, and pre-operative planning is a crucial thing. And pay attention to the alignment, version and roll stop. In case of roll stop is not good, we have to do a cementing, and tailor approach and implant choice for the patients.
Any questions?
Any minor variations in placing the stem in cemented or uncemented hips?
Placing the stem should be in the center. So whether it's cemented or placing the stem should be central to avoid varus or valgus alignment. In both we have to achieve the center of the stem. Whereas in case of a telescopic or femoral stem, femoral canal is not in a proper anatomy like more anteromedial or anterolateral in Indian population, we can go with the serial weaving and followed by stem placement. So cemented.
Thank you, sir, for guiding us through this topic. Now I invite Dr. Chetan Jatareddy from KLE Suchirayu Hubli to share his insight on dual mobility cup pen NACM for stability.
Good afternoon, everyone. I hope all of you have paid a keen attention and followed the speakers that have spoken this afternoon, who have eloquently shared their words of wisdom with regarding to how to plan and execute a total hip replacement to get a best outcome for the patient. If not, then you will end up listening to talk like mine, which is the problem of instability in a total hip replacement. So the topic that is given to me is about the dual mobility cup, whether it's a panacea for instability. We all know that total hip replacement is one of the best surgery in terms of providing the quality of life following an intervention. It is next to cardiac bypass surgery as proven in literature evidence. However, what was supposed to be a beautiful outcome for the patient can become a nightmare to the patient and you if you don't follow the guiding principles that the previous speakers have mentioned. And one of the reasons you will end up in trouble is causing the instability in the hip. Now, what are the causes for instability? I'm going to talk about, and I'm going to talk about the history of dual mobility cups, biomechanics, types of dual mobility cups, indications, benefits, limitations, and the economics of using the dual mobility cup. Now, as mentioned by the previous speakers, the causes for instability in a primary hip replacement are multifactorial. Briefly, classified into patient factors, surgical, implant, and combination. The patient factors, the risk factors we know of, common ones are hip replacement in fracture of femur, neurological disorders, abductor deficiencies, revision surgery for failed hip fixation, tumor resection surgery, very high BMI patients. Surgical factors is malposition of the cup or the stem, surgical approach, and offset issues. From the implant point of view, if you don't put them in right, you don't expect them to work right. Now, what are the solutions for this? Historically, it has been dealt with like constraint liners, or by increasing the arc of motion by augmentation, or called flat devices used to be used in the past, the jumbo cups, and the current trend is considering the dual mobility constructs. So, what is the history of dual mobility cup? It was invented by a French surgeon and an engineer in 1974, and it involves two bearing surfaces, one between the shell liner and the polyethylene cup, and the polyethylene and the femoral head. It combines two principles, one of low friction principle of Charnley, and the Necki for our concept of larger diameter femoral head to enhance implant stability. Using the dual mobility also increases the jump distance. So biomechanics, as we are all aware of, between the standard cup was a dual mobility. In the standard cup, there is one articular surface between the femoral head and the liner. Whereas in the dual, as the name mentions, there are two articular surfaces, one between the external liner shell and the polyethylene, and the second one between the metal head and the liner. Basically what it does is it increases the femoral head diameter, which in turn increases the primary arc of motion before impingement occurs and levers the head out for the patient. So, what are the problems of using the dual mobility cup? There has been concerns about increased polywear. There are specific concerns called intraprosthetic dislocation, psoas impingement, periprosthetic fractures in dual mobility cups, high implant cost, which has a bearing in our part of the world, and we still don't know the long-term outcome of using these constructs in young active patients. Now, coming to the specific complication of intrapelvic, so intraprosthetic dislocation, it is the loss of articulation between the head and the acetabular capsule liner, which can lead to the femoral head becoming articulated with the metal shell, causing an acute setting of pain and limb shortening and excessive wear. To dwell into a bit more about the dual mobility cup, the original design was by a company called Surf, which had a 22mm metallic head articulating with a polyliner, which in turn articulated with a acetabular shell, manufactured from stainless steel and coated with a plasma sprayed aluminum. The newer designs, which have been necessitated, are made of titanium and hydroxide, replacing the aluminum coating. Flanges and modular shells were added for screw fixation to reduce the risk of aseptic loosening of the shell. Highly cross-linked poly enriched with them to improve the wear. Larger femoral head sizes to increase the stability, and anatomic designs to reduce the impingement or overhang. So the dual mobility constructs have been classified into 3 generations. The first one by the inventor, which has been termed as suprahemispherical cylindrical shape at the roof, which has a tripod configuration for fixation. It was made of stainless cup with alumina coating. The second generation one is a modification. Instead of tripod fixation, it's a press fit fixation. The plasma sprayed HA coating to improve osseointegration. The anterior and posterior metallic flanges are reduced to reduce the impingement, and chamfered polyretention rim. The third generation has been classified as spherocylindrical or modern hat or anatomical, based on the shape of the outer shells. These are some of the examples of the different types of dual mobility constructs that are available in the market. So what are the indications for dual mobility cup? In a primary setting, the most important indications are fracture neck of femur needing a total hip replacement, failed fracture in osteosynthesis, neuromuscular disorders, spinal pelvic disorders as previous speakers mentioned, cognitive impairment in patients who qualify for total hip replacement, tumor resection surgeries. Whereas in the revision scenario, it is recurrent dislocation, abductor deficiency patients, revision for any other reasons, be it aseptic loosening, periprosthetic fractures, etc. Now, what is the literature evidence? I'm going to talk about a few relevant and recent papers. This paper from 2021 looked at the dual mobility in KHR for high-risk patients. It was a retrospective review of 215 patients who were young, who had osteoavian and femoral leg fractures. The mean follow-up of about 70 plus months, more than 5 years. In those patients where the dual mobility cup was used, 2 patients had dislocated the hip following motor vehicle accidents. 1 patient had a traumatic femoral periprosthetic fracture, and 1 patient had an acute infection. Interestingly or encouragingly, no intraprosthetic dislocation or aseptic loosening were encountered. 90% of the patients labeled their operation as a forgotten hip, which has to be the primary goal in a hip replacement. Coming to the next paper, this paper classifies the management of unstable hip arthroplasties. The instabilities were classified as based on acetabular component malposition, femoral malposition, abductor deficiency, impingement, late wear, and unresolved etiology. Among these, the acetabular component malposition and abductor deficiencies predominate. This paper looked at a comparative study about the incidence of dislocation and periprosthetic fracture between dual mobility versus standard cups after primary total hip arthroplasty. It was a retrospective study involving 126 patients. 53 patients had a standard cup and 73 patients had a dual mobility cup. The interesting results was in the dislocation group, 83% of them had a standard cup and only 17% had a dual mobility. That means dislocation was 12-fold higher in the standard cup, whereas in the periprosthetic group, 26% had a dislocation, whereas in 74% in DN group. That is, periprosthetic fracture was 12-fold higher for dual mobility cups. Total hip, the other similar properties, this paper is from the Swedish arthroplasty register, which looked into the total hemi and dual mobility arthroplasty, and the conclusion was similar rates of dislocation after undergoing hemiarthroplasty or dual mobility. Patients with a neurological disease and not eligible for total hip should undergo hemiarthroplasty and not a total hip replacement. And those eligible for total hip could benefit from dual mobility. Similar paper which shows modular dual mobility articulation in primary and revision arthroplasty. It was a quantitative systematic literature review of more than 2,000 implants. They looked at 8 different manufacturers to analyze all modular mobility, dual mobility cups, to calculate the jump distance, compare the jump distance, and evaluate the dislocation rate. The true dislocation rates occurred in 3.2% of the patients in revision scenario and 0.23% in primary scenario. Now, can dual mobility cup prevent dislocation without increasing revision? A systematic review involving the patients included pursuing primary hip arthroplasty for a reason to diagnosis. The reported surgery from 8 studies, 5 of them were case control and 3 were registry studies. This followed that. The top 5, if you look at the dislocation rate in dual mobility, is significantly less. Now there are similar papers like this with anatomical dual mobility compared to that. Dual mobility cups in using the titanium implant, in cemented hips, all have shown favorable results for dual mobility cups. Whereas cost effectiveness in patients beyond 80 years, they have shown that it is beneficial only if the patient survives at least 5 years beyond the index procedure. Similar cost effectiveness study showed less than 55 years it is cost effective, less than 75 years it is cost effective and saving if the time horizon is more than 10 years. Now, looking at the topic, the name that was given, dual bearings are no panacea according to this paper, because in this revision total hip replacement they looked at it using the dual mobility cups, and they showed a 11% dislocation, knee dislocation using dual mobility bearings. They found out that the main reason was that lack of abductor function. So in summary, instability is a major concern. It is multifactorial. Current evidence favor use of dual mobility, but it is expensive. Cost effectiveness needs to be looked into. Long-term implant survival studies are scarce. Judicious selection is paramount. It's an option, not a panacea for dealing with instability. It is not, dual mobility construct is not a hammer, and instability is not just a nail. Thank you.
Any questions?
Given a choice of, say, hemi versus total versus dual, you get a patient of say 75 years with a fracture neck femur, acute fracture. I just wanted you to send a message to the board.
It all depends on the patient's physiological status. If he is a home ambulator, then it is a hemiarthroplasty. If he is an active person living, working, still doing the job, still enjoying the social life, sports life, everything, then age is not the factor. It is the physiological status of the patient that matters, that it dictates what he gets.
Okay, thank you. All the speakers.
Thank you, sir, for sharing your valuable insights. As this session ends, let us take an opportunity to felicitate our moderators and our chairpersons. I would like to call upon all the speakers of the session onto the dais.
ಟೀ
ಸನ್ಮಾನ ಮಾಡ್ತಾರೆ ಬಾರ ಟೀ ಅಂತಿತ್ತು ಲೈಟ್ ವಾಸ್ ಈ ಕಡೆ
ಲೈಟ್ ವಾಸ್ ರಾಘವ್ ಈ ಕಡೆ ವಾಸ
ನೋಡಿ ಸರ್
ಥ್ಯಾಂಕ್ ಯು ಸರಿ ಸರ್ ಸರ್ ಆನ್ಲೈನ್ ಏನು ಬೇಕಿದೆ? ತೆಗಿ.
So the final session of the day, we have with us Dr. Anand Galagi sir as a moderator and Dr. Puneet Chamkeri sir, Dr. Prasad sir and Dr. Gururaj Murugot sir as chairpersons. Please welcome onto the dais sir.
ಮತ್ತೇನೈತಿ ಯಾಕ ಮುಂದೈತೇನ ಅದು ಮುಂದಿಟ್ಟಿನಿ
Next, I invite Dr. Sarang Shetty sir, JNMC Belagavi, to share his insights on THR in acetabular fractures and THR in protrusio hips.
Dr. Sarang Shetty, Dr. Raghav Reddy. I request the presenters to stay tuned with the time because we are already running late for the banquet. I think we can take the questions at the end of session. Is it okay? Yeah, agree with Puneet in the sense that the speakers can also be role models for young postgraduates as to how to maintain the time, and within the set time they should convey the message and conclude the talk.
Yes,
Right?
exactly.
First talk will be on
very good afternoon. Myself Dr. Sarang Shetty. I am coming from Belgavi. I thank you all the people from KOPPAL and the organizing committee for inviting me and all the support and the kind of hospitality. I am really thankful to all of you. My first, I have two talks. One is THR in primary acetabular fractures, and doing justice in just 9 minutes is a big deal, but as this talk would be mostly for PGs. So acetabular fractures, basic classification is lateral and Judate. Joel Mata has done a lot of work, and begin with. So this is fracture of acetabular. Today in the morning we have learned 15 slide 4. This is fracture dislocation, and there is a neck fracture. This 52-year-old gentleman, and as we can see here, this is a seagull sign. If you can appreciate the chunk. Anyway, so overall incidence is this way. So as what we have learned, it will be the first we have to classify, and CT scan is nowadays mandatory. Otherwise, you can do Judate 45-degree obturator and iliac oblique views. So this is the basic, and if you see the head here is lying out, and this is the intra-op image. If you can understand. Anyway, so the challenges here are basically for the young people. If it is neglected, there was a classification given by one of the speakers for neglected fracture dislocation, and if it is more than 3 weeks, there is organization fibrosis, and the capsule becomes fibrosed. And if you operate and do a THR in those patients, the chances of dislocation are actually less. But in primary acetabular fractures where the capsule is not fibrosed, it is very thin capsule and already it is contused with the hemorrhage and hematoma, the dislocation rate is very high. So one should be very much aware of all these complications. Sciatic nerve injury, and there are usually 3 indications in primary acetabular fractures for THR, and one of them is the X-ray which I have shown, and another is non-reconstructible head where head could not be salvaged, and concomitant osteoarthritis where there is a pre-existing osteoarthritis where we want to give a sure shot surgery to avoid sequelae of a lot of surgeries. Those patients, and we go for primary THR, and another is this is seagull sign where the wall and other. This is one of the total lagging back approach was used. Usually multi-hole cup is a lot of armamentarium is essential. One of them is having a good purchase to avoid the dislocation, and the coverage is less because the posterior wall is also fractured. I'll just go through one of the videos which will help you understand how a lot of things are covered. So if you can appreciate the thing which I am pulling is short, this is piriformis, and now short external rotators. This is superior view already. This is just small video. So lying by approach. The 2 figures are my figures on the posterior side. This was just palpated the sciatic nerve and make you understand there will be a lot of if you do there will be a lot of bleeding, and you have to be well prepared. The anesthetist, hypotensive anesthesia, and this is how the closure might look like. So another video, because a lot of things have been covered and I made it a video based kind of presentation. This is how it looks, and that is the seagull fracture posterior wall, posterior lip. So you won't get a ideal coverage will be 100% of cup coverage, but it should not be less than 60 ideally. If you have a porous coated implant, then one can go for bigger coverages. There are 2 ways one can put a spring plate and save this fragment. Otherwise, if you got a good hole of the fracture, you can have, and this is the stability and make you understand how the intraoperative things are. This is a chunk. We were not able to fix it, or we didn't use the spring plate or any kind of other buttress plates to secure the fragment, as our purchase of the cup and stability was good, and hence this is the final, and this is a combined anti-version test panorama where we get the plane of the liner and the head, base of the head, in a coplanar position or parallel to each other, and that angle is calculated. This is done usually in posterior approach. If you can appreciate, that is the 0 and the horizontal bed is 90 and that is 45 degree, and that is a combined anti-version test which gives us reliable assessment intra-op on the table as described by Chitranjan Ranaut. And as you can see here in this video, he was a young chap, no comorbidities. We have made him walk, ambulate, partial weight bearing, and even pelvic support we have given him. After 1 year, he is doing good, and there is no sciatic injury. We had a lengthening of 1 centimeter that is acceptable for the stability of the hip. In conclusion, the 3 indications of total hip arthroplasty in acute acetabular fractures. One is where you can't save the hip, if there is a pre-existing arthritis concomitant with non-reconstructible head, where head is in lot of communication, and if an elderly patient with this kind of. Thank you.
Thank you, Sanjay. This was a case presentation.
Yeah,
I thought
a lot of other things justice in 9 minutes.
I was under the impression that you are going to tell us when to do anterior approach, when to do posterior approach, and what to do in a central fracture. It's okay. The case presentation is very good. You showed us a nice video.
A lot of I changed it sitting there because it was I think repetitive. And in the morning, a lot of authors have covered central dislocation, posterior dislocation, the attitudes.
I think we go to the next topic.
Yes.
THR and protrusio hip. This was a case presentation?
No, that is that's not a case presentation. It is definition. It is a lecture. I hope.
ಮತ್ತಿಲ್ಲೇ ಈಗ ಅಪ್ಪ ಮಾಡ್ಬಿಡ ಅದ ಮುಗಿತು ಮುಗಿತಾನ ಅನ್ಕೊಂಬಿಟ್ಟಿನ
So, orthopelvis, also known as bilateral arthrocarditis, it is an intrapelvic protrusion of the acetobuli. It is chronic condition. Progresses and it is having femoral head which protrudes into the acetabulum and pelvis. It is having 2/3 of cases are unilateral. In the olden days, arthrodesis was recommended for the young and unilateral heavy laborers. THR with bone grafting in the medial wall is highly important, and a lot of authors have given a very good result, almost 90% success with bone grafting. So history and etiology. Exactly 125 years back, Adolf Wilhelm Otto, he was a German pathologist. He has described this condition. There are a few more others over the decades, and there are theories like there is a delay in the triradiate ossification, delay in the acetabular bone ossification. The causes could be, as we know, infections, TB, the classical one of the like mortar pestle type of wandering hip that we see, and another where we can have protrusion type of effect, other infections, inflammatory arthropathy, and sponge will have almost 10 to 17% of people who will have protrusio, rheumatoid inflammatory conditions, RA, then genetic we have other lot of markers, ellanormals. Metabolic is very important. Osteomalacia, where there is a softening of the bone, neoplastic conditions, then hip acetabular fractures, especially the neglected central fracture dislocation, which Galgalis was just now saying, and the endoprosthesis, the failed revision endoprosthesis, which have protruded inside to the soft medial wall or the osteoporotic bone and has stuck in there. So this is a Cambian picture where we can easily appreciate the protrusion is bilateral, and the iliopectineal line and the ilioischial line are very important. And as in the morning we have been multiple times we are hearing the teardrop is highly important. Teardrop is one which very rarely gets destructed or remodeled. Usually teardrop remains the same in a lot of conditions, so it is very important radiological landmark. We have already, one of the previous speakers has mentioned. So this is, and this is the classical Kohler's line with the, it is not exactly a straight line, but it is almost we can see on the red side, if we assume it to be a straight and we try to draw a similar line on the affected right side of the hip, we can easily see the Kohler's line on the ilioischial line, which we can appreciate the yellow line and the protrusion of the hip and acetabular. The most important thing as a surgeon is to know that the medial wall is intact or not. Even if it doesn't appear on the X-rays, you should be having a feel that there should be and there will be a membranous layer which will be intact, which should be avoided while reading. The secondary forms, as already mentioned, the primary is actually a diagnosis of exclusion, and the secondary forms are the most common ones. So this is a picture that depicts how the bone becomes softened when there is a decrease in its mass or if anything architecture changes. Usually the classifications are of 4 to 5 types. The one which I mentioned is of Sotoba and Charles polus of the ilioischial line of the polus line, mild, moderate, 0 as per the millimeters, 15 it is the severe. Then convergent and divergent are the other forms which if we appreciate I will show you in this X-ray. Then the primary and secondary which we already talked, and the direction whether it is superiorly migrated medially or it is both. And the Rana's one more classification is rate of migration of which rate it might be. You studied it was 2 mm per and medial wall defect, that is intraoperative. It is difficult to assess due to the head, and it is intraoperative assess how much is the gap in the medial wall defect. Surgical aspects one should know. Most important is when the trochanter touches the acetabulum, and once it remodels, it gives an arthrodesis effect. It is a difficult hip dislocation during the surgery that we should keep in mind. Some of the tips are, one is expected to in situ femoral neck osteotomy, where we take the sliver before dislocating the hip, and we create it like a fractured neck of femur, then the head is delivered and then the hip is dislocated. This is one of the tricks which my teachers have taught me. So this is a case, again, just to make you aware, this is having a protrusion of severe grade. As we can see, it is a neglected fracture dislocation of the acetabulum. The hip is completely abducted, externally rotated, and there is a lot of porosis. What previous people who have done this kind of reconstructions without paying good attention to the medial wall, and we can see how the progression of the hip protrusion has caused massive osteolysis and progression of the deformity. So as in the diagram A, we can see the dashed lines. This is a kind of convergent type of where the wall and the inferior and superior you will find that there is a convergent type of defect. And as you see in the diagram C, the cup should be lateralized, point A to point B. And while reaming also in the diagram B, we can see that you should not ream more on the superior, which one can ream on the inferior, otherwise peripheral fitting is lost and the bone is already osteoporotic because the patients have not loaded them, they are atrophic type and they don't have the good purchase. So these are very important tips one should take. This is the same case of the patient. If you can see, ceramic and poly, these are the post-op, and if you see on the left where there is a staples on the left side, where the obturator foramen is not visible, but on the right side, some obturator foramen has started coming up. So this we tried to restore this boy, and it gave us good results. I won't go through this video. This is the technique of how you remove from the dislocated head, how you remove the graft and how you use it. For the PG purpose, I have added this one more slide. This is the method of way we follow history, inspection, movements, measurements, pressure test. This was the neglected type of this boy which I presented, and this hip was, as we know, clinically there was FFD, and this one is immediate express 18 months before he presented to us, and it was neglected. Ideally, it would have been presented early. This kind of plating would have been sufficient, and he would have been able to save his hip. Now it became a neglected type of. And when he came to us, this is the kind of hip. So it is both protrusion, neglected, and all kind of effects. This is flexion, abduction, external rotation, deformity with shortening, and as you see, the diagram with the two yellow, it shows the convergent type of defect, and superiorly, where there is osteoporotic bone and the ilioischial line, we can easily appreciate. CT is mandatory. Wherever there are the red dots, we can appreciate the osteoporosis and the convergent defect and change in the alignment. these are normal and CT is mandatory in such cases. This will definitely help. Even if without CT people have done this, but nowadays CT is almost gold standard. So the surgical channel dislocation, in situ osteotomy I already explained, acetable site protrusion, graft, component fitting, we have already femoral site, capsular releases, deformity correction, biomechanical stability. This was our plan. Immediate post-op, 3 months post-op, some obturator foramen, 3 months pre-op and post-op. You can easily appreciate deformity is, and as you can see here, he walks. We were able to, at 1 year, if you appreciate, the obturator foramen is completely visible. And this boy had around 1 centimeter LED out of 3.5 to 4. There are more cases, but I will conclude my talk. These are also challenging cases which we did. In conclusion, exposure is important. We have to identify the defect, keep the rim intact more superiorly than the inferior. Superior is important. We should not perforate the fibrous membrane. Pre-op CT angio are important. That was in my second case. Bone grafting, infection bone grafting, if it is not available, cage till 2 to 3 mm or maximum 5 mm depending on the type of the cup. The defect could be managed, but after that type 2 and type 3 defects should be managed with either bone graft and cage. You should avoid the cemented cups. Now porous cup is almost gold standard. Cemented also can be done in good surgical hands. You should honor the bone porosis and restore the biomechanics. Normal center of rotation, cup lateralization and strengthening the medial wall. This message was given by Chitrajan Rano, and should avoid the LED or try to restore the length. Thank you.
Thank you, sir. It was a wonderful talk on pertussis.
Hello. Regarding any experience on fossilization in your cases, fossilized replacement, in cases of protrusion or criteria for cage usage?
Yes, the first case I have the video which I couldn't, but the femoral head itself we can use it and we can graft. We have to reverse it, we have to impact it, and it should be not very much so that we perforate the wall, and it heals nicely, sir. And another thing is cup cage. Cup cage definitely we should err not to use them, but if the defect is more, if there is a pelvic dissociation, then we don't have any other option. We have to use a cup cage. There is a technique where you first save the membranous fiber, then some graft, then mild cement, then cage, and then again you fix the cage. Then again in the revision cases, that it was in my second case, and then cemented cup, small, and then we can get. Usually longevity is not more than 10 15 years.
Layers of
yes, sir.
Marcellized head, then cage, then cement.
So
layers of
marcellized graft, then mild layer of cement, then cage. It will heal, sir. And then you can put one more layer of cement over the cage, and that cement will put a cemented cup. And the idea would be nowadays with cage, if you don't have one doesn't have graft, then tantalums, and you can even get from all over. High crusting of the gluteus medius. High crusting of the gluteus medius usually we try to avoid, sir. If we get maybe some, there might be some case reports, but usually we are doing either a lateral approach in my particular case. Yes, sir. Then we release. Then adductor tenotomy and capsular release and partial quadratus femoris, and along the whole, some of the cases even excision of the fibrotic capsule, especially if it is a revision of girdle shoe. Then we have to do a lot of releases.
Sarang, I have two questions for you. Suppose there is no head, primary head. Do you get grafts here? Bone graft, cadaveric grafts?
Yeah, we don't have a lab in, we don't have a bone bank in our institute. But we have done, we have got from Ramaya, from Bangalore. We got it, but we don't have a person. We have got grafts from there.
Another thing I didn't understand was the importance of the obturator foramen. You said 2-3 times in the post-op X-ray.
This was
Can you elaborate on that?
So, that we call as linking of obturator. Whenever there is a FFD, the obturator foramen does not appear clearly like two eyes. So, due to the FFD, the obturator foramen is what we call as linking of that kind of. So, these patients have a 40
So once the FFD is cleared, like
yeah,
becomes straight, you will be able to see it.
This particular patient, despite of so many releases, on day one we won't get it. It took 3 months to get that kind of X-ray and complete. On table we have cleared it, but still patient will have the pain and spasm. So it took some time.
Pelvic tilt.
Yes, sir, pelvic tilt and soft tissue will take 3 months at least.
Thank you. Thank you very much, sir. Thank you. Wonderful. Can you have the next speaker, please?
Thank you, sir. We are all grateful for your insight on the topic. May I now welcome Dr. Raghav Reddy, sir, from Bellary to speak on THR and dysplastic hip and THA in ankylosed hip, its challenges, techniques, and the role of spinopelvic balance in implant positioning.
Good evening, everybody. I thank the KOPPAL Orthopedic Society Association for giving me an opportunity to talk on two topics. First, I will be talking on THR and dysplastic hips.
ಇಲ್ಲೇ ಕೂಡ ಅವ್ರಿಗೆ ಹೆಂಗೆ ಕಾಣ್ತಿರ್ತಂಬ ನಾನು ನೋಡೋಣ ಮೊದಲು ಮಕ್ಕಳು ಅಲ್ಲ ನೀನ ತೋರಿಸಿದ್ರು ಅದು ಹೆಲ್ಪ್ ಬೇಡ ಹಾಕ್ಕೊಂಡ್ರೆ ನನಗೆ ಎಲ್ಲರನ್ನೂ ಮಾಡೋದು
Myself and Dr. Raghav Reddy from KOPPAL Orthopedic Center, Bellary. So, for doing a THI and dysplastic hip, we need to know the degree of anatomical abnormality, which is so much important. First, we need to classify the degree of abnormality as per the four classification, where it depends on the subjectivity of subluxation. So, four variants. Type 1 is said less than 50% subluxation. Type 2 is 50 to 75%. Type 3 is 75 to 100%. Whereas type 4 is more than 100% subluxation dislocation. So we need to quantify the degree of subluxation. For that we need to take a X-ray radiograph of the pelvis in both hips. Then we need to draw a line connecting both the three drops. Then we need to take the measurement from the middlemost point of the ethnic section and we need to take the measurement as A. Then we need to take the measurement of the normal vertical height of the other normal head. That we take as a P. A divided by B into 100 will give the quantity of subluxation. If it is less than 50% time on 50, again it is as per the flow classification. The problem arises when we are doing a bilateral subluxation. Here we don't have a normal vertical head height because both the heads are deformed. Here we need to have an assumption that the normal vertical height of the head is 20% of the distance between the iliac crest and the modern distal tuberosity. So this 20% of this length gives us the value B. Then the value B. Then accordingly, into the side we need to take the calculator subluxation. When I do THR, we need to be aware of the anatomical changes in the femur and the astagram and the soft tissue. In the DDH, neck is small and deformed, neck is narrow and short with small antlers. Feet is short and posterior. Femur canal is narrow and anteriorly broad. This has to be taken into consideration when we are doing the femur preparation. So, anterior growing is not looked into then the lines of the preparation of the femur system. Coming to anatomic changes in the femur, acetabulum, it is shallow, sloping, definite superior laterally and anteriorly. So when we are leaving the acetabulum, our lemur should be more on the posterior aspect. If we don't do that one, then we will leave out the anterior part of the acetabulum. And we should be aware that anterior posterior dimension is small compared to the anterior caudal diameter. The cup size is determined by the small anterior posterior dimension of the acetabulum. We should be knowing that the bone quality of the acetabulum is good because there is no loading stresses happening as a acetabulum. These changes are worse in case of subluxation and dislocation. Coming to the soft tissue changes, adductors are dented over the femoral head. And in other sections, psoas, adductors and rectus femoris are contracted. In most of the hip replacement, sometimes we do adductor anatomy after total hip replacement depending on the adduction. But in cases of DDH, we need to plan the adductor release before going with the total hip replacement. In DDH, capsules elongated and deepened, and this has to be exercised while doing the THR. We should be aware of sciatica, femur and vessels of Sutton. We should assess intraoperatively that there is no undue tension over the sciatic nerve. There should not be undue lengthening more than 4 centimeters. We need to plan preoperatively. To looking like to plan the acetabulum head and to plan for the drafting of the acetabulum. We need to draw an intermediate drop line and the line drawing the connecting the superior part of the both the sides. In a normal case, these two lines are parallel, but in this line it is divergent. And if it draw a line 45 degree inclination, we will come to know how much of it will be uncovered after doing the acetabulum cover. We should use our implants in the acetabulum components, usually uncemented components are preferred. Normally, the smaller acetabulum implant should be, acetabulum cup should be kept ready. We should keep the acetabulum cups from starting from size 36. Usually, most of the companies will start providing from 42. We should order pre-hand before the surgery to use the 36, 38 acetabulum cups available. And we need to use the 22 mm head in socket with outer diameter is less than 48 so that we have a sufficient liner. Location of the socket is very much important when we are putting the acetabulum component. In dysplasia type, the type and close classification, we need to find a true acetabulum. For that, we need to start weaving from the acetabulum vertically downwards towards the floor. Once we reach the floor, we need to change the inclination and anteversion of the weaving. In subluxation, that is type 2 and type 3 close classification, we need to prefer to restore the hip center. Mild elevation of hip center is acceptable. Structural femur head autograft may be needed for covering the acetabulum cup. We need to avoid placing graft beyond lateral margin of cup because if only when the graft is loaded that it will get integrated with the native bone. This slide will demonstrate the technique of grafting the acetabulum side. So we need to take the head, we need to delimit the cartilage, we need to make it bivalve, and we need to place that bivalve head for the superior portion of the acetabulum. We need to fix it tentatively with KYS. Then we need to start weaving with acetabulum limber. Once the weaving is complete, then we need to fix with the screws. The screw should be in the direction of the sacroiliac joint, so that the screw is in line with the clavicular continuity, so that there will be better integration of the block with the acetabulum bone. This is a little animation. type, we need to restore the normal hip center. Augment deficiency of bulk graft and metal augments if available. Augment porotic intraarticular bone with defects and cancers autograft. We need to avoid medial wall perforation. While preparing the femur in a dysplasia or subluxation in type 1, type 3 chloride plastica, we need to we should be aware of high anteversion of the neck. We need to take a lower cut so that anteversion can be adjusted. The solution for increased anteversion are either you use an uncemented modular like S1 or you can use uncemented component with femur derotation osteotomy or cemented regular osteotomy. Smaller size can be used. In case of dislocation, trochanteric osteotomy and advancement can be done. Cemented which can be used in elder patients with lesser deformities. In younger patients, modular stems are always preferred. Subtrochanteric shortening and realignment osteotomy through a transfemoral approach is one of the possibilities. This is a schematic diagram where we are doing subtrochanteric osteotomy. So we are making one more osteotomy and we are extending the head. Then we are preparing the acetabular cup, place acetabular cup, then place the femoral component in the trochanteric portion. Use dental traction, see the amount of overlap of the shaft over the trochanter. Cut that much of the bone. Place the stem into the distal part of the stem and use this cut portion of the bone and use as a honor bone that fix it as a slice. The advantage of femur subtrochanteric shortening and realignment is use a best deformity correction, use excellent shock and exposure, and use better restoration of offset, and there is no trochanteric osteotomy needed. Where disadvantage is a complex procedure with high chance of non-linear, longer recovery, and indicate only a single patient. While doing subtrochanteric shortening or alignment, it should be essential to know alternate anatomy. We should expose the joint properly. Restoration of the normal hip mechanism is important. It's a very satisfying procedure, but not for beginners. Take home message: in this time, we should know about the type of dysplasia. We should be aware of the anatomical changes in the acetabulum, femur, and soft tissue, and we need to try to restore the center of rotation or hip center. Acetabulum, we should be aware, familiar with acetabulum living, bone ducting technique, and subtrochanteric osteotomy. Thank you. Welcome. Any questions?
Take on the next topic.
Yes.
I have one doubt. For type 2 and type 3, you said to get the cup to the native or you just accept a high hip center?
So there are two schools of thought. So one school of thought is try to get it to the natural native acetabulum. So the thickness of the actual true acetabulum has a very good bone quality. But recently people say that with the off-turning with the false acetabulum will have a thicker cortical bone. So there are two scholars, it all depends on the surgeon. Which one to be used?
Because I was under the impression that pro type 1 and type 4 try to place the cup with the native acetabulum. And type 2 and type 3, the bone quality is better in the false acetabulum. You can accept high hip center in pro type 2 and type 3. So
if you place the cup in high acetabulum, there are high joint reaction forces and early grade. That is one of the things which is there. As much as possible, try to restore the natural true acetabulum, particular true acetabulum. If it is not possible, then we need to accept the false acetabulum.
I think this is I strongly follow Vijay Bose. I think what Vijay Bose says is that pro type 1 and type 4 bring the cup to the native acetabulum. Type 4 because you are doing a subtrochanteric shortening osteotomy. That is the reason you get it back to the native acetabulum. Pro type 2 and type 3 you can accept high hip center. I think the results are better. What is the opinion of the this one? I don't know. I think in pro type 2 and type 3 you can accept high hip centers.
Yeah, that is something I think dependent on the surgeon's philosophy probably. But by and large, I think a little higher hip sentence is acceptable nowadays. Type 4, getting it down to the cup, I think it's quite a challenging thing.
My next topic is total replacement in ankylosing hips, challenges and techniques and the role of spinopelvic balance in incline position. Again, we said two topics and there are time given for me to 10 minutes. I try to restrict and make it short as much as possible. So when I deal with ankylosing hip, we need to know the cause of ankylosing in that particular case. So the usual causes of ankylosis are infections such as septic arthritis and tuberculosis, are inflammatory conditions, ankylosing spondylitis, rheumatoid arthritis and psoriatic arthritis. Other trauma and injuries and other causes like prolonged immobility, osteoarthritis, congenital malformation and ectopic calcification. We need to have a proper clinical examination because deformities are better understood clinically than radiologically. We need to assess sagittal, coronal and rotational deformities. We should have an idea of the range of movements and different adjacent joints. We should have an idea of true and apparent lengthening and abductor function. The exercise of pelvic both hips is important to know the position of the whether it is abdomen, whether it's in abduction, adduction or rotation. It gives an idea of pelvic obliquity in the joint fusion. Femur can also choose the quality of fusion and the bone quality and the size of pelvic pelvis and the proximal femur. This exercise we need to say about any cyst in the acetabulum. We need to see the deformity of the limb. We need to see whether it's a complete ankylosis. We will get an idea of the neck length, neck offset. We will get an idea of how much of the shortening is there, and we will get an idea of the femur canal. CT scan is of great help in assessing the bone stock, medial wall, the valvular continuity, femur canal diameter, and the pain at the level of the joint. This is the columnar section CT where you can see the cyst in the acetabulum. So we should be prepared for the acetabular grafting. We will come to know the level amount of fusion. We will come to know the bulk. We will come to know the neck length, and if it is developed, we will come to know the femur canal. This is your axial CT where you can see how much of fusion is whether the fusion is more anterior, it is shown at it helps in our approach and dissection. Relief spine exercises are very important because here we need to see about the scoliosis, hyposcoliosis, and whether it's important for the radial for the anesthetic to give us spinal or epidural. And lateral exercise is important to see for the pelvic to see the sacral slope, pelvic fill, and any pseudo-orthosis. And cervical spine exercises are important because we need to have a backup plan of endotracheal intubation. Sometimes fiber optic intubation may be required. In preoperative planning, we need to evaluate the cause of ankylosis, rule of active infection. Templating as in any other TSI is very important, but in ankylosing it may not be accurate because female head it may not be because of the deformities. Here it gives an idea of the female head side acetabular cup. It may indicate to you about the need of a modular implant depending on the proximal femur morphology. Sequence of surgeries when we are doing these type of tests, whether spine or hip first. In both cases are like usually it's a spine first. When we are doing the hip or running, it's always hip first because any changes in the biodynamics have an impact on the dynamics of the knee. And when we are decided on the hip, we need to decide which hip should be operated, whether it's a right or left, whether it's abducted hip or adducted hip. It's always it's better to operate on the abducted hip because it helps in the positioning. If we keep, it's very difficult to position the patient in abducted position, lateral position. Incline sense, it's unsymmetric is preferred because there will be a lot of loading forces on the femur side or the acetabular side. Always unsymmetric which is preferred. Always we should have a modular prosthesis handy. Anesthesia concerns. Anticipate for difficult spinal, we have a backup of fiber optic intubation. You should should be aware that the chest expansion restricted and ankylosing spondylitis, those people who have decreased tidal volume, and most of the patients have, at least 30% of the patients have RVBP. There are high chance of increased bleeding, so anesthetists should have maintain a hypotensive anesthesia. Positioning is very important in these cases. It's, most of the time we do in the posterior approach, so lateral position is required with good sacrum pubic support. Adequate padding is important. Multiple pillows or headrings is important to compensate for the cervical spine stiffness. Patient should be strapped and make sure that table is tiltable. Precautions during surgery. Sciatic nerve injury is possible due to acute lengthening, scarring, limited retraction, and altered anatomy. Exposure is difficult because of distortion of anatomical pain, dilation of hip center, rupture sternum, soft tissue contractures, and ankylosis. In addition to the regular exposure, we should be prepared for the gluteus maximus release, fraction lengthening of TFL. We need to make an attempt to, we need to identify the extracerebral flexion. If the limb is fixed in external rotation, we need to tilt the table so that we have a view of the posterior aspect, identify metacerebral flexion, remove the rectum, then we need to have a complete visualization head and neck soft tissue release in this knee. Well approach may be needed to the hip in external rotation. In case of external rotation, process structures namely capsule and rotators are contacted. Flexion deformity includes sciatic nerve at this. In certain cases, trochanteric prosternity is the only way forward. Tilt the table forwards and towards to expose the anterior and posterior. We need to do the wafer osteotomy. When we wafer osteotomy, we should make sure that we are not disturbing the damaging the abductor, GTR asteroidal work. We should use the fresh osteotome or the fresh salt to have a clear cut, and they should not be only splintered. This is a schematic representation of the wafer osteotomy, and then here is a clinical picture of the wafer osteotomy. After the osteotomy, we have to take the ring and take a fractionate of humor, then try to reduce the remove the head with either piecemeal dissection, or we can do it acetabulum leaving over the head until we reach the native middle floor. We reach the floor of the acetabulum. Femur is restricted anterior with splenic. Two treatment clips may be used to have a 360-degree exposure, which is very important. Kneeling has to be done, keeping the lower margin of the kneeling in line with the parallel to the calf. We need to be aware of the pelvic obliquity before doing the kneeling, because if it is abducted or adducted, it leads to either the closed cup or open cup. Cup position, there are different recommendations for cup position. Cup inclination should be between 40 to 42 degrees and a combined anteversion of 32 degrees, which is recommended by Whitmer et al. And then another recommend cup position of 25 to 30 degrees, 35 degrees in males and 35 to 45 degrees in females. Cal can be always used as a guide, keeping the leaning balance to cal, which are the most approach. This is the cal, and our leaning should be in parallel to the cal. What is the correct position of the cup? When we place the lemur or the cup, there should be narrow edge of bone anterior superiorly, and here there should not be cloud anterior, not cloud the edge of the anterior wall, and it should be at the level of cal, and there should be 2 to 3 millimeters of posterior superior uncovering. Coming to the femoral compression, anteversion ranges from 17 to 30 degrees. Concept of combined anteversion is important. As stated earlier, templating will not be accurate. Kneeling before aspirin may be required in certain cases. In younger patients, try to preserve the bone. Femoral ulcer character is reduced. Judging lesion with necron. Valvate epicondyle can be used as a secondary landmark. When in doubt, take a CM picture to assess the pulse strength, inclination, and shortening lengthening of the vein. Closure again, close is difficult because posterior structure may not be available for a tight posterior closure. Quadrators can be used as a savior, translocators in the anteriorly. Adductor tenotomy, iliopsoas release and anterocapsule release may be required during the surgery. These ankylosing spondylitis are notorious for hypertrophic ossification. So copious was with at least 3 liters of normal saline to clear the surface of any bone debris. Overzealous retraction should be avoided. Use breastplate for to stop bone cuts. No failure stripping should be done. Post-operatively, we can use the indomethacin 25 to 75 mg. Creatinine is okay for 36 for 3 weeks. Alendronate 25 mg twice a week can be given for 3 months. If you have access to data between 70 to 700 centigrade of can be given post-operatively using linear accelerator 350 from anterior side and 350 centigrade from posterior. Now coming to the second topic of second part of the topic, the role of spinal pelvic balance in implant position. This is per se a huge topic. I try to keep it as small as possible. Historically, total hip replacement lived on the living safe zones 40 plus or minus 10 degrees subduction, 15 plus or minus 90% for established approach. Assuming the pelvis was fixed, but in fact it changes with posterior changes from position changes from standing to sitting. The paradigm shift from static to dynamic position. This movement directly changes the functional orientation of the ashtanga. From standing to sitting position in a healthy flexible person, the pelvis tilts posteriorly. This motion is often coupled with lumbar spine kyphosis, leading to flattening of the lower back. So in a neutral pelvic, there is a neutral pelvic tilt. When standing, there will be anterior tilt of the pelvis, and in sitting position, there will be posterior tilt of the pelvis. So these are the diagrams comparing the anterior tilt and the posterior tilt of the pelvis. In the when there is anterior tilt, the inclination will be around 41 degrees and there will be 10 degrees of anteversion in standing. In sitting, where there is a posterior tilt, there will be inclination of 54 degrees and 38 degrees of anteversion. Change in pelvic tilt, for every 10 degrees of pelvic tilt, there is a change of anteversion of 7 degrees and inclination of 3 degrees. Because of this, if you implant astabulus of a normal position in a fixed pelvis, there are chances of impingement and dislocation. So we need to assess the pelvic spine mobility. These are the two comparisons where there are two concepts: there is stuck standing and stuck sitting. Stuck standing, in the stuck standing, you can see there is exaggerated lumbar lordosis. You can see the closed-like type of upper foramen with a proper pelvic inlet view. In a stuck standing, where is seen in ankylosing spondylitis, where the pelvis is in flexion. Because of that, there is an open eye view type of picture. These are the comparison of between stuck standing and stuck sitting. In stuck standing, there is a sacral slope more than 30 degrees. There is exaggerated lumbar lordosis. There is anterior pelvic tilt. This happens in degenerative spine in posterior instrumentation. Anteversion is leading to functional retroversion. So there is a risk of anti-impingement and posterior dislocation. This has to be overcome by increasing anteversion to 25 degrees. In stuck sitting, sacral slope is less than 30 degrees. There is loss of lumbar lordosis. Pelvis is tilted posteriorly. This happens in ankylosing spondylosis, leading to loss of flexion. Anteversion is increased, leading to functional anteversion. Risk of posterior impingement and anterior dislocation is common. So anteversion should be kept around 15 degrees. Consequence of ignoring spinal pelvic balance leads to dislocation, exploding and wear. Instability and patient dissatisfaction and aseptic losing is also there. Take home message: good pre-op workup and planning, adequate exposure release, neck cut without splitting and damage to walls or fractures, restoring biometric roots of the hip, identifying true astabulum, restoring astabulus center, correct astabulum femur component placement, and we should have a 3D orientation of the hip. Thank you.
Thank you, Dr. Raghav. Excellent topic for today. Any questions? I think before our General Secretary gets ready for the next talk, we can take one or two questions.
Sure.
Hello. I think this is a very difficult topic, and getting the cup placement right in a spinopelvic thing, in a non-robotic, I think it is very tricky. And that is the reason maybe the robotic is the thing of choice nowadays in spinopelvic things. Definitely it is a very complicated topic, and this needs very nice placement, otherwise it will end up with dislocation.
Any questions? I have one question. I think it's a very important practical point which I think you could have conveyed to the audience. Like in an ankylosed hip on the table, how do you know you have reached the bottom of the slab?
So it is identified by the unossified ligamentum disease and the fat pad after fat pad attack.
Perfect. That is the thing. I wanted you to come out.
Because there is one of the slides where somehow
Whatever may be the ankylosis, whatever may be the bony mass inside, even after decades of ankylosis, the one thing that doesn't get affected is the ligamentum teres and the pad of fat surrounding it. So once you reach that, you know you are at the bottom.
So to know the thickness of the floor, we can use that limit and we can use that case also. 2.5 limit can be used to identify the thickness of the floor.
Thank you so much.
Thank you, sir.
Dr. Harish Mukta will take over the stage now.
Thank you, sir, for a thoughtful discussion. I would now like to invite our speaker, Dr. Girish Vasanad, sir, Chief Orthopedic Surgeon, Vasanad Hospital, Bagalkot, to share his experience on revision CHR in Tier 2 cities.
Hope I will not bore you today. This will be the last lecture. Greetings from Bagalkot. I would like to share our experience of using hip arthroplasty. Look at these two cases. Do you find the same or they are different? Okay, I will get back to this at the end of this lecture. Revision arthroplasty basically means either revising a part or whole of the previous hip replacement components during that surgery. This operation varies from simple minor adjustments of the components to the massive operation replacing the significant amount of bone or the metal. So basically why the revision should take place? It means to say what are the indications for these revision hips. Pain is the commonest indication with the reasons behind. It may be plastic wear, dislocation, loosening of the implant, infection, osteolysis, sometimes pain from the hardware. So revision is not like a primary index surgery. This revision arthroplasty is very complex and lengthy. It takes time. Most of the time it is challenging one, right from explantation of the implants, existing implants, bone grafting, reconstruction, soft tissue balancing, and we may be having some surprises during surgery which we would not have expected in spite of a pre-op CTs, and it's obviously you all know that it's costly. The causes for these failure of the previous THRs could be right from aseptic loosening. This is the commonest indication for the revision hip, pain, and the dislocation of subluxation, lysis. Infection takes about 12%, acetabular infection in either of the components, periprosthetic fracture, malalignment, and implant failure. Overall, about 83% includes the indications for the revision hips. It could be either early failure or it could be a late failure. In most of these two cases, you can see that early failure as well as late infection predominates because it can take place either in the early perioperative period or more than 3 weeks. As I told you, this is the commonest indication for the revision of the hips. For these to catch these cases, we need to have a regular radiological follow-up during the primary surgeries. Look for the zones where you can find the loosening, and also looking for the patient's new symptoms. We need to avoid the major bone loss. These are the zones of bone loss on the femoral side as well as on the acetabular side. This is one case which was fracture neck femur operated myself about 12 years back, bipolar hemiarthroplasty. So she used to get a pain, hip pain, thigh pain, not able to walk in the last few months, 4-5 months. And the last month we revised it to, because you can see that the stem is penetrating, is going for a varus collapse, and there is no fracture as such. If you see, I didn't do a CT for this case. The stem is penetrating to the lateral cortex. Intraoperatively, you could find that there is a fracture just below the trochanter area. So we need to wire it. We use the long stem bypassing the stress riser. The another cause for the revision is either the bearing or the ceramic wear. There might be osteolysis. This is nothing but a tissue response for the wear debris. It could be most common with the traditional polyethylene bearings, and nowadays it's less. Dislocation or instability is another cause attributing for 1 to 2% of the total revision cases. Either it should be either from the component size, acetabular or the femoral side, or it could be a soft tissue issue, maybe the muscle tension loss or the function, and the components. If it is a lesser diameter internal head, then it's another case for a revision case. Periprosthetic fractures, these are nothing but sometimes they are the stress risers, mainly predominantly in the elderly cases where the THR was done or by hemiarthroplasty was done, may require implant fixation. So this is one case of AMP, osteomorosis, well done about 20 years ago. So this lady, she developed a periprosthetic fracture which revised to a long stem, totally uncemented. Infection. This is, I think, it's a nightmare for either both the surgeon as well as the patient. It needs a lot of attention. We need to prevent this infection, even in the index surgery as well as the revision cases. What we should know about this is we should maintain the clean air environment, and we should have elective wards for such cases, skin preparation, surgical technique if the surgery gets prolonged, as in case in these revision cases, tissue handling. All these factors will contribute for the post-operative infection. So most of the 90% of the times, Staph aureus are gram-positive cases, but we also should know that we are aware that recently the gram-negatives are increasing. And with all this, hardly, unlike other infection cases, perioperative infection with the implant institute like TKR, where it's a superficial joint, but in the hip cases, hardly any systemic symptoms will come across. Only 12% of the cases, they come with the classical signs of infection or so. In this case, they could be just a persisting pain, which could be the underlying deep infection. So how to tackle, how to diagnose this case? Either we have to do as well ASR, CRP. They are all highly sensitive and specific. Both, in most of the cases, you have 83% of probability. If both are normal, almost infection is not there. Otherwise, other investigations like interleukin-6, procalcitonin, and further to scan these, technetium 99 scan to know the uptake. Along with that, another scan like nuclear medicine which involves a gallium-65 citrate scan. Prosthetic joint infection level leukocyte scintigraphy is also used to diagnose the infection. So, what were some cases, affluent case, in a known case of like where clinically suspected collection in the joint, we can do that suspicion of the infection. If you are suspecting, you can aspirate the joint fluid and send it for gram stain and culture. So, intraoperatively, if you are when you are revising the infection case for a revision hip, intraoperative sending for gram stain cases will hardly give 27% of instant sensitivity for the infection. So there is not much role for the intraop gram stain. But instead, if you send a tissue culture or the fluid culture from the intraoperative side, from 5 corners, 5 to 6 corners, there is a it's a highly sensitive as well as specific. So, Musculoskeletal Infection Society, with regarding this prosthetic joint infection, they have made a criteria, at least 4 out of these 5, ESR, CRP, synovial white cell count, synovial BMN percentage, and more than 5 neutrophils per high power field. So if the infection is less than 3 weeks, or if it's an infection more than 3 weeks, either it can be decided with a surgeon, cure with dia, that is, you can retain the implants, debridement, antibiotics, give antibiotics, retain the implants. But using this dia technique, if the infection which has occurred within 1 week, the chance of curing the infection are high, as high as 90%. If the infection is 1 to 2%, chances are almost 50-50. And if the infection is more than 3 weeks, if you are doing dia for such cases, the results are less than 10%. So with all this background of knowing the failed hips, if you are going for a revision hip, what we should know, or what is your aim? Removal of these old loose components, limit the destruction of the host bone or the tissue, soft tissue, reconstruction of the bone defects, either with the bone graft or the metal, stable revision implants. You should choose the implants which are suitable for those failed cases. And as in previous speakers told, restore the COR, the center of rotation, as much as possible. So revision arthroplasty is more difficult than primary, very poor results compared to the primary hips. Requires very good pre-op planning with good choice of implants. We need a long, good X-rays of both AP and lateral view, and CT is almost a must in most of the cases. And try to get the previous operative notes if it's your own case or if it's a friend case, which company is used, what is the size, what was the size, so that you can mentally prepare before going for the revision case. And keep all the implants possible. You should have a good instruments like high-speed drills, burrs, and flexible osteotomes to remove the cement, and acetabulum implant extractor. So on the femoral side, we should have all the armamentarium, right from cemented, uncemented, long stem, even keep normal trauma cases like plates, screws, nails also. In the acetabulum side, we should also have not only the regular implants, we should have some new implants, which are used mainly for these revision cases like jumbo cups, multi-hole cups, and tandem cups, and you should also have cages. And if you are planning for dual mobility, that also should be in your armamentarium, plus augments, because we should in the surprises, as I said, there could be acetabular defects which may have to tackle with these augments, acetabular augments. The main aim is to radical debridement. Doing the radical debridement is like treating a tumor case. So this, I'll share one case of PHR, which is 35 years lady, which was diagnosed for AVN or DDH. She was operated with uncemented PHR. After 3 to 4 months of PHR, it was done elsewhere. She presented with persisting pain, almost 1 year pain. She used to complain of mid-thigh pain or knee joint pain, sometimes deferred pain to the lower limb. This was the case. You can see that, not so obviously seen, she doesn't have a constitutional symptoms as you get in an infection case. But you can see that there is a proximal femur thickening, medial and lateral cortex. There is a thickening of the cortex, and the CT scan showed that there is a periostitis on both the sides. In this case, we decided to go for stage procedure. We explanted the original implants and went for a cement spacer with vancomycin antibiotic. This is a company-made spacer which used 5 grams of stimulant along with this. This was kept, and she relatively her clinical symptoms gradually disappeared. And our aim was to keep for at least 3 months, but she was not. She was insisting to keep for some more time. almost we revised 2 months back, and this is a uncemented total hip replacement. Again, we have used in the revision case also Stimulon. So far she is doing well. So we have other 3 cases with different 3 scenarios where the revision hip was done. One case of septic arthritis eventually landing into a THR. This is basically a septic arthritis of the hip with all the markers as, I'm doing this. So what we did initially, arthrotomy, regular arthrotomy, joint debridement with vancomycin Stimulon beads. Patient was okay initially, but his pain persisted. This was a post-op X-ray. All culture was negative, AF is still negative. No surgical site infection, but he was having a stiff as well as painful hip. After 8 weeks, after 6 weeks of IV oral antibiotics, again we had to do gallstone arthroplasty with again vancomycin cement spacer. He was doing very well radiologically as well as clinically. Then we changed it to uncemented total hip replacement. He's doing well as of now since 1.5 years without any recurrence of infection. This another case is a tabla teacher, 45 years young male, fracture neck femur. This was operated elsewhere. Ideally should have done a fixation. They went for a uncemented bipolar processes. This is the first X-ray shows uncemented bipolar processes. But on 3rd day of post-operation in the same hospital, he dislocated hip. Then they changed to, on the 5th day, they changed to cemented bipolar. Unfortunately, that got infected from 5th day itself, pouring pus. He was treated with only dressings, antibiotic change of antibiotics, many times physiotherapy and all those things. But he was not completely cured of this. After 8 months, he consulted us. When he came to us, MRI showed that, CT scan showed that there is a posterior inferior limb mildly displaced fracture along with the rare fraction that shows a transverse zone. So this was showing some amount of infection around the process. So again in this case, we counseled him, planned for a stage procedure, implant removal, radical joint debridement, vancomycin cement spacer, plus Stimulon beads. This is the first, in the previous case we had an issue with sciatic nerve palsy with a spacer. So in this case I was little bit hesitant, so I didn't do much lengthening. So there is a little, you can say that trochanter is overriding. But this patient is doing very well. Again with after 3 months everything is coming down. Clinically he was doing very well. So we did in this case uncemented total hip replacement with 2 screws on the acetabular. In this case we used a dual mobility cup along with the Stimulon beads even in the revision case. So this is his immediate post-op. 2 years, 1 month follow-up. There is no he is not, he is doing extremely well. In fact, he is not squatting, but he is doing his job. The last case is a 22 years male. He had a trauma. His posterior wall acetabulum fracture along with the dislocation with the hip. He is from the neighboring district here. So he went for bone center treatment for 4.5 months. It was a stiff hip. Unfortunately, I don't have post-op pre-op X-rays. So we did the uncemented THR for this patient. There was little posterior wall defect in this, but we could manage with a bigger cup. But in this case, he had a sciatic nerve palsy, which almost took 7 months to recover. Everything was going well. He was doing well. He's walking. Everything he's doing well. But on just before the marriage, when he came to give me a marriage card, invite me for his marriage. But after the 5 days of his marriage, he again fell from the truck. Suddenly jumped from the truck. He dislocated. Fracture and dislocation again. This is how he came to us soon after his marriage. So this was challenging for us. We can see that the head along with the cup is dislocated outside. the what we kept is a small defect on the posterior wall was a difficult for now because that gave the issue here. It was not accepted by them. So we decided to go for, this is a CT. You can see that there is no posterior wall as such, a huge defect there. So either we have to plan, allograft was not an option because chances of failure are high. So we thought of doing acetabular augments. So getting acetabular augments was a big issue to buckle coat because we have to wait for 2 months to get the implants. Very costly. This is what we did with the acetabular augment and revise the hip with the uncemented. This is the just yesterday's X-ray. He is doing squatting, sitting. He is using the Indian amount. Sorry. So that was his video. He is doing very well with this. So you should be very careful when we do revision cases, whether it's your case or it's somebody else. So these are the 2 cases of bipolar, bilateral THRs which are done. Are they different or the same? There are 2 different cases. There is nothing extra in this. Just wanted to keep you alarmed. Thank you. My pranams to my gurus, Dr. Verasamy Ravindran and Pranavat sir. Thank you very much.
Thank you, Dr. Vasanth. Ask him not to jump again.
Wait for 3rd revision then.
Thank you, Dr. Girish.
Thank you, sir.
I think we can ask Dr. Harish Murthy to come. I really appreciate that such enormous, severe cases are being handled in Bagalkot, and you have the skill sets also and the availability of implant and infrastructure. Because even in a place like Bangalore, many would have the courage.
Thank you, sir, for your valuable opinion on the topic. Now let's invite Dr. Harish Murthy, sir, from LIMSide to discuss about the topic 3D printing in primary complex THR.
This being the last talk of the day, I will take this liberty to take another 1 or 2 few minutes more. Rio, starting. Okay, we'll talk. Greetings from Raichur. What is 3D printing? 3D printing is a form of additive manufacturing technology where a 3-dimensional object is created by laying down successive layers of material from a digital file. 3D printing is also called as rapid prototyping or additive manufacturing or layered manufacturing. 3D image of an item is created by using a computer-aided design software, and this CAD information is sent to a printer. And this is how the 3D prints. That the 3D image is got either by CT or MRI. You create a STL file. Cleaning and editing is done by the mesh lab software. Slicing of the 3D images are done, and it is fed to the printer, which will print the model. There are various applications of 3D printing and 3D graphics, 3D tools, 3D implants, and 3D bioprinting. I will not go through the other than arthroplasty indications for 3D printing, but common models are this is very commonly used in pelviacetabular fractures, complex hip arthroplasty with acetabular defects, complex spinal deformities, and other indications. Coming back to our cases, this is the case of as fracture acetabular. I just have put in this case here because this is how a full model of 3D printed model is printed in Raichur Institute of Medical Sciences 3D printing lab. So we have established a 3D printing lab in Raichur, and we have given this to one of our postgraduates, and he does the 3D printing, and this is how we print our models with the video again will not work. It is working. All the previous videos was not working. So this is how the 3D printing actually occurs, and it is printed layer by layer, and you can see how each model is created. So this is actual model of our 3D printer in our college. So this was the, with the help of Dr. Shivraj, we reconstructed this case. Coming back to our arthroplasty cases. So this was a 36-year male patient, polytrauma with fracture acetabulum and fracture shaft of femur. So we understood what are the fractures of the acetabulum. So this was a T fracture of the with a posterior wall fracture. We exposed this fracture, and because it was shaft, we did a retrograde femur nail, and we reconstructed the acetabulum. We did a with the Stobas approach and posterior approach, and we could reconstruct the acetabulum, and this was how the acetabulum was reconstructed and the femur was nailed. So everything was going on fine, but after 3 months, that patient ended up in avascular necrosis, and you can see the head has completely got absorbed. And you can see now that the head is completely absorbed and the acetabular fracture is healing, but the femoral fracture has still not consolidated. So we got a CT scan now. The CT scan, at least this CT scan, did not show any screws inside the acetabulum, and we thought that none of our screws are inside the acetabulum. And we sent this CT to a 3D model, and we got the 3D model done, and this was by the MySegmenter software by Jajal, and they showed that our screw is inside the acetabulum in the patellate fossa. I don't know whether that is the reason for our avascular necrosis. And then we got the computed pictures, 3D pictures that showed this model, and this was the model showing that one of our screws is inside the cup, and none of our posterior wall plates, neither the hook plate or the column plate or the wall plate was inside, or any screws from this plate was inside the acetabulum. So what we thought, and the 3D planning showed that if we rim up to 58 millimeters, then we can put in a cup and none of our screws will come in our way. So this is the help of the pre-operative 3D planning, which will tell us what are the things to be removed, what are the things to be kept inside. See, we only removed one screw from the anterior column screw. So they gave a 3D printed models like this, and they show that screw is there inside the anterior column screw, and if you remove the column screw and read 58 millimeters, our cup should sit in. Because our femur fracture had not united, what we did in the first step was, first stage, we removed the anterior column screw, we removed the retrograde nail, and we put in a plate. And because we were not sure, because our THR should come there and it will not sit there, so we removed the retrograde femur nail and we put in a plate, because we were not happy about the femur thing. And after putting the plate, we still had sufficient place for us to put the prosthesis. This was with our planning. We could see, unfortunately, one slide is missed. Afterwards, we have done the revision surgery for these patients, and THR, we have done the second stage THR, wherein it is fitting properly and the patient is walking very nicely now. This is another case, a posterior wall fracture of the acetabulum. It was plated like this. Unfortunately, this did not work, and completely there was absorption of the head, and it was very unstable, and we had to again do the planning. So we did again the 3D planning. So if you see the acetabular defects, so this will qualify for Pfefferowski 2B. Infection was ruled out. The medial wall of the teardrop was intact. The superior dome or the hip center migration was less than 2 cm superior laterally. The anterior column or the collar line was intact. The posterior column lysis was not there. The remaining host bone was more than 50% contact was there. So what are the aims of acetabular site fixation? Obtain a stable fixation with prosthesis, restore hip center, and achieve a stable articulation. And for Pfefferowski type 2, options are either jumbo cup, T-Marks cup if host bone contact is less than 40%, trabecular metal augments for peripheral cord, Bagalkot Boston is used, or oblong cups and structural allografts or custom made patient specific titanium implants. So we removed all the, so this was the pre-operative planning, and this was after removal of the implant on the pre-operative planning. So this is the augment that we had designed, and they also give us what is the size of the screws, what should be the size of the cup size, what should be the size of the screws that will be put in the cup. Everything will be given pre-operatively by the planning. And we got the augment printed for this particular case. So we got a 3D printed titanium augment, and this was the surgery, and after post-operatively with this augment we could get a very nice posterior fit, and the patient is very nice and stable, and the patient is doing fine now. So this was a very complex Paprosky type 2 acetabular defect managed with patient-specific 3D printed implants. So another case, this was a complex revision case. The revision case is, the primary was done long back, 31 years male patient, 12 years back the index surgery was done for neglected fracture neck of the humerus where ESR and CRP was normal, and prototype given much before the original the 3D printed cup was given, and they give us the details like this: what should be the size of the screws, where should be the size of the screws, and this is the prototype design that is given very nicely beforehand, and this is the actual model with the prototype of the tri-branch cup in situ. So this is how we can play around with the model, and 3D printed models will help us in planning. And this is the actual 3D printed titanium implant. We got it printed, and the pre-operative checklist what we kept ready was the 3D printed cage and appropriate size titanium screws, dual mobility cemented cup with antibiotic bone cement, allograft for bone bank from the bone bank from MS Ramayam, titanium fluted stems of all lengths and diameters were kept inside, kept ready, and this is the surgery what we did, and we could recreate the same defect what was there in the model. The same defect was there when we exposed it, and we could put in our tri-branch cup and then put in a evolutus cemented dual mobility, and with a titanium fluted stem we could get away, and this was the post-operative X-ray. So in a very complex revision case with the Kaprowski type 2A defects, we could manage with a 3D printed tri-branch device, dual mobility cup, titanium fluted stem, and this is the post-op X-ray. So to conclude, 3D printed models and planning is a very nice tool in complex cases in orthopedics when defect and deformity correction is needed. 3D printed implants are very useful in complex defect management, either in complex primary or in revision arthroplasty scenario. Thank you.
Thank you, Harish. That was real huge and of international standards, I would say. Any questions?
See, turnaround time in India, it is about, we hardly see that all the defect and the problem is from our side. The company, they will make everything in 3 weeks. In 3 weeks turnaround time, everything will be ready. See, we have to approve the design, we have to make the payment, and then all the delay will be from our side. But if everything is ready, the turnaround time is not more than 3 weeks. They send us the link, they ask us to approve the design, and if we approve the design, then the model is the tri-flange cup or the augment is printed.
No road be a problem to you say advance payment.
3 weeks is what is the turnaround time.
Because it works out cheaper than the Zimmer travel.
The tantalum augment, what Boston has used, I think the tri-flange cup or the augment will be much cheaper than the Zimmer biomet tantalum augment.
The same thing happened. We had to use a calculator, so that they sent the calculator cheaper than the.
Thank you, Dr. Harish.
Thank you.
Wonderful lecture. I think we are coming to the last topic.
Thank you, sir, for sharing your 3D view on the topic. Let us invite next speaker in this session, Dr. Raghavendra Kembhavi from Mysore, who will present about hip arthroscopy.
By the time Dr. Raghavendra Kembhavi gets ready, I want to share a few of what I think should help the postgraduates and the junior speakers from the AO school. They teach the teachers, the teacher of teachers, a lot of them are from AO. They teach them how to educate them in their AO training programs. They also tell them about the slides, about the content of the slides, about the body language, lot of things go into it. Like, because as a teacher, they have to be the role model for the next generation of speakers, and they are given a topic. And then the general rule of the thumb is, if you are given a 8-minute talk, you have to speak with 8 slides. Maybe we can, for our this thing, we can go ahead with up to 15 slides, max. So what I was trying to tell, in 15 slides, I mean the amount of written material on the slides can be less. You don't have to expose all your knowledge or all your this thing about orthopedics that you know. If anybody is interested, they'll come back and ask the question. So you have to convey the message. You have to see that the audience doesn't get bored. There may not be full theory on the slide, just 4 or 5 lines per slide. The background, what it should be, and the fonts, what it has to be. So by and large, I would say that if you have a 8-minute talk, I keep my slides between 15 to 20 max. So that should be good enough. And you need to practice it once, probably, if you are doing it once in a while. If you are a very good speaker, you have given the lecture before, it's okay. So if you have 50 slides for an 8-minute talk, that doesn't make any sense. You are trying to show what all work you have done, and you cannot do justice in 8 minutes. And that's what I would like to tell the juniors speakers and also the postgraduates. Try to convey whatever you have given the topic in the correct time and try to end by that time. 8 minutes is 8 minutes. That's right. I'm going to say this.
Thank you. So, good evening. Thank you, excellent, for the kind invite. Honored to be here. So, I'll try to finish as quickly as possible. So, I'll be talking about hip arthroscopy portals and the applications. So, there are 18 plus portals that are described in hip arthroscopy, but we don't use all that. So before we go to the portals, we have to know what are the arthroscopic compartments. We have single compartment, we have peripheral compartment, and we have a point-to-point compartment. So accordingly, we use the portals. We in central compartment. First technique, we have two important portals, that's anterolateral portal, and we have working portal as an anterior portal, and rarely we do use posterolateral portal. So before we go to the portals further, we have to know what is unsafe area here. Main line drawn from the ASIS. If you go medial to that, that becomes unsafe. So we try to stay lateral to that, and we have we know that it's around 5 cm on the tip of the trochanter, and posteriorly we have sciatic nerve. So when we go to the peripheral compartment, first technique, we have four portals mainly. One is proximal anterolateral portal, second one is anterior portal. Both are visualizing portals. The second one is working portal, and third portal is anterolateral portal. And the last portal, often used for anchor placement, is that's the distal anterolateral portal. So that essentially becomes a shape of the diamond. So in peritrochanteric space portals, we are addressing the routine medial space or the ITP or the trochanteric bursa. Weaving portal becomes distal, that's anterior to lateral portal. And if the working portals becomes the proximal, that's anterolateral portal and posterolateral portal for the social management. So outside in capsulotomy technique, two main portals, again anterolateral portal and anterior portal, and this is a generalized setup. Everything falls on the opposite side of the surgeon, that's the machine, the anesthesia machine, the ventilators, and the arthroscopic towers on the opposite side, and the fluid management on the other side as well. And the CM, it may come in between the legs or the opposite side of the surgeon again. Now indications, anywhere in the world, FI is the number one indications. So we know that CAM, pincer, that's due to focal overcoverage of femoral head due to established retroversion, or it could be due to coxa profunda like this. So all can be addressed arthroscopically. Second indication, extra-articular impingement. So we have ESOS impingement, subspine impingement, and we have ischiofemoral impingement. All can be addressed in arthroscopically with very good results. And the third indications, fracture management, again we have a lot of role of arthroscopy in fracture management. Loose body removal, this is one of the cases where I had to take out a lot of loose bodies following the fracture dislocation, and that was another case of Bacon's type 1 where I fixed arthroscopically with the two Hubbard screws, and this is not my case from the article, so we can address the testacular fractures as well arthroscopically. So septic hips, very common indication in India, it can be tubercular, it can be pyogenic, so all we can do a good lavage arthroscopically. Cerebral disease, very good indication again, it can be PVNS or cerebral chondromatosis, because they can go straight into the joint, we can take out all the loose bodies and cerebral diseases. Again, for me, this is the very, very important and very good indication for me, especially in India post-COVID. The reason I'll tell you, we can address a lot of issues arthroscopically. This is one case which I did multiple greenhouse in the head, and the picture on the right side is after I reduce the compression, as you can see the bleeding from the femoral head. So we can address FII along with that. What are the arthroscopic advantages? We can address the synovium, we can address the head, that is a development test, we can address the label as well, and we can of course address the FII. So that is one patient where I am doing TAM osteoplasty. So this is another pediatric patient on the right side. You can see the physis, we can do a TAM osteoplasty as well. So this is one patient, another patient where I had to resect the pincer and do a label reconstruction. So that's a poster. On the other side I did a THR, on the right side was pre-collapse. So I did arthroscopic consistent core decompression as well as pincer resection with the label resection. Label reconstruction, sorry. So we have good articles on arthroscopic assisted core decompression, all show very favorable results following arthroscopic assisted core decompression. This is one of my paper which is I supposed to present in ISHA, that's International Society of Arthroscopy, to be held in October this year, and I have paper on this as well. So next indication, earlier osteoarthritis hip. So this patient with the marginal osteophytosis, you can see a dent on the femoral head. So I had to do a pincer resection. Now this patient is almost 4 years now without any problems. So as you can see, early osteoarthritis hip can really avoid unnecessary total hip replacement. So external snapping syndrome, ITP syndrome, trochanteric bursitis, gluteus medius repair, all comes under peritrophantic issues, so all can be addressed arthroscopically as well. So on the third picture, we can just do a medius repair, just like we do a rotator cuff repair using the anchors. So sciatic nerve release following some strictures or adhesions around the nerve, we can do endoscopic release of the sciatic nerve as well. So hamstring repair, yes, they are another good indication, though rare. We can use the same technique. We can use put 2 anchors in the ischial tuberosity and do a hamstring release, proximal hamstring release repairs. Sorry. So what are the miscellaneous indications for hip arthroscopy? Following THR, is there a role? Yes, definitely we have a role of hip arthroscopy. Following THR, be it ileocyst, impingement, following large cup or retroverted cup, suspected infection, we can derive synovitis, impingement, yes. On the right side here, we can see that there is a residual cam, so that can be addressed arthroscopically, and metallosis and hardware or the loose body removal. And of course, if there is any arthrophytosis, we can release the tissues following that. So adhesive capsulitis, just like we have adhesive capsulitis of shoulder, do we have adhesive capsulitis hip? Yes, we have adhesive capsulitis hip as well, though rare, but we need to really look into that. So there is a good article which shows that arthroscopy has a really good role in adhesive capsulitis. This is one of my patients. As you can see, there is a global restriction of the movement which I addressed arthroscopically and release doing well. So chondral defects, anywhere you go in the conference, they are the real hot topics. So principles are same, microfracture for less than 2 cm. You can do autologous chondrocyte transplantation if the defect is more than 4 cm, and you have other techniques as well. So again, all can be addressed arthroscopically. Now there are no real contraindications. Only real contraindications for arthroscopy is advanced arthritis. That means if the joint space is less than 2 mm, don't do that. So other contraindications are AVN post-collapse, protrusio, though they are not real contraindication, but it's very difficult to do in such cases. And other conditions where it's very difficult to distract the hip, then comes the contraindications. So this is one of my paper again, a second paper we presented this year. I compared 2 techniques. Hopefully I'll present that. Now take home message: successful hip arthroscopy depends on the portal anatomy. We have to place it properly. There are a lot of portals inscribed, but basic portals are anterolateral portal and anterior portal, and stay away from the unsafe zones. And there are various indications, be it intra-articular, extra-articular, or peritrophantic. Now we have another hip 360 to be coming up this month to be held in Koppal, and anyone interested, please try. Thank you so much.
Thank you, Raghavendra. There are very few people in Karnataka doing hip arthroscopy. You can count them on your fingers. One hand.
They have got extra knowledge, especially my favorite is tubercular hip with blood gain. Tubercular hip with blood gain. He can avoid the devastating complication. Yes. Or in the other two bodies.
Thank you so much, Raghavendra.
Thank you, sir.
It's wonderful to have you here. Srinivas.
Thank you, sir, for your knowledgeable opinion on the topic. Now it's time for the felicitation of the speakers. All the speakers who are in the session, kindly come on dais. Moderators and chairperson, kindly do the felicitation.
Sir, hello.
Smile, sir.
Now, it's time for felicitation of the moderator, Dr. Anand Galagari sir, and chairpersons, Dr. Puneet Chamkeri, Dr. Prasad, Dr. Gururaj Gurgo.
ಬೆಳಿಗ್ಗೆ ಕೊಟ್ಟಿದ್ದ ಬ್ಯಾಗ್ ಇಟ್ಟಿದ್ದಲ್ಲ ಇವತ್ತು ಇಟ್ಬಿಡೋಣ ಸರ್.
There is a small announcement, especially for PGs. Just a moment, stay back. There is a banquet in Sampige Heritage Resort in the outskirts of Koppal. PGs who doesn't have one vehicle, there is a transport arrangement being made. There are cars which roads requires. You can take use of the transport facility. Please, I'll give a number. Please note down. Note down, and you can talk to them, and they will help you, guide you, and take you to and fro. You can take their help. Okay, a designated number. Okay, issue. Please note down the numbers. 97313 20332. Shall I repeat again? I will repeat again. 97313 20332. Okay, his name is Ishwar.
Vishwana number.
Jairam Travels. Okay?
Vishwana
You
number.
can tell okay, you please take help of them. They are there for you. Thank you. And please join us without fail. We have got a wonderful banquet arrangements being made. Have a good time. Thank you.
ಮತ್ತು ಬಂದ್ರ ತಡ್ರಿ ಪೇ ಮಾಡ್ತಾರೆ.
We would like to end this session by thanking you all for participating in today's event, KOPPAL HIP-360.
Your presence and engagement is greatly appreciated, and we hope you find the discussions informative and valuable. Have a great evening. Thank you all again.
ಇದು ತೆಗಿಸ್ಬಿಡ್ತೇನೆ. ಎಷ್ಟು ಜನ ಕೇಳೋ, ಇಷ್ಟು ಜನ ಮತ್ತೆ ಎಷ್ಟು ಬರ್ತಾರೆ ಕೇಳೋ. ಎಲ್ಲರೂ ಬರಲ್ಲ ರಾಘು, ಇಷ್ಟೇ ಜನ.
ಸರ್ ಇದು ಸೆಂಟ್ರಲ್ ಇರೋದು ತೆಗಿಬೇಕು. ಕೂದಲು ಅದಕ್ಕೆ ಬೆಳಿಗ್ಗೆ ಒಣಗಿದ್ವಿ, ಈಗ ಅದಕ್ಕೆ ಖುಷಿ ಆಗ್ಬಿಟ್ಟು ಆಗಲಿ ಟೆನ್ಷನ್ಗೆ ಆಗ್ಬಿಟ್ಟು ಏನು ಎಣ್ಣೆ ಹಚ್ಕೊಂಡ್ಬಿಟ್ಟಿದ್ದೆ.
ಎಣ್ಣೆ ಹಚ್ಚಿನ ಅವನ್ನೆಲ್ಲ ಇಟ್ಕೊಂಡು ಕೊಡ್ತೈತೆ. ಹಾಂ ಈಗ ಮೇಲೆ ಹಾಕೊಂಡ್ಬಿಡ್ತೀವಿ
ಹಾಕೋರಿ
ಇಷ್ಟೆಲ್ಲ ನಿಲ್ತ ನೋಡೋಣ. ಇಷ್ಟೇ ಏನೋ ಕೇಳು, ಬರ್ತಾರೆ ಅಂತ ಕೇಳು.
ಸರ್ ದಿಸ್ ಇಸ್ ಇಟ್.
ಹಿಂದೆ ಲೋಗ ಹಾಕ್ತಾರೆ, ಬರಲ್ಲ ಈಗ ಆಮೇಲೆ ಹಾಕಿ ಕೊಡಕ್ಕೆ ಬರ್ತದೆ. ನೀವು ಮುಂದೆ ಹೋಗ್ಬಿಡಿಲ್ಲ ನಾವು ಒಂದು ಲೈಟ್ ತೊಗೊಂಡ್ಬಿಡ್ತೀವಿ.
ಯಾವ್ದು ಸರ್? ಇಲ್ಲ ಸರ್, ವಿಡಿಯೋ ತಗೊಳ್ಳಿ ಫಸ್ಟು, ಆಮೇಲೆ ನಾನು ಫೋಟೋ ತೊಗೊಳ್ತೀನಿ. ಎಸ್ ಎಸ್.
ಸ್ಮೈಲ್ ಸರ್, ಸ್ಮೈಲ್.
ಓಕೆ, ಸ್ವಲ್ಪ ಚೇನ ಈ ಕಡೆ ತಗೊಳ್ಳಿ.
ರೆಡಿ ಸರ್, ರೆಡಿ ರೆಡಿ ಸರ್, ಸ್ಮೈಲ್ ಸರ್, ಹಾಗೆ ಇರಿ, ಹಾಗೆ ಇರಿ.
ಮುಂದೆ
ಓಕೆ, ಇಲ್ಲೇ ಬರ್ತಾ ಲೈಟ್ ಆಫ್ ಮಾಡ,
ಲೈಟ್
ಆಫ್ ಮಾಡ ಲೈಟ್. ನಿನಗೂ ಬೇಕು ಲೈಟ್?
ಸರ್. ಹಲೋ ಸರ್, ಇಲ್ಲಿ ನೋಡಿ. Right, sir. You will take one more smile. Okay, thank you.
ಇದನ್ನು ಕೇಳ ಸ್ಟಾಪ್ ಮಾಡಿ ಒಳ್ಳೆ ಚಲೋ ಮಾಡಿ ರೆಡಿ ಹೋಗಿ ಇವರು ಸ್ಪಾನ್ಸರ್ ಐತೆ ಇನ್ನೆಲ್ಲ ಇಡ್ತಾರೆ ಅವರು. ಎಲ್ಲ ಇಟ್ಟರೆ ಮಾತಾಡ್ತಾರೆ.
team and Finch team equal spread ಆಗಿದೆ.
ಹತ್ರ ಬರ್
ಓಕೆ.
ಅಲ್ಲ ಇವು ಎರಡರಲ್ಲಿ ಒಂದು ಅಲ್ಲಿ ಇಟ್ಟಿದ್ರಲ್ಲ ಆ ಟೈಪಲ್ಲಿ ಹಿಂಗೆ ಇಟ್ರಿ ಚೆನ್ನಾಗಿ ಬರುತ್ತೆ. ಸಾಕು ನಡೀತೈತಾ?
ಆ ಕಡೆ ಅದ್ರ ಹಿಂದ್ಗಡೆ
ಒಂದು
ಎರಡು ಲೈಟ್ ಬಂದ್ ಮಾಡಿ
ಸರ್. ಒಂದು ನಿಮಿಷ ನಾವು ಬ್ಯಾಡ ತಗೋಲ್ಲ, ನಾವು ವಿಡಿಯೋ ಮಾಡಬೇಡ
ಸರ್. ವಿಡಿಯೋ ಮಾಡಿದ್ಮೇಲೆ ನೀವು 5 ಮಿನಿಟ್ಸ್. ಹಲೋ ಸರ್, ಫಸ್ಟ್ ವಿಡಿಯೋ ಆಗುತ್ತೆ, ವಿಡಿಯೋ ಹತ್ರ ನೋಡಿ, ಆಮೇಲೆ ಫೋಟೋ ತೊಗೊತೀನಿ, ಆಮೇಲೆ ಲೈಟ್ ಆಫ್ ಮಾಡ್ತೀನಿ, ಅವ್ರ ಫೋಟೋ ವಿಡಿಯೋ ತೊಗೊಂತಾರಂತೆ. ಓಕೆನಾ? ಎಸ್ ಸರ್, ಪ್ಲೀಸ್ ಸರ್, ಸ್ಮೈಲ್.
ಹಾಗೆ ಇರಿ.
ಯಾ ಪ್ಲೀಸ್. 7 ಗಂಟೆ ಆಗಿದೆ, ಎನರ್ಜಿ ಡೌನು. ಬ್ಯಾಂಕೆಟ್ ಏನೋ ಅರೇಂಜ್ ಮಾಡಿದಾರಂತೆ ಸರ್, ಸೊ ಪ್ಲೀಸ್ ಎಲ್ಲರೂ ಅಟೆಂಡ್ ಆಗಿ.
ಒಂದು ನಿಮಿಷ
ವೇಟ್ ಫಾರ್ ಅ ಮೂಮೆಂಟ್.
ಬಂದ್ ಮಾಡ
ವೇಟ್
ನಿಂಗೆ ಬೇಕಾ?
ವೇಟ್ ಸ್ಮೈಲ್ ಸರ್. ವೇಟ್ ಸರ್, ಒನ್ ಮೋರ್, ವಿ ವಿಲ್ ಟೇಕ್ ಒನ್ ಮೋರ್. ಸ್ಮೈಲ್. ಲೈಟ್ ಆಫ್ ಆನ್. ಎಸ್ ಸರ್, ಎಸ್ ಸರ್. ಹಾಂ ತೊಗೊಳ್ಳಿ. ಓಕೆ ಸರ್.
ಆರಾಮ್ ಆರಾಮ್
ಹಾಲಿಸ್ಟಿಕ್ ಪೇನ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್.
ಹಾಂ ಸರ್.
ಸರ್ ಅದಕ್ಕೋಸ್ಕರ ನಿಮ್ಮ ಲೈಟನ್ನು ಆಫ್ ಮಾಡಿಸಿದ್ದಾರೆ. ಹಾಲಿಸ್ಟಿಕ್ ಪೇನ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ವಿತ್
ಓಕೆನಾ?
ಓಕೆ ಸರ್.
ಓಕೆನಾ?
ಓಕೆ ಸರ್.